Chandan Jha sir and Dr. Mitali Dhandekar to the stage. And the speaker for this session is Dr. Gaurav Agrawal. Sir. ये तो आ ही नहीं रहा है.
Good afternoon, everyone. It's a great honor to set the ball rolling for what today is a momentous day for the small endocrine community of the state. And what better person than this great jewel, Dr. Gaurav Agrawal, to start the session. A very dear friend. Once upon a time, I was a resident with him, a very fun person, and that same resident is now heading the parent department of endocrine surgery at SGPGI. That same resident is now the president of the endocrine surgeons of India. And amongst his many achievements is the fact that he's been one of the leaders unraveling the story of primary hyperpara in India. I am blessed to be his friend, not only for the part of reflected glory, but for the sheer genuineness of his warmth and love that he has for his friends. Sharing the responsibility today with me is Chandan Jha, who has trained under Dr. Gaurav Agarwal, and Dr. Mitali Lal, who is a head and neck surgeon here, whom all of you must be knowing, and does exceptional work on parathyroid and thyroid surgery. So Dr. Chandan, will you take it forward from here?
Yeah. Thank you, the organizers, for making this happen. It is a proud moment and emotional moment for me as well, because Gaurav sir has been my teacher, and we have always looked up to him for help in whatever matter we wanted, and he has always been there. Extremely good teacher, and extremely good orator, extremely good breast surgeon, and also an endocrine surgeon. Many would not know probably that he is actually the first trained endocrine surgeon in this country. He was the first person to get PDCC from SGPGI, and then he further took advanced training in endocrine surgery from Australia. His profile speaks for himself. He doesn't need any introduction. With a H index of 50, more than 10,000 citations. He is among the leading researchers, not in India, just, in fact, he is one of the leading researchers on the globe. So with these words, I would hand over the mic to Dr. Mitali if you want to say something, and then Gaurav sir, we can listen to him now.
I think let's not delay it any further, please. Go ahead.
Well, thank you very much. First of all, thank you, Dr. Santosh and endocrinologist of Bihar for honoring me by inviting me to the inaugural meeting of the Bihar Endocrine Society. Well, my introduction, to my mind, the best part of my introduction is that I have great friends here in Patna, in Dr. Anil Singh, Dr. Santosh Singh, and great students like Dr. Chandan Jha. And that gives me immense pleasure to be back to this friendly city, people with, large hearts and warmth, and I've always enjoyed coming back to Patna. And especially a privilege for me to be asked to do the first talk in this inaugural conference. Well, I wish this inaugural conference of Bihar Endocrine Society is the harbinger for a very successful society which succeeds in not just giving platforms for scientific exchanges, but also to bring up the standards of endocrine practice in our part of the country, which I'm sure all of you would agree is in the best interest of our society and all of us who have any interest in endocrinology, including us endocrine surgeons. So if I may have the slides. Is there a presenter here which I can use? Okay. So Dr. Santosh Singh asked me to talk about the surgeon's perspective of management of primary hyperparathyroidism. I'm talking to an audience primarily of endocrinologists, so I think half my job is done, because you are all very well aware of how primary hyperparathyroidism is managed, and so I'll try to stick to what surgical Thank you. So I'll certainly try to provide the surgeon's perspective for management of primary hyperparathyroidism. Primary hyperparathyroidism is a common disorder, unfortunately still underdiagnosed in our country. It is characterized by intrinsic autonomous excessive PTH secretion, which occurs due to a single or multiple pathological glands, which are mostly adenomas, but in around about 10% these may be hyperplastic glands and rarely malignant tumors. And the classical primary hyperparathyroidism is diagnosed based on presence of hypercalcemia along with high serum PTH levels. This disease has varied manifestations. In majority of rest of the world, the developed world, the disease is diagnosed as asymptomatic hypercalcemia. However, in contrast, in our country, still majority of our patients are overtly symptomatic, and some even are crippled because of the disease. So my interest in parathyroid surgery started as a fellow in endocrine surgery, and then at that time, 30 years ago, 25 years ago, the disease was indeed very different compared to what we treat today. Still, a large proportion of patients continue to be overtly symptomatic, as we published 25 years ago. At that stage, we had patients coming with, had crippling parathyroid bone disease. We also coined a few very new terms like a syndrome of disappearing bones. This was mandated, or we had to do this because there were patients who had no bones visible on X-rays. That's the extreme kind of osteoporosis these patients had. And at that stage, in those days, the PTH levels used to be sky high, the calcium would be very high too, but not necessarily causing hypercalcemic crisis. The picture has changed a little bit, but still majority of our patients are symptomatic. The classical symptoms of primary hyperparathyroidism, as I'm sure all of you would remember from the textbooks, this is a disease of bones, stones, moans, abdominal groans and psychic overtones. Unfortunately, because we still are not diagnosing these patients early enough, we continue to see patients with fractures and renal calculi with high calcium and PTH levels. Then coming to why I have been called to discuss this disease today. Why should the surgeon's perspective be relevant? It's because primary hyperparathyroidism is a surgical disease. It is surgery which is curative for this disease, and it's the most common cause for outpatient hypercalcemia. Because of misdiagnosis and delayed diagnosis, patients often have progressive end organ damage, osteoporosis, fractures, renal stones, even renal failure. And the outcome of the disease is quite to a large extent dependent on the expertise of the surgeon who's treating it. In expert hands, it is eminently curable, but it is only possible when we recognize it timely and treat it appropriately. This is a disease with a wide spectrum of presentation. On one hand, we have asymptomatic patients with or minimally symptomatic patients with hypercalcemia and hyperparathyroidism. On the other extreme of this spectrum is patients with crippling skeletal disease and renal failure. Dr. Santosh specifically asked me to also talk about some of the unusual presentations. So I would be discussing normocalcemic and normohormonal hyperparathyroidism. We know that a certain proportion of all patients with primary hyperparathyroidism have a familial disease or a genetic form of disease. And then I would also like to discuss a little bit about the masked hyperparathyroidism, which we think is much more common in our part of the country because of vitamin D deficiency. This disease, of course, has numerous and varied clinical manifestations, but the skeletal radiology is quite interesting. I'm sure you all remember the pictures of osteitis fibrosa cystica with salt and pepper skull and subperiosteal resorption in the hands and brown tumors. At times, patients may have jaw tumors. Not all jaw tumors are because of a jaw tumor, hyperparathyroidism jaw tumor syndrome, and majority of patients have an adenoma, a benign tumor, some of which are large enough to be palpable. So the disease is diagnosed by documenting high serum calcium, total or ionized, and it is important that we correct the calcium levels for the albumin, and then we, as a routine, we do 3 consecutive days serum calcium levels, because one level alone may miss the diagnosis. And one single high calcium levels should not be taken as a diagnostic value. It must be reconfirmed. While doing this, while documenting hyperparathyroidism and hypercalcemia, we need to exclude familial hypercalciuric hypercalcemia and the vitamin D deficiency and renal insufficiency in these patients, and the various drugs which may cause interference with these. So what is important to re-emphasize is the diagnosis of primary hyperparathyroidism is essentially biochemical. It is not sufficiently diagnosed based on clinical means and not on imaging means too. One common complexity that we face is often some physicians and some surgeons believe that unless we have been able to document or demonstrate a pathological gland on imaging, we do not have a diagnosis. This is certainly not correct. I would repeat myself that the diagnosis is biochemical and localization is secondary. When we are evaluating a patient with suspected primary hyperparathyroidism, we would, as I said earlier, use corrected total serum calcium or ionized calcium along with intact PTH levels. If we have high calcium and high PTH in a paired sample, the diagnosis is quite well established. Majority of patients would have low normal or subnormal phosphorus levels and normal creatinine levels. Vitamin D, 25-hydroxy vitamin D levels are often subnormal, but then majority of patients now, before they are referred for surgery, they would have received vitamin D supplements, and 24-hour urinary calcium is also useful. We assess the skeletal, metabolic and densitometric features by doing DEXA and serum alkaline phosphatase. We also assess for the end organ damage, other end organ damage, like evaluating for renal function as well as for ectopic calcifications and nephrocalcinosis. So the evaluation is essentially aimed at confirming the biochemical diagnosis while excluding the mimics of this disease and also identifying the target organ involvements. Now coming to what are the indications for surgery. Pretty much all patients with primary hyperparathyroidism today have some or the other indication for surgery. The exceptions are far and few. Extremely high surgical risk, perhaps with low or minimally symptomatic disease and with no end organ damage evidence. Those are the few patients who can be observed or put on medical management, but almost all of the rest of the primary hyperparathyroidism patients would be benefiting from parathyroidectomy or parathyroid surgery. So in patients who do not have symptoms, if they are younger than 50 years age, they are expected to undergo parathyroid surgery, and all patients with symptomatic disease must have a surgical referral and consideration for parathyroidectomy. In patients who are asymptomatic and have at least one of these criteria, like serum calcium which is more than 1 milligram per deciliter above the upper normal limit, or BMD by DEXA of a T-score of less than 0.25, vertebral fracture risk as assessed by X-ray or CT or MRI, or presence of a vertebral fracture, deranged EGFR, and complete 24-hour urinary calcium of more than 250 milligram per day for women and more than 300 gram for men, and presence of nephrocalcinosis of nephrolithiasis demonstrated on imaging. If there are no medical contraindications, then asymptomatic patients in whom medical supervision is not either desired or not possible, they should also be subjected to parathyroidectomy. And asymptomatic patients who desire not to be on a very stringent lifelong follow-up or frequent evaluations can be considered for parathyroidectomy. Now, as I said earlier, localizing a diseased parathyroid gland before surgery is something which we desire only for assisting appropriate or considering appropriate surgical procedure. It is not a diagnostic test. It is a test which aids the surgeons decide the most appropriate surgical approach for a patient. We often use a combination of two localization techniques, one anatomical, the other functional. And the first line set of localization studies used are a high resolution ultrasonography, and we believe surgeons who have focused training in ultrasonography of the neck, thyroid, parathyroid, they do a better job than a general radiologist, and combined with the functional imaging like a MEB scan, technetium 99M MEB scanning. However, very often we are also using 4D CT, which has the fourth dimension is the time, and a choline PET CT, which mostly we reserve for patients who have persistent recurrent hyperparathyroidism. But even at the cost of repetition, I would like to remind everyone that parathyroid imaging is only done to guide the surgical approach, and it is not the diagnostic test for the disease itself. The principles or the logic that we use while doing parathyroid imaging is that imaging has no utility in confirming or excluding the diagnosis of primary hyperparathyroidism. Patients where we do not find a pathological gland or disease gland on this imaging or localization techniques, they still are candidates for parathyroid surgery. The difference is that those patients would need a bilateral neck exploration in parathyroidectomy. However, patients where we are able to localize a single gland, pathological gland on imaging, they can undergo a minimally invasive or a focused parathyroidectomy. Imaging is performed for operative planning, and the accuracy of this imaging, parathyroid localization, is much worse, much lesser, much inferior in patients who have multi-gland disease. There are various combinations used, but as I said, commonly we use a combination of high resolution ultrasonography and MEB. Combinedly, they have a very good sensitivity and specificity at localizing a single gland disease. However, when it comes to multi-gland disease, this accuracy is not really so great. Before operating a patient, what needs to be advised to the patients is the majority of patients should be advised to continue the usual daily intake of calcium of 1000 to 1200 milligram. Patients who are vitamin D deficient can be safely given vitamin D supplements before surgery, And preoperative voice localization is appropriate because if you are operating in the region of recurrent laryngeal nerve, there is a possibility of causing iatrogenic voice change. So it is important to document normal voice vocal cord function before that. There are a few patients who would present and who would be diagnosed because of hypercalcemic crisis. Such patients need appropriate medical management in form of forced saline diuresis, thiazide diuretics, at times other means like calcimimetics and calcitonin, and then to be followed by an emergent or semi-emergent parathyroidectomy. The strategy that guides us while operating patient with primary hyperparathyroidism is that parathyroidectomy is the only definitive treatment for this disease, and the preoperative localization in form of the first line evaluation of ultrasound and NIBI, that helps us decide whether a patient is a candidate for more focused or minimally invasive parathyroid surgery. For all others, where either the parathyroid localization has failed, both are negative or they are discordant, then we would have to undertake a bilateral exploration of the neck and find out the diseased parathyroid gland, remove it. If this is multiglandular, then appropriate multiglandular excision would be required. If, however, we find concordant imaging on this imaging localization technique, then we can undertake a focused exploration with or without intraoperative PTH estimations. So parathyroidectomy, the parathyroid surgery outcomes are indeed determined by the training and expertise of the surgeon. In hands of experts, parathyroid surgeons, the cure rates certainly exceed 95%. However, this is not universally so. So please do select your parathyroid surgeons very well. So the two distinct surgical approaches to parathyroid surgery are focused parathyroidectomy and bilateral neck exploration. The difference lies in patients where we know that which location the diseased gland is located. We straight away go to that location and not explore rest of the neck, so that we can reduce the amount of exploration or dissection required, thus reducing the potential morbidity, scarring, and so many other complications. However, not all patients are candidates for focused parathyroidectomy. There are still numerous indications for bilateral neck exploration. These include patients who have syndromic disease, secondary hyperparathyroidism, negative imaging, multi-gland disease, failure to localize a gland intraoperatively, which has been localized earlier, and failure for the intraoperative PTH to drop, coexisting thyroid disease requiring thyroidectomy. These are the indications for bilateral neck exploration. The surgical approach is guided by this thought that we try to do focused parathyroidectomy when appropriate. However, we should not shy away from exploring the whole of the neck when it is required. Minimally invasive parathyroidectomy has various forms or various types. The commonest performed is what we call as open mini incision lateral parathyroidectomy. It can also be video assisted parathyroidectomy or endoscopic parathyroidectomy, but now more and more people are also moving towards robotic parathyroidectomy, though it can be discussed that there are very few real benefits of robotic parathyroidectomy over the conventional parathyroidectomy. Whether focused or bilateral, as I have discussed earlier, is based on concordance on imaging. Surgical anatomy and the embryological basis of anatomy helps us surgeons find a parathyroid gland in the neck. It's not only the anatomical location. In about 15% cases, or about 15% of all parathyroid glands are not found in their utopic or usual location. They migrate to different locations, and usually they follow the embryological path. And so we often remind ourselves that parathyroid surgery is an embryological surgery. There are numerous adjuncts that we use to increase the success rate of parathyroidectomy. The commonest one is the intraoperative PTH monitoring. It is made possible because of very short half-life of the PTH, and what we do is during parathyroid surgery we take numerous blood samples. One sample we take before induction of anesthesia, the next one is before excision of the parathyroid gland, and then 5, 10 and 15 minutes later we do sampling, and if in case the 10 minutes post excision sample shows more than 50% fall in the PTH levels, that is highly predictive of cure of parathyroid hyperparathyroidism. We also use certain other adjuncts like frozen section histology and near infrared fluorescence and intraoperative neuromonitoring. IOPTH, as I said, is useful to a large extent in confirming cure. However, it is not a replacement for the expertise of a surgeon. It only helps in certain cases, not always, and it has numerous shortcomings too. So we can't be overly dependent on it. Following parathyroidectomy, usually patients, those who have no symptomatic hypocalcemia, they require just the usual daily calcium intake and vitamin D supplements. However, roughly about 20% to 25% of our patients today, they still have symptomatic hypocalcemia, and certain patients have hungry bone syndrome, and they would require intravenous calcium and calcitriol. And then appropriate follow-up is required earliest at 6 months. We reassess them for calcium to normalize, and also monitor for end organ damage or recovery. This is one typical case with a 33-year-old lady with bone pains and recurrent renal calculi with high calcium levels and PTH levels, and the gland was well localized both on ultrasonography and a MEB scan, and so the patient was subjected to a focused right inferior parathyroidectomy that you see here, and it was a typical parathyroid adenoma. Intraoperative PTH levels, they exhibited curative fall, and indeed the patient was cured. The next patient is an example of a familial form. This patient, 48-year female with recurrent renal calculi and a strong family history of syndromic disease. She had hypercalcemia, hyperparathyroidism, also had high prolactin levels and prolactinoma, and this patient had multi-gland disease, so underwent a 3.5 gland excision with cervical thymectomy, and of course she had multiple adenomas. There are about 10 to 15% patients who have familial form of various diseases of hyperparathyroidism, usually MEN1 or MEN2A, HPT or jaw tumor syndrome, or familial isolated hyperparathyroidism. These familial forms are due to various gene mutations, and these patients require specific consideration while being operated. Patients with MEN1 are treated with subtotal parathyroidectomy. However, patients with MEN2A and HPT jaw tumor syndrome, they can be treated well with selective parathyroidectomy. Word about normocalcemic and normohormonal parathyroidism, hyperparathyroidism. If patients have the classical hyperparathyroidism is the picture is the calcium and PTH both are high. However, in normocalcemic, the calcium levels may be normal or high normal with high PTH. In contrast, normohormonal would have high calcium but normal or high normal PTH levels. These are mostly considered to be diseases caught at certain time in the natural history of the disease. It is widely recognized that normocalcemic hyperparathyroidism is relatively less aggressive and is treated with there are various hypotheses for the pathophysiology. There is a subclinical phase 1 of which is normocalcemic, and then subsequently the patient would be expected to have hypercalcemia too. So normohormonal hyperparathyroidism is a relatively new entity. Again, it has both of these entities. There is no data regarding optimal treatment strategy, and the guideline based on the expert recommendation is what guides us. The management options are surgery or medical management or close observation. The surgical management here, we often find multi-gland disease in these patients with decreased sensitivity of localization studies or small adenomas. And so the cure rates are also somewhat lower in normocalcemic or normohormonal. Masked hyperparathyroidism is a problem which we often face in our patients because of vitamin D deficiency. These are patients who have classical hyperparathyroidism, but the calcium levels do not rise or are not as elevated because of the concurrent hypovitaminosis D. So these patients, if they are subjected to or they are supplemented with vitamin D and serially followed, you would eventually find that some of them would have hypercalcemia and hyperparathyroidism. And that helps us establish the diagnosis and differentiate from mild secondary hyperparathyroidism due to. And this is a child recently operated who was 12 years with bilateral limb pain, and we found a mediastinal parathyroid adenoma, and this patient underwent a video-assisted thoracoscopic parathyroidectomy for the ectopic mediastinal parathyroid tumor, and indeed the intraoperative PTH levels fall, and this patient is cured. Parathyroid carcinoma fortunately is not a very common entity. Roughly about 2% of all primary hyperparathyroidism patients have carcinomas. What is important is to recognize this entity preoperatively or intraoperatively, and then the patients should undergo an en bloc resection of the parathyroid tumor with the thyroid lobe and with appropriate lymph nodal dissection. Surgical cure is established by establishing or demonstrating normal calcium hemostasis at least for 6 months. What determines surgical cure is correct biochemical diagnosis, understanding the disease phenotype, appropriate surgical treatment, and judicious use of intraoperative aids, and of course the surgeon's experience. In hands of high volume parathyroid surgeons, the cure rates exceed 95%. A certain proportion of patients, for hopefully less than 5%, would have persistent or recurrent hyperparathyroidism. These patients need appropriate evaluation and judicious treatment. Not all patients need reoperation, fortunately. So in summary, the surgeon's perspective of primary hyperparathyroidism is based on robust diagnosis of the disease, based on clinical, biochemical and imaging technique, but the diagnosis is established primarily on biochemistry. Parathyroid imaging has a role in determining the appropriate surgical approach. Patients who undergo parathyroidectomy in hands of experienced parathyroid surgeons have high cure rates, and often we try to, parathyroid surgeons would subject patients to minimally invasive or focused parathyroidectomy with high cure rates. Thank you very much, and if there are any questions, I'll be very happy to answer them.
So thank you, sir. It was actually a rule book for people who practice surgery of the parathyroid. So very elaborate, and you covered all the right points. If I had to summarize it, it is not uncommon for us in this part of the world to see symptomatic parathyroid diseases. Commonly who come to us with swellings in the jaw most of the times, and like you rightly or aptly named it, the syndrome of the disappearing bones. It is ideally, the main presentation of patients who sort of present in this part of the world. Also, an important point that you made is that asymptomatic hyperparathyroidism also needs to be seen from a surgical perspective, particularly in the younger age group. Just to conclude, parathyroid disease management is truly a multidisciplinary approach. It involves equal contribution from the surgeon, from the endocrinologist, from the laboratory services, from radiation, from the radiologist, from nuclear medicine specialist, and most importantly, the post-operative management. It is one of the surgeries which give the most dramatic results from a patient's perspective, and also maximum peace from the surgeon's perspective as well when you see a drop in the serum parathyroid hormone. I'm sure you would agree with it, sir.
Certainly, yes. This is that tiny tumor which often eludes the surgeon. And by the way, these overtly symptomatic advanced cases, they pose a lesser surgical challenge compared to the asymptomatic or minimally symptomatic, very early stage disease. But then the expertise of the surgeon is in locating and finding those tiny sub-centimeter tumors too, and it's not so difficult. Well, actually there's no predilection for inferior glands. Perhaps the reason why imaging diagnosis is that of inferior gland more often than the superior one is because even the superior glands, because of the weight and the deglutational draw, they migrate inferiorly to lie close to the inferior pole of the thyroid gland. So it's a misconception that there is a predilection for inferior gland.
Any other question?
So we often talk about migrated or descended superior parathyroid gland.
Thank you, Dr. Gaurav.
Thank you.
It was an excellent presentation, and we are all blessed to have you here. I'll hand over the mic to the person in charge. Thank you.
Yeah. I will request the speakers and the chairpersons to come to the checkers point area for felicitation. We'll be starting off with our inauguration ceremony. I would like to invite our chief guest, Dr. D.K. Srivastav sir, on the stage. Our guest of honor, Dr. H.K. Singh sir.
कोई नहीं, कर देते हैं, तुरंत कर देते हैं सर, तुरंत कर देते हैं सर।
Dr. Kaushik Pandit, sir, President, Endocrine Society of India. Dr. KVS Harikumar, sir, Secretary, Endocrine Society of India. Dr. Santosh Kumar Singh, sir, President, ESI Bihar Chapter. And Dr. Ved Prakash, sir, Secretary, ESI Bihar Chapter.
इधर है वेद। It's my pleasure and honor to call Jargar sir over the stage. Sir, Jargar sir.
Now I would like to invite Dr. Santosh Kumar Singh sir for giving the welcome address. Okay. Okay, now we'll. ठीक है. Okay. I will request to please light the lamp.
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीमभयदां जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थिता वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदा
Now I would like to invite Dr. Santosh Kumar Singh sir to give the welcome address.
Dear all, a warm welcome on behalf of the organizing committee to the inaugural annual conference of Endocrine Society of India, Bihar chapter. I hope with a positivity that this would be a fruitful conference, and in advance I ask for apology for any of the shortcomings we may have. So thank you for coming. I am really obliged and I am indebted. I am not taking the names. From the look you can guess to the persons I am seeing. So all of you, I am just grateful. Thank you.
Now I would like to invite Dr. KVS Harikumar sir for the address.
Good afternoon, everybody, and greetings to the Bihar Endocrine team for the excellent show. And this is the inaugural first meeting of the state body, and I am sure this will be the first, and then it will progress very soon with the way the team is working. And we from the Endocrine Society of India are witness to it, because as a secretary I am here, our president is here, president-elect is there, vice president is there. So you can see the amount of participation which we want this society to be here. Okay. And I wish all the best to the organizers. Thank you, sir.
I would like to invite Dr. Kaushik Pandit sir, President ESI National.
Respected dignitaries on the dais and off the dais, dear friends. Endocrine Society of India is the only official body of endocrinologists in the country, and Endocrine Society of India has spread its wings all throughout this country. Today, Endocrine Society of India is very proud to see that the first inaugural program is coming in a state which had not had it earlier. This only substantiates the fact that the endocrine care at this part of the country, which had experienced a bit of a vacuum, will no longer be there under the able guidance of many people, many endocrinologists in the state. I am very proud and would like to congratulate the Bihar Endocrine chapter to have done their first endocrine meeting. Thank you very much.
Thank you, sir. Now I would like to invite Dr. H.K. Singh sir, our guest of honor.
Good evening to everybody. Actually, Endocrine Society of India Bihar chapter was first time opened at Ahmedabad Civil Hospital conference on molecular endocrinology. And Dr. J.K. Agrawal asked me to become a life member. Then the Shyam from Osmania University, he told, no, ask him to branch. So 5 members branch minimum requirement. I paid 5 members to the society and created society. And since 92 till 2000 of my superannuation, every year Endocrine Society meet was done. Dr. S. Kumar, Dr. J.K. Agrawal, Dr. Shyam Sundar, Dr. Jargar, उस समय यंग चैप थे, माथे पर बाल था उस समय बाल अभी थे everybody came here. Not once, several times. J.K. Agrawal and S. Kumar, they were the pet umpire speaker every time. So, for this, I wish, but the younger generation came and dismissed the previous one. And then they started again new chapter. So, this is not first time. It is 9th or 10th time, actually. Okay, with this I wish the successful, because I opened the endocrinology department also and run it till date. Actually, I am 86 at present. So, with this. I wish you success.
Thank you, sir. Now I would like to invite Dr. D.K. Srivastava, sir, our chief guest.
Good afternoon, ladies and gentlemen. It's a matter of great pleasure for me to be here with all of you, the dignitaries on the dais, the National President, Dr. Kaushik, the National Secretary, the Dr. H.K. Singh, one of my younger colleagues, Dr. S.K. Singh, Dr. Prakash, and all the dignitaries of the dais, the esteemed endocrinologists and physicians of Patna. Indeed, it's a very august occasion to be here in the annual conference, first annual conference of the Endocrinological Society of India, Bihar chapter. And we hope you all will benefit a lot from the ongoing scientific deliberations that would follow, and I hope with these few words, I wish the conference a great success. Thank you.
Thank you, sir. Now I would like to invite our dear guest, Dr. A.H. Zagar, sir, one of the senior most endocrinologists of India, for his guidance.
It's quite gratifying in my personal capacity to be here today. When I applied for my endocrinology DM, there used to be only one seat in the whole country you could compete for at PGH Chandigarh. And I went to my director, Professor B.K. Anand had retired as the Dean of All Institute of Medical Sciences, and he was appointed as Director SKIMS. His first response was, before signing, I said, what is there in endocrinology? I'm going to make you a cardiologist. And my appointment actually was first as a lecturer in cardiology. So there's nothing in that. I said, no, sir, I want to do endocrinology. He said, you will have to resign from your current post from SKIMS. Suja, you won't believe it. I was married, I had just a kid, and I resigned. And I had to fill in a form for DM endocrinology for a seat. There was one in the country. So sometimes, you take a chance with life. Huh? And I never regretted that. Always delighted. So, one day, during a meeting, I was telling Pandit, there was an Indo-US endocrine meet organized by All Institute of Medical Sciences, Medical Council of India and British Medical Council, Professor M.M.S. Ahuja, and Professor Joplin was representing Britain. He was a chief of endocrinology at Hammersmith Hospital. And two things happened on that day. One, I told Professor Ahuja, why don't you start? There was a 15 days in-house program, but there was no postdoctoral program in AIIMS. I said, why don't you, sir, start a DM here? He said, why don't you go and talk to the director AIIMS? There was a lady who was a radiologist who was a director. She says that what is left in endocrinology? Why do we need a separate specialty? Physicians do treat diabetes. The Professor Ahuja, 1984. And second thing was that Joplin offered me a job in England. That is another good thing. I did not join him because I always enjoyed being in my country and doing what I did. Thank you so much, Santosh, for asking me to be here today. And some of the very senior colleagues, friends with whom I have exchanged notes over a period of decades. And looking at the agenda today, I see not only some of the best topics getting discussed, but probably the very best from the country chosen to do so. Pleasure being here and honored. Thank you so much.
Thank you, sir. Now I would like to invite Dr. Prakash, sir, Secretary ESI Bihar Chapter, for the vote of thanks.
At the outset, I would like to, first of all, I would like to welcome you all, the speakers, chairpersons, delegates, and the friends from the media and the other colleagues who present here. It's really a great honor for me to propose vote of thanks for this inaugural annual conference of the Endocrine Society of India Bihar chapter. And first of all, I would like to thank our chief guest, Professor D.K. Srivastava sir, for his presence here and taking time and pain to be present here. And after that, I would like to thank Professor H.K. Singh sir, who is one of the senior most member of the Endocrine Society of India and also the senior most member of the Endocrine Society of India Bihar chapter. Thank you, sir. And after that, I would like to thank Professor Kaushik Pandit sir, who is the President of the Endocrine Society of India, for taking their time and pain to travel from Kolkata to Patna. And thank you, Professor KVS and Dr. KVS Harikumar sir, who is the Secretary of the Endocrine Society of India, to present here on this inaugural annual conference. And a special thanks to the senior most people like H. Jargar sir for their presence here. And after that, I would like to thank all the speakers from the different part of the country who is going to deliver their talk and going to benefit us with their expertise in the field. And all the chairpersons who are from the different parts of the Bihar who present here, I would like to thank them all. And no conference will be a success without the presence of the delegates. So I would like to thank all the delegates for the presence here. And after that, I would like to thank our sponsor, the various pharma companies who participated very generously in the organizing this conference. And after that, I would like to thank the hotel people, the people from the print and media, and the people who present technical team for this conference. With this, I would like to thank you all, and with this, I conclude my talk.
Thank you, sir. Now I would request you all to stand up for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Now we'll take a short tea break and reconvene at 3:45 p.m. The tea break is in the Utsav hall.
We need to finish early and we will start our next talk from 3:45 p.m. Thank you.
सांगे पकड़ा डंडे पर उल्टा लगा दिया और उसी तक लेता उसको ठीक कर देते पहले खटा खटा इसको ये इसके हला एकदम चला दीजिए ये कर दीजिए टेबल यही तनी तनी से शिकायत चल जाएगा सही बात है थोड़ा दिन में काहे काम खराब चल पानी चलो ठीक थोड़ा आगे टेबल कर उसने भर टेबल थोड़ा पीछे कर लो उसने का आदमी जगह थोड़ा पीछे कर लो एक एक सटा दो हाँ ठीक
के नाम चढ़ा हुआ होगा, समझ गए? हाँ, अरे हो गया हो, तू देहू नहीं हिलाया, देहू नहीं हिलाया, सुनो यहाँ एक स्पॉट भी हो रहा है, स्पॉट पर भी हाथों से लीकेज हो रहा है, हल्का फुल्का बैग है, समझे ना? हैंड बैग वो नहीं होता है, वही है। खाना रात में है, खाने में आ जाना। क्या बोले? रहेगा तो मिलेगा, खत्म हो जाएगा तो नहीं मिलेगा।
So, dear all, it's 3 minutes to go. थोड़ा सा जल्दी कर लेना है. We can have our snacks while sitting too. So kind request.
I would request everybody to settle down. We will be starting off with the next session. For the next session, I would like to invite our chairpersons, Dr. Rajesh Tiwari sir, Dr. Rajesh Kumar sir, and Dr. Sajjad Hassan sir.
Very good afternoon, everybody. I am thankful to the organizers for giving me an opportunity to attend this CME, the first annual conference. Without wasting much time, I would like to invite the speaker, sir, Professor Hari Kumar, sir, to give a talk. The topic which is very interesting to physicians as well as surgeons, especially urologists. We share a common platform.
Absolutely. Thank you, sir, for the invite and greetings to all. Next 20-25 minutes, I shall be speaking about one of the most, I would say, interesting topic, but maybe neglected, maybe not much focused in the current world. Sexual dysfunction in diabetes. I'll cover both the genders in this. Okay. I'll start with one of the historical quote and I'll end with Bollywood. Okay. So man survives earthquakes, epidemics, and a lot of all problems, but very difficult to tolerate a bedroom tragedy. This was told many centuries back. Okay. So I'll cover under the following headings: introduction, pathophysiology, male and female sexual dysfunction, some of the clinical dilemmas which you would be seeing in day-to-day practice, and some recent advances in this field, which they are. Physiology of sexual responses by and large is the same in both genders. Okay, it is important to understand that you require some amount of arousal, some amount of the genital function, and then orgasm and ejaculation. These phases are the same in both the genders, slight difference being the time taken in each phase, the refractory period, and then the subsequent stimulation. That is the only difference between these two genders, but otherwise most of the times it is the same between both males and females. And if you look at the prevalence of sexual dysfunction, almost if you look at onto your right side bars, as age advances, obviously the sexual dysfunction increases. Okay. So almost close to 70% beyond 60 and 70 years age group, you have problems with the sexual dysfunction. So that is again important to understand. And if you look at what are the things which are actually matter, it is very easy for a male sexuality, quite easy, controllable, but for a female sexuality there are a lot of issues as far as the controls are concerned. So why this is important is because of this factor, because you have lot of other things which determine the sexual function. It is not only the hormones, it is your biological, it is your psychological, it is your cultural, it is your social. So many factors are there which actually make a sexual function appropriate, or maybe the person is inability to do inappropriate. So something like that. So important to understand that lot of dimensions exist in this. For next 10 minutes we will concentrate on the male sexual dysfunction and then we will move to female subsequently. It is now changed as sexual dysfunction as the topic. Most of us have read only erectile dysfunction. Erectile dysfunction is a component of sexual dysfunction. It is not the only dysfunction. Okay. Obviously that is the most common which people would come with. You have ejaculatory dysfunction, you have orgasmic dysfunction, and you have low sexual desire disorder, the hypoactive sexual desire disorder. So you have different functions which exist, different disorders which exist. So you need to classify because the treatments are different between different disorders. Somewhat similar system also exists for the female sexual dysfunction as well. You have the female sexual dysfunction functional index score. It's a more of a paper which you give to any lady. You just tick, and depending on what they have marked, the number of scores, you can identify where the disorder is. So it is more or less, I would say, more comfortable identifying the disease and more practical in labeling what is the underlying disease. That is also important. After knowing what are the disorders, whatever are the types, what we need to look is approach to a patient. Conventional approach is this, that is, you look at A1C, you look at his maybe lipids, you look at his blood pressure, and then you write your prescription and then send. But unfortunately, this is not going to solve the problem. You need a bit more go into deep and ask something more with the patient about what actually you want to identify. Most of the patients don't come out with the problems. So if they don't come out, you can actually introduce the topic to the patient. You can just say that my previous one who just walked out when you entered is the one who actually had this problem. Do you have anything, something like that? Or maybe somebody else, you need to just give an incident so that develop that rapport with the patient and then bring that information out so that you can actually help the patient overcome some of these problems. Detailed history is obviously important, looking at smoking, cardiovascular disease, the spectrum of what diabetes, what are the complications, the lower urinary tract symptoms, BPH, neurological disorders, all those things are important whenever you are looking at identifying where is the problem, because if you have problem in any of these, you have sexual dysfunction. So important to address that. Without correcting them, you are unlikely to have any benefit. You need to do some clinical examination, focused, conventional, normal, general physical examination. Some of the specific examinations, you may have to look at the importance about the sphincter tones, important about the metabolic control, important about the neurological examination. All those things will help you to identify the underlying neuropathies and other things. Specialized testing is generally not required in most of the patients whom we see. May be required in some patients who actually you have started therapies but you are not improving, or maybe you require to document somebody in a medical legal cases, and these are the patients whom you may have to do actually a specialized testing. But otherwise, more or less these are restricted in a given subset of patients, otherwise you do not require to do a specialized testing in most of the patients with the sexual dysfunction. Management is simple in the sense because you need to do your lifestyle, you need to do your disease control, you need to do all other chronic management control, comorbidity management, and obviously for males the first and the only available option is the phosphodiesterase 5 inhibitors. You have different ones, I will come to that, and you have secondary options if they are not able to reach the objective with that. Okay. So, conventional available sildenafil and tadalafil are the ones which are mostly used depending on whatever dosages. Either you use on demand or you use a daily prescription. Tadalafil is one which gives you the option of having a daily prescription, not on demand, so that you don't actually have the stress of the tablet performing. So, if you have a planned act half an hour later and you put a tablet now, that keeps running in your mind whether it is going to work, not work. So, tadalafil takes away that stress, possibly will give you, and there is enough management for the available erectile dysfunction. Non-responders, you can use the injection therapy, intraurethral, intracavernosal, not much of data, not much of response. Again, no response, you can use the combination of both first generation and second generation both together, and then last is the penile implant. So, this is the nutshell as far as the sexual dysfunction, erectile dysfunction in a male. You have, as I said, there is something else also, that is the ejaculatory disorder. So, premature ejaculation is another one which comes with this. So, you have to use SSRIs which does fairly okay. Retrograde, you may have to use imipramine. Orgasmic disorder, there is no treatment, and for hypoactive sexual desire, testosterone is, I would still say, off label, but there is something known as a functional hypogonadism. But if there is evidence of hypogonadism, testosterone will work here. Why I have shown this is because most of the times whenever somebody comes with sexual dysfunction, everybody jumps and gives testosterone. So, important to understand, this is the interlink between hypogonadism, metabolic syndrome and erectile dysfunction. If you have hypogonadism, that is the only time testosterone will work, otherwise it is not going to work. If you have erectile dysfunction, you first go to phosphodiesterase inhibitors. If you are not able to improve with phosphodiesterase inhibitors, you have evidence of some testosterone deficiency, that is the time you come to a combination of these two together. Okay. So, important, do not jump on to giving testosterone to everybody who comes with sexual dysfunction. You have some other benefits of having testosterone, vitality, mood, bone, those are explained, those are there for the elderly ones. Okay. Now, we move to the female sexual dysfunction. Data, despite we feel that it is not a problem, but very many number of studies have said that even 60 to 70% of females beyond menopause, that is 50, 60 years, are sexually active and they have problems with that. Different problems exist in the female sexual dysfunction, especially in the diabetic spectrum, pelvic floor dysfunction, incontinence, polyps, lot of UTIs and GTIs which do not trigger or do not give that comfort zone to the lady. These are important things. Hypoestrogenism is obviously a factor in the menopausal and even diabetic for that matter. Management options are very limited as far as the female sexual dysfunction is concerned. More or less you are restricted to use only a estrogen creams to improve the estrogenization of the vagina. DHEA off label is still considered to improve the sexual function. Even testosterone in a lower dose, you have DHEA creams also, but most of them are off label. There is not one which is proven in a postmenopausal diabetics. Premenopausal for a hypoactive, I will come to that in recent advances, there are some drugs. Okay. So, this is as far as the female sexual dysfunction. Some of the clinical dilemmas what we see in day to day practice. Okay. One is most of these patients would have BPH. Okay. So, whenever somebody is coming with erectile dysfunction, please look at what the drugs they are using for the prostate. Okay. Finasteride and dutasteride, by virtue of their mechanism of action, will reduce the DHT levels. Okay, so we'll have less intratesticular testosterone. You have ejaculatory problem when you use tamsulosin, the alpha blockade. So depending on what is the sort of problem, is it a premature or a retrograde ejaculation, or is it a hypoactive desire, you may consider changing the drug what you are using. Conventionally, look at beta blockers, look at prostate drugs whenever somebody walks in with a erectile dysfunction. The second important thing in the younger patients with sexual dysfunction is this: lot of muscle built, lot of people who go to gym and who abuses the anabolic steroids. If you have more of exogenous testosterone coming out, your endogenous ones will go down. So you are actually having lot of sexual dysfunction. So important to understand, go to that history in these patients, what are they using, where are they going. Because isme kya, if you use all these anabolic steroids, आप भाई तो बन सकते हैं, बाप तो नहीं बन सकते हैं. So important to understand. Okay. So you can actually inform the patient that you are actually killing your own intratesticular testosterone. Varicocele is another important thing, which most of the patients actually consider that is a problem, even for infertility, even for hypogonadism. There are some meta-analysis which says that higher degrade varicocele has got higher risk of hypogonadism. Preferable to address it when you don't have any other reason or you have corrected all other reasons. Important again, there are some meta-analysis which said that it is important to address that if you don't find solution otherwise. Nowadays no talk goes without speaking about GLP-1 RA. So two pleasurable things in life, actually speaking. Okay, one is eating. Okay, so we all eat for pleasure, and the most other important thing is the sexual act also gives you the same pleasure. So that is why when you give GLP-1 RAs, you get more depression, you get more suicides. That is what the thing is. So what happens to sexual function? That is also, there are some of the studies which have come up. The rewind data which we look for cardiovascular, there is some erectile dysfunction data also of the rewind trial using dulaglutide, which says that these agents have improved the function of sexual function, but not directly. Though GLP-1 receptors are demonstrated across the reproductive system, but they have been mediated through improvement in the metabolic health, not through direct. Couple of recent advances and then I will finish. One, as I said, the melanocortin activators and flibanserin. These are the two drugs which are approved in the last few years for female hypoactive sexual desire disorder premenopausal, not postmenopausal. Okay. They are melanocortin activators, and another is a norepinephrine reuptake inhibitor. The another important thing is PRP. Now PRP is the one which is the, it's like a vitamin D of all. Okay, you can do PRP anything and everything. So there is some meta-analysis which says that PRP also improves. It's an intracavernosal injection of PRP. I don't know how it works, but there are enough studies to say so. Okay, so these are some of the things which people have been trying to improve how things work as far as the sexual dysfunction is concerned. Another important thing is the couple pause. We understand about menopause, we understand about andropause. You may have sexual dysfunction with partner in front of you, but may not have with a partner neighbor. So that is known as couple pause. So whenever you are finding that in history, look at closely, interview both the couple individually, simultaneously. Then only you will be able to find a reason why they are having sexual dysfunction. Okay? Because this is, as I said, it takes time to find out the reason, but unless you find out the reason, you will not be able to give a solution. Eroxon is one which is approved by FDA for erectile dysfunction. It's a topical gel which you just apply prior to the planned sexual act. So it's like your alcohol, something like it evaporates and stimulates the nerval endings and stimulates the vasal flow. Okay. So you have over the counter gel for erectile dysfunction, quite expensive, not yet available in India. but this is a US FDA approved couple of years back. So to conclude, sexual dysfunction is very important but neglected and underdiagnosed. Most of the changes are inevitable in diabetes, microvascular damage, there is no doubt, but it is modifiable. You look beyond ED. We all learnt ED, but we look beyond ED and now it is sexual dysfunction. Multifactorial etiology, look at appropriate therapy, don't jump on to testosterones. Important for the primary care practitioners to engage patients. Most important actually is the last line, the positive approach to sexual health. The importance is don't discount it that if he is otherwise okay, A1C is okay, his sexual health will be okay. It is not so. And I said I will end with Bollywood. So Bollywood has put it on the main cinema as far as the highlighting some of these problems are concerned. I am sure some of you or most of you would have seen the movies. And one famous dialogue of Badai Ho, okay? Mummy Papa ke karne ki cheez hai kya? You should never discount that when we interact with the patients, no matter what the age is. It is like when you are supposed to eat till you die. If you are otherwise supportive, you may have a sexual act also till you die. So I finish here. Any questions or comments, I shall be happy to take.
Thank you, sir, for wonderful and very insightful and very concise and clear presentation, sir. And definitely it was also full of sense of humor from your side. So now the forum is open for any question. Anybody? Because still we have some time.
Yeah, in that subgroup analysis of Rewind, they have done even the semen analysis at the entry and at the end.
Yes.
It is, they have been able to show that only these things were seen in patients who have got otherwise metabolic benefits.
Yes.
Non-responders did not have benefit here also.
Yes.
And tissue studies have shown that GLP-1 receptors have been seen in the Sertoli cells, in the Leydig cells, in the entire testicular tissue. But none of that has actually made any difference. So by and large, that Lancet paper says that it is only because of improvement in metabolic health you will improve. And there is umpteen number of evidence that if you lose weight, your sexual function also improves. Yes. Like metabolic syndrome improvement, that will help you.
Thanks, sir.
Anybody else?
The anogecultion and cyproheptadine, any role, and the treatment for anorgasmia coming from the use of GLP-1 receptor agonists, possibly related with the dopamine pathways. So the treatment.
See, that is why actually when I looked at it is the surprising fact that now that label is more or less on the verge of going with the GLP-1 as far as the depression and suicide things are concerned. But traditionally anything to do with reduced your appetite will reduce your mood and reduce your well-being. So that is why that sexual dysfunction also come into it. The neurotransmitter level wise dysfunction, if you look at it, it is more or less vague, or you are not able to look at the intracavernosal or intra, I am talking about here, the dopamine levels and serotonin levels. So unlikely that you will have a benefit, because you cannot discount the metabolic benefit induced changes. So you will not be able to find any difference in that. Despite losing weight, you are still not having a sexual dysfunction, is what at least that much of data we can lay a hand on, which is still a better proposition. Unlike in the past, where you may actually be able to have induce more problems with it, but here you are not inducing the other problems. That is the only difference. Cyproheptadine,
orgasmic disorders actually have got no treatment both in the male as well as female. That is one place there is nothing which you can do.
Sir, in most of the cases, especially in a young one, the storytelling is the thing. They listen from the colleagues about the act, other thing, how much they sustain, other things, and they get depressed. So, and somebody who comes from the spermatoria, they also get disturbed and there is some sexual dysfunction. So what I want to say is that the young persons, those who are otherwise well, but because of colleagues' description and exaggeration, they get depressed and they fail to have that.
I agree. See, the problem actually, one of the, I have not highlighted that here. The another biggest problem of sexual dysfunction is the addiction to the pornographic material which is widely available. It was not so widely available decades back, but now it is a lay of hand, a click, you will get anything what you want to see. Unfortunately, as I said, 70% of sexual function is driven from top, and your genital system only will work if that drive is intact. Now, the drive, if you are looking for something else, even though your sexual organs are intact, but the expectations are something different. So, that is why lot of young guys have this problem, because one, they are influenced by the videos or they are influenced by the friends, but on ground what is happening is different. So, that is why you don't, that mismatch is there between the expectation and the reality, and that is a problem with which we are having the sexual dysfunction.
Thank you, KVS Harikumar sir, for a very interesting topic. We often do not talk with our patients so frequently, so it's a very interesting topic by a stalwart like you. Thank you, sir. Now the session is over.
Thank you sir for the invite.
I would request the speakers and the chairpersons to come to the check-up point area for felicitation. Now for the next session, I would request Dr. B.K. Singh sir, Dr. Supriya Mukherjee sir and Dr. Anand Gupta sir to chair the session. I would request Dr. Anand Gupta sir to come. Achha. I would request Dr. Anand sir to come.
So, for the next session, we have Dr. Kaushik Pandit sir, who is current president of Endocrine Society of India, and I think he doesn't need any introduction. Sir, over to you, sir. Over to you.
Respected chairperson sirs, my respected seniors in the audience and dear friends. As I have said, it's indeed a great opportunity not only for me, but also for the Endocrine Society of India to visualize that Endocrine Society is setting its foot in this part of the country, and it's a very pleasurable moment for all of us. And I'm really thankful, especially to Dr. Santosh Kumar Singh for providing me this invitation to have a discussion on something which is close to our heart. Diabetes, you all know, it's genetic, at least partially, if not in whole. But the current understanding of genetics of diabetes is rather quite complicated, at least for common people like us. But there resides a form of diabetes where the genetics of diabetes is easily understandable, and we call this as monogenic diabetes. To start to think about monogenic diabetes, we can start with a standard English idiomatic expression of a needle in a haystack, simply exemplifying the fact that they are really very rare and it's difficult to pick them up. And while we talk about this monogenic diabetes, we come to another idiomatic expression, standard expression in English, where it shows that it's just the tip of the iceberg, meaning that despite the fact that it is easy to find out by genetic means, most of them are not properly diagnosed and treated. Rather, the majority, nearly 80% of the cases, are misdiagnosed and not treated properly. And that's where the importance of monogenic diabetes comes, because it has got substantial contribution for the therapeutic implication. Because in many situations it will unnecessarily avoid the insulin therapy, miss the family screening, or the unchecked anxiety. Now, when we talk about any genetics, the monogenic versus polygenic is easy to understand in the sense, in the monogenic variety, there is a single gene defect, where there is only one defect, which if you can unravel, then it becomes easy to identify and treat properly. In contrast to a polygenic, where there are multiple defects, like the right part of the story, where it's more of a chaos. And if we go into the different type of monogenic diabetes, and if we categorize them on the basis of the timeline of diagnosis, we will recognize that the first 6 months of life, the diabetes that happens, the monogenic variety is the predominant one, and that's what is known as neonatal diabetes. And something which occurs a little later, more than 1 year, more than 12 months, it's usually type 1, but both can happen. And in the gray zone, between 6 months of age to 12 months of age, both can happen in such a situation. So the golden rule is, less than 6 months, it's neonatal diabetes, go for immediate genetic testing. If it is more than 12 months, assume that it is type 1 and go for antibody testing. For neonatal diabetes, there are various varieties of neonatal diabetes. The one which is rather quite common and sort of easy to understand, not only genetically, but also pathophysiologically, is that there is a potassium gate in the beta cells, and in that gate you have got some agent like KER6.2 or SER1, the receptors, and they have got their names so far as the genes are concerned, that KCNG11 and ABCC8. What they do is that in that defective beta cells, the potassium ATP channel remains open, and the beta cells cannot depolarize, and therefore the insulin, despite the fact that it is being produced, remains trapped. So there is gross insulin deficiency leading to hyperglycemia. So if by some method a key is adjusted there, blocking that hole, this will immediately solve the problem, and fortunately that key is available with us for quite some time. They are plain and simple sulfonylurea tablets that are available. And with such a simple thing, that a sulfonylurea can treat a neonatal diabetes if the KCNG11 or ABCC8 is positive. So it makes sense to go for genetic testing in such a situation to decide about the course of therapy for throughout the life. Now there is also this neonatal diabetes can also be two different types. Interestingly, one is transient neonatal diabetes and another version is permanent neonatal diabetes. If it is transient neonatal diabetes, better it is, because nearly 50% of them are so. They develop diabetes in an early part of life, but they get out of that. So the pancreatic cells change and ultimately they go out of that phase of diabetes. But if it continues for some more time, especially if it is associated with KCNG11, ABCC8, they are usually permanent neonatal diabetes. Whereas if it is 6q24 variety, then it is a transient neonatal variety, which is also quite rather significant in its presence. So diagnosis less than 6 months of age, test for 6q24 first, because this will give you a good news if it is positive. It is transient neonatal diabetes. Else, test for KCNG11 or ABCC8, and they are the targets for sulfonylureas, because that will give you an option of treating them with plain and simple sulfonylurea. Other genes are also there, which certainly can be tested as well. Now next comes what is known as MODY, that is maturity onset diabetes of the young, where theoretically it's behave like type 2 diabetes but occurring in a young person, and that's why this nomenclature. It's usually autosomal dominant, affected parents with 3 generations of history. Very, very importantly, the autoimmunity, that means the type 1 diabetes antibodies must be negative. The C peptide, at least later on, nearly 5 years of age, would be detectable or preserved, may not be very much preserved in the initial phase of the disease. And they, of course, do not suffer from the usual problem of severe obesity or metabolic syndrome. So that's how we diagnose maturity onset diabetes of the young. But I'm sorry to state that this nomenclature of MODY is out. I don't want to mean MODY is out. I hope that you don't make a second meaning of it. What I want to mean is that now you don't call this MODY anymore. You call this as the defect followed by the diabetes. The one which we used to call as MODY1 earlier, which is a defect in the HNF4 alpha gene, you call this as HNF4A diabetes. Subsequently, like GCK, glucokinase gene, which is defective leading to MODY type 2, we call it as GCK diabetes, and so on and so forth. So the international consensus recommends gene name plus diabetes, and we would like to follow that one. So if we are into this precision detective framework, when to suspect this MODY or whatever you say, we can think of in a 4 different scenario. The first scenario may be neonatal, less than 6 months of age. It can be familial young onset diabetes. It can be familial mild hyperglycemia, or it can also have extra pancreatic syndrome. Let's take individually all of them. So scenario A, the infant which is less than 6 months, we have said that presumably it has to be a neonatal diabetes and should be assumed so and tested for the neonatal diabetes genes. Gray zones between 6 months to 12 months, you test for antibody. If it is negative, you assume that this is neonatal diabetes, else it becomes type 1 diabetes. And autoimmune type 1 diabetes, or type 1A to be very specific, is very, very rare before the age of 6 months. So you know how do we go about. Scenario B, where there is mild hyperglycemia, maybe familial, where they are actually asymptomatic. It's usually an incidental discovery. It is actually a problem with the glucose sensor defect. So sort of something like a broken thermostat, and they usually have got a stable fasting hyperglycemia. This is what is the classical of what in yesteryear is known as MODY type 2 is now known as GCK diabetes. And fortunately, they do not suffer from the ills of diabetes with time. So this mild hyperglycemia is actually non-pathological. Scenario C, where there is false type 1 in the sense that HNF1A or HNF4A type diabetes, whether this is type 1 or MODY, we have to think in terms of other parameters like ketosis, positive antibodies, measurement of very low peptide. Whereas if there is an autosomal dominant history, C-peptide which is not very low, especially after 5 years, which is antibody negative, we think of HNF1A or HNF4A diabetes. HNF1A especially has got a property of marked glycosuria at normal blood glucose as well. So that gives you an idea about whether this is HNF1A or HNF4A. And one particular group in the world has proved that if you can measure the urinary C-peptide, that probably gives a much better outcome in diagnosing them, much easier. Fortunately, we have got a Exeter probability calculator which is freely available on the net, and anybody can utilize this one, which asks about 3 or 4 parameters like age of diagnosis, body mass index at the time of diagnosis, HbA1c at the time of diagnosis, time to insulin. And with this calculator you can understand what is the probability of having MODY, and depending on that you can direct your test. You may or may not do the test depending on the degree of probability. Scenario D is extra pancreatic syndrome which are also there, something like say renal cysts or deafness, or for that matter uterine abnormalities, gives you the clue that this is this variety of MODY. Like in MODY 5 you have got renal cysts or uterine abnormalities. In mitochondrial type of genetics you have got deafness associated. So those extra pancreatic syndromes gives you the clue as to what variety of MODY that we are talking about. We have already said that potassium channel pathophysiology is associated with KCNJ type neonatal diabetes, where it is much easier to do the treatment with sulfonylurea because it attaches itself to the SIR1 which is close to that potassium channel and blocks it, allowing the depolarization in the beta cells to happen, and therefore the hyperglycemia can be treated so easily. Treatment revolution is that in yesteryears neonatal diabetes were treated only with insulin. With the current understanding of the SIR1 pathophysiology, we understand that they are very much amenable to treatment with sulfonylurea, though at a little higher dosage. Treating HNF1 and HNF4A or MODY3 or MODY1 in earlier years, they are sulfonylurea sensitive. There is more sensitivity in than the usual type 2 diabetes. They require a low dosage of sulfonylurea, and standard dosage that we treat for type 2 diabetes leads to severe hypoglycemia. So HNF1A diabetes can be identified by a very low degree of need for sulfonylurea, whom you had been thinking of type 2 diabetes harboring that one. GCK diabetes, fortunately the only thing that you do is by your vocal route. You really don't need to do anything, the art of doing nothing. Pharmacotherapy is ineffective, and it does not regulate the set point which is set at a higher one. And fortunately they do not suffer from the standard ills of diabetes or macroangiopathy or macroangiopathy of diabetes. So you actually do not need to do anything. Only thing is that you let the person and the future physicians to know that he has got hyperglycemia, which does not need to be treated. But only in one situation in GCK diabetes you have to be careful, is that if that person, that lady becomes pregnant, if the fetus is GCK positive, once again you don't need to do anything. But if the fetus is GCK negative, then this little high glucose would lead to macrosomia, and then this is the reason why you need to treat this mother who is GCK positive, had not been treated yet, needs treatment for the sake of her baby. Treating HNF1B and syndromic forms requires insulin. Sulfonylureas are ineffective. Management is early insulin therapy and monitor the renal function and magnesium. precision treatment matrix for GCK is only diet and observation. HNF1A or HNF4A type of diabetes is a transcription factor mediated diabetes. Low dose of sulfonylurea is effective. KCNJ11 ABCC8 is a channel defect. High dose sulfonylurea is needed. HNF1B is developmental defect, homeobox domain, where insulin is the answer. But it will be incomplete if I don't tell you that the future is now, because with an NGS, we can identify this defect much earlier and do what is known as a halo effect, changing the family dynamics, because it's an autosomal dominant. So genetic counseling has got a tremendous role, and correct diagnosis stops unnecessary insulin therapy in such situation. And next gen sequencing, that is NGS type of testing, is the one that we should go for rather than one gene only, and that is cost effective in the long run and tests all monogenic candidates simultaneously. So in summary, suspect if the diabetes is less than 6 months, antibody negative, this is neonatal diabetes. Confirm your MODI by using probability calculators and urinary C-peptide ratio testing. Treat insulin for HNF1 beta or tablets for neonatal diabetes and HNF1 and 4A type of MODI. It definitely have got an impact so far as diagnosis, treatment and the future of the person is concerned, as well as the importance of genetic counseling in the future generation. I'll stop here and would invite questions. Thank you very much.
Thank you, sir, for your nice and precise. So, usually it is said that diabetic runs in the family because no one runs in the family. But it is not correctly true, because there are definite genetic etiology in up to 5% of the cases. And I want to add that the test of choice is whole exome sequencing, which is very cheaper now, 6,000, 7,000. The cost has come down tremendously and it is available on 6,000, 7,000 rate. So whenever you suspect, you must do genetic testing for the complete and accurate treatments. So house is open for any question, comment or query.
Sir, is there any importance of urinary C-peptide and insulin ratio? And can you explain, sir, in what way the urinary C-peptide level will help in our clinical setting? Okay.
We did not have access to the results of the urinary C-peptide. It came out of one important study from one particular center. It's not a very standard one practiced all over the world. But the center that had given us this idea gives us a very easy to test protocol, easy to test parameter as an urinary C-peptide, where you can differentiate between different types of diabetes, monogenic versus polygenic, with one simple test. So if you think that this is HNF1A, then probably urinary C-peptide measurement would be helpful.
Sir, one question from my side regarding transient neonatal diabetes. For how long we can expect remission in those patients?
Times vary, but it usually 6 months to 2 years the diabetes gets resolved.
So if there is no question, we can conclude the session and
Thank you
move
very
to
much.
next. Thank you.
I would request the speakers and the chairpersons to come to the checkup point area for felicitation. For the next session, I would like to invite Dr. Subhash Kumar sir and Dr. Anil Kumar Singh sir.
Yes, good afternoon everyone. Wonderful program of Bendocon 2026, and we know that the whole scientific program is curated so well that now hall is full, and we must thank the organizer Santosh sir and everybody for this. And we have a very erudite speaker, Dr. Sujay Ghosh, with us, and we know that the talk which is going to be taken care here is on structured program on type 1 diabetes. We have heard about structured program of type 1 in UK, and here we have a program called West Bengal type 1 which is been awarded, it is been awarded by SPAD 2025 Scientific Innovation Award, and also UNICEF has awarded, and it is the program was led by none other than Dr. Sujay Ghosh himself, and he is here to teach us, which can be followed to all the different states of India, where type 1 children can be helped in such a way. I have read his article, and it is so nicely done that we all should learn to his model, and we can also adopt, our government can help us in terms of looking after type 1. So over to Dr. Sujay Ghosh without wasting any time.
Right. Thank you, respected Chairperson, sir. Firstly, big thank you to the Bihar chapter of the Endocrine Society of India, particularly Dr. Santosh, sir. I am witness to the registration of the state affiliate of Bihar for the Endocrine Society of India. It started when I was Secretary of Endocrine Society of India, and it is wonderful to see that this state has started its first meeting. Now, Dr. Singh asked me to actually present on this topic, though perhaps personally I would have wanted to speak on other original research, but I'll try and talk to you about the work that we've done in West Bengal. It's more of a public health approach to type 1 diabetes rather than any other scientific approach. So first of all, India has the highest number of children with type 1 diabetes. When we were MBBS students, we were taught that type 1 diabetes happens in the Scandinavian nations. Finland, Sweden has high numbers, but because India's denominator is so big, we have the highest number of people with type 1 diabetes. And if any of an Indian is diagnosed with type 1 diabetes, his life expectancy is only around 29 years from the time of diagnosis. So if an Indian has an average lifespan of 70 or 71 years, if you're diagnosed at the age of say 10 years with a diagnosis of type 1 diabetes, it means at the most you will be living until the age of 30 years. Look at the same data in the Western world. Lifespan is shortened by about 3.5 years in the Scandinavian nations if you have type 1 diabetes. The next paper that I quote, I would actually thank Dr. S.V. Madhu from UCM Delhi for this particular publication. So in India, you know, you have the ICMR Young Diabetes Registry, Dr. Mohan, Dr. Nikhil Tandon, all of them are part of it. And he had the courage actually to publish this bit of the data, that UCM Delhi was looking after close to 900 children with type 1 diabetes. And in a 6.5 year follow-up in a tertiary care center in Delhi, 11.6% of the children had died. So that is the situation in tertiary care setup in the capital city of India. Then just imagine what the situation is in a district hospital and in a subdivision or in a village. The problem in India is private healthcare is only for the affordable few. There is no insurance coverage for any kind of diabetes, forget about type 1. And it is individuals and organizations who are actually running the show in terms of type 1 diabetes. The other issue is health is a state subject. So each state decides what they want to do in terms of their health policy. But the national health policy is driven by the central government. So even if you have a national health policy on something, it is up to the will of the state to decide what they want to do. And the other thing is, if you look at the non-communicable disease program, because that's what the central government runs, it has had 4 revisions in the last 15 years. And if you press Control F and type in type 1 diabetes, it figures twice. Once when it talks about the types of diabetes, and in the glossary of terminology it talks about T1D is equal to type 1 diabetes. So what do you do? So I kind of did a literature search to figure out, are there existing models of type 1 diabetes care in public health care systems in low and middle income countries, and there is no such model in any country in any of these setups. All the models are there in the developed countries, in the developed world. So the first thing that I reached out was to reach out to pharma companies, because they know who is buying insulin. So किसके घर में influential person है जिसके घर में किसी का type 1 diabetes है. Otherwise nobody wants to change any policies. That was the first thing. So finding the right people. So some speaker, some judge, some politician who has a type 1 in the family was willing to listen to me. And I gathered information, and then we thought that whatever model we create, in that we have to provide the medication, ensure monitoring of these children, provide counseling, emergency care, and what's most important is data and publishing, because what you've not published, you've not done. And the model should be simple, economic, it should be scalable, and it should be sustainable. So we based our model on the intermediate level of care of model of the ISPAD, International Society of Pediatric and Adolescent Diabetes. And that entails that every child should be on a basal bolus insulin, they should be provided glucose strips for monitoring, HbA1cs every 3 months, intensive diabetes education, and annual screening for all the comorbidities and complication, and you have to provide emergency care and support. So the first few years, like everything else in life, is failure, failure and failure. The first 2 times I applied to the central government through the program implementation plan, it got rejected. And then the director of health services told me, why don't you apply it as a plan or a project, in a pilot project in innovation. So that is how I applied through the state government to the central government for funding. Because you know, there is something called program implementation plan which happens every 2 years. From this year it is going to happen every year, wherein if a state writes to the central government to say, my state has this problem, can you provide us some support? They will provide 40% support, and the rest 60% will have to be provided by the state government. The reason my director of health services said to do this was, he said, if you can show that this is working, then the central government is obliged to acknowledge the fact that this is a public health problem and this solution is working, and therefore they have to scale it up. And we managed to do phase 1, that was 2020 in the project in innovation, and we obviously had our limitations and advantages. On the basis of the phase 1, we applied again a couple of years later for phase 2. So in phase 1 we started 5 clinics in 5 district hospitals of the state. In phase 2 we added another 10 districts, and this is what we did. So that's the logo of our clinic of type 1 diabetes. So the non-communicable disease clinic which is there in each district hospital, we upgraded it to a once a week type 1 diabetes clinic in the existing NCD clinic. It wasn't easy, and we had to find solutions because supply of drugs is always a problem. So what we did, we created a mini pharmacy within the type 1 diabetes clinic, so that you have control over the supplies of that place. The devices, the equipment, and the IT support and the mentorship. Shomik, for example, is here. He had initially did the mentorship of Imambara General Hospital, which is in Howrah district. So we started off with a day-long intensive training program at Shasto Bhavan, and this is a typical type 1 diabetes clinic that we've set up. This is from MR Bangur. This is from Barashat Hospital, you can see. And what we did, we basically plagiarized the adult NCD program. The adult NCD program has a diary. We converted that into a type 1 diabetes patient ka history taking diary, a card, an SMBG logbook. We created a web-based application portal so that everything is electronic, from prescribing to stock taking to monitoring, from investigation, everything is there, and e-prescribing. So we had control of everything for every child, and these are the things that we have been giving to each of the child. insulin regular, insulin glargine, 40 IU syringes, 100 IU syringes, 100 strips for the glucometer per month, lancing device, lancets, all of that. And this is typically what you would see within the clinic. You have the refrigerator, the drugs and the consumables. We trained up the nurse and we kept data of everything, monthly summary reports and other things. We created IEC material, and every 3 months we do additional camps. Why? Because this service is being run by the pediatrician and the adult physician who we have trained up, along with the NCD counselor, the clinic nurse and a data entry operator. And it's a fixed individual. ये नहीं कि बाकी का जो program चलता है, आज तुम चले जाओ कल हम जाएंगे, ऐसा नहीं होता है. It's a named individual. So in each of the camps we do something in terms of the patient service as well as additional education. This, as you can see, is an AI enabled digital fundal photography camera with which we are screening for retinopathy as well. So this is my state of West Bengal. So the yellow bits is the first bit that we started off. The green is phase 2. The last red bit is Darjeeling, which has officially been inaugurated. The patient services will start from next month. So if I give you an idea of what did we do and what did we find of phase 1, because that phase we have more than 2 years data now. And I'm only going to show you the data of the patients who are already being enrolled somewhere else. For example, they were coming to Kolkata for treatment. We did not, I'm not showing you data of people who are newly diagnosed, because if I show you data of newly diagnosed who came to the clinic, I will be overestimating the benefit. So these are people who were getting treatment somewhere, maybe a tertiary care hospital or elsewhere. And I'll just show you. So important thing to understand is that what is the family income of these children that we are looking after. The family income monthly is about 7,000 rupees for a family of 4.5 to 5 people. So per individual in that family, the earning is only about 1,600 rupees. And if you see, 40% of our children are coming from below poverty line. That's, so you know, financially they are disadvantaged, and educationally also they are very, very disadvantaged. 20% of their parents, both parents have not finished primary education. So you are trying to tackle such a difficult situation. So to start with, not everybody was on basal bolus therapy. After we enrolled them, everybody is now on a basal bolus therapy. And look at the injection sites. They were unhealthy in about 25% of the children to start with. Now almost about 99% of these children, their injection sites are wonderful. And almost everybody is self-injecting if you are above the age 7 years. So we are only allowing the parents or somebody else to help the child if the child is below 7 years of age. Otherwise, everybody else is on self-injecting. When we started off for the entire cohort, the HbA1c, mean A1c was around 9.4, which we have brought down to 8% in 2 years' time. And you might argue and say, oh, jo basal bolus pe tha, those are the ones premixed, those who have now been shifted on the basal bolus, they must have benefited more. So we've done a subgroup analysis to show that there is consistent improvement irrespective of what you were on when you started. The lipid profile, the thyroid profile, not much to talk about. Acute complications. Now I started off by showing you that paper of Dr. Madhu to say that in about 6.5 years, 11% of the children were dead. Now we have 5-year data, death rate is 0. 5-year data of 1,700 children, death rate is 0. And we have prevented ketoacidosis and hospitalizations as well. Now this bit of the clinical data. But what about the psychological bit? So we've looked at all of the basal psychometric parameters in terms of diabetes specific health outcomes, quality of life, general well-being, family functioning and social support. And what we have shown is undoubtedly all of the parameters have improved in our children and their families. Now I started off with the expenditure. I told you the family earns about 7,000 rupees, right? So if you look at direct plus indirect expenditure before we enrolled them into the program, out of pocket expenditure was about 2,600 rupees. So out of a family income of 7,000, they were spending 2,600 rupees per child. Now once they are in our program, they are spending 200 rupees a month. That is predominantly because of the transportation cost and the loss of the wages of the parent for that one day that the child has to be brought to the clinic. So this is summary of our findings. 41% below poverty line, 20% parents have no schooling, 100% now on basal bolus, A1C down to 8%, much less hypos, hospitalization and death down to 0, improvement in mental health and treatment costs gone down dramatically. So we've published our methodology paper and we've published in Lancet to show that this should be the model of care for India. And we still realize there is plenty of gaps because the staffing through which we are delivering the care, these are NCD counselors, these are doctors, physicians who have never treated type 1 diabetes. So we need to pump in more support in terms of the education, patient education, dietary inputs and psychological support. I'm happy to share that we have been working with the University of Leeds and with DigiBeat, which is a UK based organization. We have created an app in English, Bengali and Hindi with 209 items on it, which has videos, infographics and animations with regards to education of these children and their parents, which we will be providing to them for free. This is going to be launched around the 3rd week of April 2026. We have applied for and got a grant wherein we are creating an AI based application for carbohydrate counting. So you just have the food in front of you, take a picture of it with a 2 rupee coin next to it, because that will be comparing it to give you the portion size, and it will speak out 4 unit insulin, so that you don't have to teach people how to do carbohydrate counting. The next thing that we felt was that why be selfish and stick everything to the state of West Bengal. So what we have created is, I call the dummy's guide or the idiot's guide on how to set up a type 1 diabetes clinic in a public health model. So we've broken up everything. So for example, when you go to a place to do a visit, that we want to do a clinic here, what are the things or checklists that you should have? Physical infrastructure. अच्छा ठीक है, आपके पास blood pressure instrument है, बच्चों का कफ है, स्टेडियोमीटर है, weighing machine है, everything. We have not kept anything to chance, so that anybody can start a clinic anywhere that we want. The next thing that we've done is we've created a program for the school health. So every child, to whichever school he is going, we are educating the teachers, because 6 hours a day the child is in school, so that that child does not have any issues in terms of management and help in the school. And the good thing is, most of the schools, for example this letter, the schools have pledged support, that they have made everything for the child free in terms of education, all fees waived until class 12 for these children with type 1 diabetes. Now I told you to start with, my aim was to change the national health policy, because once the national health policy changes, the states have a framework to work upon in terms of what do they do in terms of a policy. So there are 2 verticals in the national health policy that we are in the process of making change. Number 1 is the RBSK, the Rashtriya Bal, and the other is the NCD. So I'll talk about this a little later. The next thing that we have launched in 3 districts in West Bengal is the 4T campaign. So we have educated everybody in the healthcare system about the diagnosis of type 1 diabetes. So the first T is thirst, second T is toilet, third T is thinness, and the fourth is thirsty, tiredness, thinner, toilet. So any of these 4 symptoms anybody has, please do a blood glucose, and on an emergency basis send the patient to the hospital. And I'm happy to let you know that the RBSK last week has already declared that the form that we have created, because I don't know whether you know, every ASHA worker has been given a tab. You have the NFHS data, so every ASHA is now going to the rural houses. In there we have added a form for children, in which it will capture, do you have a child with diabetes in your family, so that that child can be tracked to the district hospital, to the type 1 diabetes clinic. So that has been already done. So the making of a national health policy, for the last 6 years I've been fighting for it. I'm on part of the national program of NCDs for children and technical expert for children and diabetes, and the RBSK. And we have created both of these 2 documents which are lying in the ministry for approval. We are going to have the first bit, that is the RBSK guideline, is going to come up first, and that's going to happen within the next few months in India. I have actually gone and helped 8 other states to launch this program. through certain agencies, including the Clinton Health Access Initiative as well as UNICEF, as explained by Sir. And like he explained, that we've got the ISPAD award last year. And I would like to finish by thanking the government of West Bengal, the government of India, Life for a Child, Breakthrough T1D, UNICEF, Diabetes Endocrine Research Trust, and particularly Masuma, who's my PhD student. She's an MPH, she's doing a PhD in public health, and Clinton Health Access Initiative. Thank you very much.
Thank you. Incredible.
Thank you.
Worth saluting. I'm sure all of us would be heartened to know that type 1 diabetes, if the entire system gets together, it will not be disheartening and not be discouraging to physicians and the family. If anybody in the house has anything to pick his brain on, please go ahead.
Diagnosis of type 1 diabetes? Sir, the diagnosis is being not made by the clinics. It's by the other healthcare professionals down to the ASHA worker. So there are 4 heads under which it goes. The mobile health team is there, the Anganwadi worker is there, the school health program is there, and everybody else. So we have educated them about the 4T campaign. So anybody with any one of those 4 symptoms, they will be asked to do a blood glucose test. If it is above range, it will be presumed that the child has type 1 diabetes, even if the child has other forms of diagnosis, and the referral has to happen within 12 hours.
What is the cost per child in a year?
Right. So we've made a cost estimation of the treatment that we are giving. It's about 13,500 rupees per child that the government is actually spending. The advantage is we are not calculating the human resource, because ये लोग तो काम वैसे ही करने वाले थे.
That's great.
In those children who had been included in this program, the first question. And second question is, once if their child is having diabetic ketoacidosis and any of your center notices that, where you refer these children for the further management?
So the first thing I will answer is our hospitalization rate for DKA was 0. So we have been able to teach them the sick day rules over and over and over. Every visit, talk about the sick day rules. That's number 1. The other thing that we did in phase 1, Shomik is here, is that we had tagged each of these district hospitals to one medical college. So for example, Imambara Hospital I had tagged with Shomik with NRS Medical College. So, and the district hospital, we trained the pediatrics department as well as the medicine department. So if they at any point of time have an admission and where they feel that they are unable to tackle the problem, a blue light ambulance will take that child to the tertiary care hospital.
Would this app, sorry,
please go ahead.
Would this app that you talked about would be available for everybody, or
it will be a free app for everybody?
Everybody.
It will be an open resource.
Okay. Thank you.
Shuja, did you have a chance to compare and contrast Madhu's data with that of yours? There are striking differences. Madhu did not report any hypoglycemia whatsoever.
Right.
So do you think that they might have been under-treating those patients?
No, the challenge is, when we started prospectively with a web-based application portal to document everything. Dr. Madhu's data that he has published in DRCP is retrospective kind of data, where they have gone and asked people, ki kaise the aap? So that's a very, very subjective way of collecting data. The death bits is hard data, because he has gone and done a death audit. Because he's gone and found out these children were not coming, let us send people to their houses to find out what has happened to this. That is how he found out that they are dead. And whether whatever the cause of death he has written is right or wrong, I don't know. But that is what he has found. Because unless and until you prospectively decide that these are I can show you the software, it is very robust. Everything goes in. Every visit, every height, every weight, every CGM, CBG data is documented. And every time they are asked about what happened, पिछले महीने में कितने बार assistance लगा, so that this is much more objectively, prospectively taken data, and I can't compare our data with his data.
And there is no thyroid function abnormality or celiac in your series.
No.
You have a large number,
Yes.
1700.
So in the celiac screen that we've done we've published that in IGM as well. Eastern India somehow we have much less celiacs. And in our type 1s, you know, even from PG, I think how many celiacs have been seen, sir, in the last 20 years? 3 celiacs in type 1? Not more than that.
Anything else? Then we'll wind up. Thank you very much.
Thank you very
Great
much.
talk.
Thank you.
I would like the speaker and the chairpersons to come for the felicitation. Now for the next session, I would like to invite the chairpersons, Dr. R.P. Srivastava sir, Dr. Anand Kumar sir, and Dr. Saket Kumar sir to the stage.
Topic, of course, we are going to talk about hypoglycemia. Every person, every physician who is treating diabetes dreads this word, hypoglycemia. All of us have come across hypoglycemia. But is it always due to diabetes only, or the way we are treating diabetes? Or maybe it is beyond diabetes. It is beyond diabetes that there are cases of hypoglycemia. And should we tackle hypoglycemia en masse, tagging it with diabetes, or is it something else? Etiology is different. We all know hypoglycemia can occur, what we call reactive hypoglycemia. There is alcoholism, there is drugs, tumors, they all can cause hypoglycemia. So I think Swami Goswami is going to talk about treatment of hypoglycemia in diabetes and beyond diabetes. And of course, his credentials are all mentioned on the chart. I don't have to mention it. He's a learned and a very articulate speaker. So welcome to you.
Thank you, sir. A very good evening to all of you. If you look at hypoglycemia in patients without diabetes, that's extremely rare. And this rarity is not an accident. There's an evolutionary basis for this rarity. So if you go back in time millions of years, our ancestors could not step out and have a samosa like we are doing today. They had to hunt for their food. And we know that the brain uses glucose as an obligatory fuel. So if you did not get your food for one day, and if your brain did not get its glucose, our ancestors would have turned into prey instead of being a predator. So you had robust mechanisms to maintain your glucose levels. And those mechanisms are still at play today, because of which it's much more easier to develop hyperglycemia in an individual who is otherwise euglycemic than to develop hypoglycemia. And some of the mechanisms which prevent hypoglycemia are there in this image. Whenever your glucose level starts dropping below 80, and particularly when it reaches 70 milligrams per deciliter, insulin secretion is turned down. It starts getting cut off. Along with the decrease in insulin secretion, there's an increase in glucagon secretion, followed by release of epinephrine, and quite late there is release of cortisol and growth hormone as well, all of which are counter-regulatory mechanisms which result in an increase in blood glucose. At the same time, you have adrenergic symptoms as well, which tell you that something is wrong. You possibly need to search for food. And when your glucose level drops below 54 milligrams per deciliter, neuroglucopenic symptoms set in. You are really hungry, and this is a time when you are frantically searching for food. And in this entire mechanism, the liver, the kidneys, and the adipose tissue play a very important role in maintaining your normal blood glucose levels. So whenever you have hypoglycemia in an individual who does not have diabetes, that's a red flag. It means that something is wrong in this intricate physiological system which is resulting in hypoglycemia. So what I'll do today is I'll talk about some of the causes, how to diagnose them, and the basics of management of hypoglycemia in individuals who do not have diabetes. Now the first step is confirmation of hypoglycemia, because all that which looks like hypoglycemia might not be hypoglycemia. You need to look at the clinical circumstances of hypoglycemia. When is it occurring, the severity of hypoglycemia? You have to recreate the crime scene. The circumstances under which hypoglycemia occurred have to be recreated and certain tests done. You then need to look at the test results, interpret them, and finally manage according to the etiology of hypoglycemia. So as I said, the first step is confirmation of hypoglycemia. So how do you confirm hypoglycemia? You need something called the Whipple's triad, and all three criteria need to be fulfilled to say that yes, this is hypoglycemia. The signs and symptoms must be those of hypoglycemia. The plasma glucose, mind you, it's not a capillary blood glucose, the plasma glucose level should be less than 55 milligrams per deciliter, and after the plasma glucose level is raised after giving glucose or food, the symptoms should go away. So all these three, when fulfilled, you confirm that yes, this is hypoglycemia. Now again, in normal individuals, particularly young women below the age of 40 years, the glucose levels at times might go down up to 40 milligrams per deciliter without any sign and symptom of hypoglycemia, and it is actually physiological, not always pathological. But whenever the glucose level is less than 40 and you're not having any symptoms, you need to have a relook at the test. Erythrocytosis, thrombocytosis, leukocytosis, all of them can result in artifactual hypoglycemia. The glycolysis inhibitor should be there in the tube, and preferably it should be assayed immediately to confirm hypoglycemia. However, in someone who has definite neuroglucopenic symptoms, you are very likely dealing with an organic pathology behind hypoglycemia. Once you have confirmed the diagnosis of hypoglycemia, you then look at the clinical circumstances of hypoglycemia. Of course, if someone is critically ill, if someone is on a drug which causes hypoglycemia, life is easy. You look at the underlying cause and treat accordingly. The most important history with regard to hypoglycemia in an otherwise healthy patient is timing of hypoglycemia with regard to meal. Whether the individual has fasting hypoglycemia, particularly during the night or early in the morning when you do not have food for long periods of time, or whether it is postprandial hypoglycemia, which is hypoglycemia occurring within 5 hours of meal intake. So fasting or within 5 hours of meal intake, that's a very important history. Social history, particularly psychosocial, I'll come to that very soon, and weight gain and acanthosis, because weight gain implies that actually the patient is going for defensive eating to avoid hypoglycemia. Something pathological might be at play. And acanthosis means that there is increased insulin level, endogenous hyperinsulinism for whatever cause resulting in acanthosis. So in an otherwise ill individual, you look for some of the common causes, and as I said, life is easy, the diagnosis is almost obvious. One of the rarer causes of hypoglycemia in an otherwise ill individual is what is called non-islet cell tumor hypoglycemia. So what is this non-islet cell tumor hypoglycemia? So certain mesenchymal and epithelial cell tumors, particularly hepatocellular cancer or gastric cancer, release something called big IGF-2. This big IGF-2 acts through the insulin signaling pathway, acts like insulin to cause hypoglycemia without increasing endogenous insulin levels. So this is something which is very rare, and but the good part is that it's almost obvious. These patients are ill and they have a diagnosed malignancy resulting in hypoglycemia through the IGF-2 mechanism. In our pharma textbooks, we have a big list of drugs which might cause hypoglycemia, but with most of these agents, the quality of evidence is low to very low. There are only these handful of agents which have moderate quality of evidence directly linking them to hypoglycemia, and practically the first three are the drugs which are commonly used in clinical practice, which can directly result in hypoglycemia through a variety of mechanisms. Now, if the individual is seemingly well, ill individual, drug we have spoken about, seemingly well, then you are left with certain other causes. So if hypoglycemia is predominantly occurring in the fasting state, you might be dealing with an insulinoma. It is a tumor secreting insulin on its own. They are usually very small, commonly occur in females in the 5th decade of life. There are two causes of postprandial hypoglycemia because of endogenous hyperinsulinism, one of which is called non-insulinoma pancreatogenous hypoglycemia, where unlike insulinoma, where only a certain part of the pancreas has a tumor, here the entire pancreas is at fault. There is increased release of insulin in response to a prandial stimulus. And you can have something called post-bariatric surgery hypoglycemia. There are many hypotheses for this. Increased GLP-1, increased sensitivity of the beta cell to GLP-1, all of this might result in postprandial hypoglycemia after a bariatric surgery. It's important to keep in mind that the post-bariatric surgery hypoglycemia usually occurs a year, at least a year after bariatric surgery. So any hypoglycemia in a bariatric surgery patient which occurs within a year or occurs in a fasting state, not in a postprandial state, could be an insulinoma rather than a post-bariatric surgery hypoglycemia. There are other rarer causes like antibodies to insulin, so that when insulin is released, these antibodies bind to insulin, prevent it from acting. After some time, they suddenly release the binding, insulin is released, and it might result in a sudden hypoglycemia when the patient has taken food several hours back. Accidental, surreptitious, or malicious hypoglycemia is often a common cause of hypoglycemia which we deal with in our practice, and it can happen because of surreptitious use of sulfonylureas or surreptitious use of insulin. So when we are dealing with fasting hypoglycemia, how to recreate the situation? So if you ask your patients to fast, and if there's an underlying insulinoma, about 2/3 will develop hypoglycemia within 24 hours, 93% will develop hypoglycemia within 48 hours, but if you want to push the numbers close to 100, you need to fast for 72 hours. You can allow fluids without calorie, non-caffeinated fluids, and the patient should be ambulatory. The patient should not be bed-bound. You keep on sampling blood every 6 hours, but you do not need to send all the samples to the laboratory. It is only when you terminate the fast that you send the samples for analysis. And when do you terminate the fast? You terminate the fast whenever the patient develops a plasma glucose level which is less than 45, or has a plasma glucose level less than 55 with signs and symptoms of hypoglycemia, or 72 hours have elapsed since the beginning of the test. Even if the patient does not develop hypoglycemia, you send the samples. And you assay the samples for insulin, for C-peptide, for beta hydroxybutyrate. Ideally, you should also assay for proinsulin and oral anti-hyperglycemic agents, but they are not readily available in our country. So what is the basis of these tests? If we fast for 72 hours, the normal starvation response will set in. There will be decrease in insulin secretion, because of which insulin and C-peptide will be virtually undetectable. There will be ketosis, the beta hydroxybutyrate should go up. And if you give IV glucagon at the end of 3 days of fast in a normal individual, since the glycogen stores are already depleted, no further glycogenolysis will occur, the glucose levels won't go up. So you give glucagon at the end of the test and see if the plasma glucose is going up. And finally, do not forget to feed the patient, 1, because you want to save the patient's life, and 2, because you have to reverse the symptoms of hypoglycemia to fulfill the Whipple's triad. So this is the 72-hour fasting protocol. Talking of postprandial evaluation, it is done when you are suspecting postprandial hypoglycemia. Do not use a liquid or an oral glucose solution, but try for a mixed meal. A meal with which usually a patient develops hypoglycemia is the meal which is given, and then you assay and send the sample when the patient develops hypoglycemia. Now, how to interpret the result? In a normal individual, as I said earlier, the insulin and C-peptide should go down, the ketones should go up, and after giving glucagon, the glucose should not increase because you have exhausted your glycogen stores. In patients with insulinoma, endogenous hyperinsulinism for other causes as well, or in those getting a sulfonylurea, the response will be opposite. The insulin and C-peptide levels will be elevated, and the ketones will be suppressed because there is excess of insulin which suppresses ketogenesis, And since there is insulin, the glycogen stores are still there at the end of the fast. And if you give glucagon, there will be an increase in the glucose levels. I'm not going into the other causes because they are much more rarer. So what if you fail to complete the fast because of patient anxiety or physician anxiety? That fast is terminated. So if you terminate the fast at least after 18 hours, you can still somehow analyze the results. So if the patient has fasted for at least 18 hours, you send the beta hydroxybutyrate and do the glucagon challenge. If at this point of time you get normal starvation response, which is an increase in ketone levels without an increase in glucose levels after giving glucagon, meaning that the glycogen store is exhausted, it means that starvation response has set in, there is no endogenous hyperinsulinism, and you can simply observe the patient without further evaluation. However, if the starvation response is not adequate after 18 hours of fasting, the bad news is you need to repeat the test again. So once you have confirmed endogenous hyperinsulinism, which is increase in insulin, increase in C-peptide, decrease in beta hydroxybutyrate, and no increase increase in glucose after giving glucagon, the next step is to localize the lesion because you need to treat the lesion. CT scan, MRI, endoscopic ultrasound, there are varying degrees of sensitivity to detect the lesion. What has come as a saving grace, as a lifesaver in this situation is the Exendin PET CT. Indolent insulinomas, benign insulinomas, they overexpress the GLP-1 receptor. So when you are doing an Exendin PET CT, they light up with almost 96 to 100% sensitivity. When you are dealing with malignant insulinomas, you can go for the somatostatin scintigraphy because they express more of the somatostatin receptor than the GLP-1 receptors. Earlier, selective pancreatic arterial calcium injection was done, but with the advent of Exendin PET CT, it has gone into the background. Now, before going into the management of some of these conditions, one of the commonest causes of hypoglycemia that we deal with, because at NRS Medical College, if I look at the last 10 patients who were evaluated for hypoglycemia, 8 of them turned out to be in this category. So in individuals with pre-diabetes, because of excessive or sort of discordant increase in insulin secretion in the postprandial phase, you can have a late postprandial hypoglycemia, which is about 4 to 5 hours after a meal. Usually these patients are obese, they have a family history of obesity, of diabetes or PCOS. But again, it's important that you still need to do the provocative test and rule out insulinoma with imaging in all of them, because 20% of patients with insulinoma can also come with postprandial hypoglycemia. Insulinoma patients can be obese because of defensive snacking. Insulinoma patients can have acanthosis, just like patients with prediabetes, so you need to be careful there. Now, the definitive management of insulinoma is, of course, surgery. You need to remove the lesion. Radiofrequency ablation can also be done in indolent insulinomas who are not candidates for surgery. If you fail to localize the lesion, or if you can localize the lesion but you are waiting for surgery, diazoxide is available, is usually used in doses of 150 to 200 milligrams per day in adults. Often a thiazide diuretic is given along with it to avoid fluid retention. You have other drugs which cut down the insulin secretion as well. The octreotide, pasireotide have a role in metastatic insulinoma to sort of reduce tumor growth, reduce insulin secretion. Peptide receptor radionuclide therapy is being tried as well, and in very refractory cases, you can try the mTOR inhibitor or the tyrosine kinase inhibitor. I'll spend a minute on this because this is possibly going to be one of the more commoner causes of hypoglycemia that we'll be dealing with, given an increase in bariatric surgery that's happening. So again, this is a postprandial hypoglycemia, nutrition-stimulated hypoglycemia. So nutritional modification is the cornerstone of therapy. Avoid giving liquid with meals, it accelerates absorption. Give more of proteins, fats, complex carbs, less than 30 grams with the main meal, less than 15 grams with a snack. After taking a meal, if your patient can lie down for a couple of hours, that reduces gastric emptying. You can use drugs to slow down gastric emptying or to reduce insulin secretion. It is important that when a patient with post-bariatric hypoglycemia develops hypoglycemia, you do not give excess amount of glucose because that can trigger more insulin release. Give 10 to 15 grams of glucose and follow it up immediately with a protein or fat, which can be, say, a peanut butter or a cheese sticks, to avoid acceleration of gastric emptying. And in very refractory cases, you might have to resort to surgery and even reversal of the original bariatric surgery. So talking of the other causes, when you are dealing with non-islet cell tumor like hepatocellular cancer, gastric cancer, releasing big IGF-1, you need to debulk the tumor or remove the tumor. Glucocorticoids have a role, and alpelisib, which is used in the treatment of breast cancer, interferes with the insulin signaling pathway and has a role. Insulin autoimmune syndrome has been reported in patients taking methimazole, patients taking alpha-lipoic acid. The good news is that in 80% of the cases, it resolves within 3 months. You just need observation, you don't need to do anything. The bad news is that if it doesn't resolve, you can try a variety of methods, but evidence is very scarce. An important thing to keep in mind is that when you are dealing with surreptitious hypoglycemia, always look at the patient's psychological history. I had a patient with type 2 diabetes, a child, who had abnormal hypoglycemia. Although the child was on basal bolus, the episodes of hypoglycemia seemed a bit discordant. On careful observation, or rather on careful history taking, it was found that he was injecting insulin without taking food just to get its parents' attention, because its parents were fighting amongst themselves and he wanted his parents to give more attention to the child. So you have to take a careful psychological history whenever you get surreptitious hypoglycemia. So to sum up, whenever you get a patient without diabetes with hypoglycemia, you confirm the hypoglycemia with Whipple's triad. You look at the circumstances in a critically ill patient or with drug intake, your things are easy. In an apparently well patient, recreate the hypoglycemia either by fasting or by giving a mixed meal, analyze the results and then treat accordingly. But I would end with the sayings of Albert Einstein, who said that everything should be made as simple as possible but not any simpler. I say this because it's actually extremely difficult, more often than once, when you are dealing with non-diabetic hypoglycemia, to pinpoint the cause and treat successfully. Thank you.
Thank you, sir, for that nice deliberation. And before opening the session for the floor, I would like to have one question regarding insulinoma. Many of patients, sir, they usually come to us with hypoglycemic unawareness, and because they have long-standing thing, and usually they go to some neurologist for symptoms like seizure, and then they come to us. Can we have some other options to make them diagnose the insulinoma rapidly? Because at all the centers, we don't have a facility of diagnostic fast, because you need to have a proper setup. You have to have resident there and a proper lab setup. So is there any I can say clue to go specifically for insulinoma or like that?
So with repeated episodes of hypoglycemia, there is hypoglycemic awareness where the threshold for developing symptoms come down. The thing is that the adrenergic symptoms, they do not develop and the patient directly goes into neuroglucopenic symptoms, but the threshold for neuroglucopenic symptoms doesn't shift much. So it's usually in that 50 to 55 range that they develop neuroglucopenic symptoms where they can be picked up. The problem is that you still need to go for that critical sample when the plasma glucose is at least less than 55. The reason being that only when the plasma glucose is less than 55, that insulin secretion is almost completely shut off, so that those insulin C-peptide values, they are validated only when the plasma glucose is less than 55. The other problem is that if you go for an imaging directly, you might pick up a non-functioning lesion. And just a non-functioning adenoma or a simple SOL which is not the culprit lesion, and you might go for an unnecessary surgery. So there is no shortcut, you have to go for that critical sample, otherwise the surgeon won't go in and it won't be validated.
Okay, sir, thank you. So if there is any question to audience, they can ask to sir.
not exactly, it's with RYGB, the Roux-en-Y gastric bypass, that you get the most, and of course with the lesser sort of effective procedures, the incidence is much less. But with RYGB, about 1/3 of patients could develop after a period of a year. They might get some amount of post-bariatric surgery hypoglycemia.
If there is no questions from the audience, I conclude this session. Thank you, Dr. Somak.
I would request the speaker, sir, and the chairpersons to go to the facilitation area. For the next session, I would like to invite the chairpersons, Dr. Priyadarshi Narayan, sir, and Dr. Abhishek Kumar, sir.
Thank you, Santosh sir, for calling me to the dais. The adrenal disorders are very common, but less diagnosed. And we know that this is the gland of emergency. And so in emergency situations, we are less taught. Our residents are not trained. So let us gain some insights how to use corticosteroid in various adrenal disorders in none other than the master endocrinologist from the Odisha, Dr. Professor Sambit Das. Please, sir.
So a very good evening one and all, respected chairpersons and distinguished doctors present here. First of all, I must thank Santosh Singh sir and the team Bihar Endocrine Society for giving this opportunity. So I will be speaking on optimization of glucocorticoid therapy in diverse adrenal disorders. As we all know that glucocorticoids is a widely used molecule across the specialties, and even outside the medical curriculum it has been used left, right and center. So my talk today is to tell how we should optimize glucocorticoid therapy in various adrenal disorders related to endocrinology, and if someone has started with glucocorticoids, how we can go about tapering and stopping it. So that's the motto of my talk, and I'll be discussing with 4 simple case scenarios. So the agenda is I'll be discussing on glucocorticoid physiology, because we must know how the glucocorticoid is secreted and how we must emulate a normal physiologic secretion. Optimization of glucocorticoid therapy in various adrenal insufficiencies, primary, secondary, congenital adrenal hyperplasia, and something known as CIRCI, CIRCI, which I'll be discussing. I think many physicians who would be managing critical illness and adrenal insufficiency will be knowing this term. Then I'll speak few points on newer advances. So coming to glucocorticoid physiology, just to recapitulate our physiology knowledge. So the 2 adrenal glands which sit above the kidney actually has got a adrenal cortex and an adrenal medulla. So adrenal cortex has got 3 parts. One is zona glomerulosa, fasciculata and reticularis. So glomerulosa secretes mineral corticoid that maintains the blood pressure and the electrolytes. The zona fasciculata secretes the glucocorticoids, and the zona reticularis secretes the adrenal androgens. And if we see the right side diagram, just to show that how the glucocorticoids are being regulated. So from the hypothalamus, if there is any stressful condition, that secretes CRH. CRH acts on the anterior pituitary to secrete ACTH, and ACTH acts on the adrenals to secrete glucocorticoids. And glucocorticoids have action on metabolism, like it's mostly catabolic, like glycogenolysis, gluconeogenesis, proteolysis and lipolysis, mostly a catabolic thing, and it has got some effect on the cardiovascular and other organ system also. So this is the basic of glucocorticoid physiology. Now, how much glucocorticoid is secreted in our body endogenously per day has been studied by various authors across the world, and it is between something like 5 to 8 or 9 to 11 milligram per meter square. And if you can just sum up, it is the daily production is around 5 to 10 milligram per meter square, that is 15 to 25 milligram per day. So if we are giving a physiological supplement, then we should try to give this much of glucocorticoids. Now secretion dynamics is very important because it is clinically relevant. So there is a circadian rhythm, that is a 24-hour fluctuation of the glucocorticoids, and it peaks at the time of maximum activity or when the person starts activity. So for human being who are diurnal species, the early morning peak is there. For nocturnal species, say for example any of the nocturnal animals, it peaks at the night. Physiological purpose is prepares the organism for wakefulness and metabolic demands, and the clinical relevance is that optimal sampling time is early morning. You have to check for the glucocorticoids, and so also if you are giving glucocorticoids, the peak should be in the morning time. There is also a short pulsatile rhythm throughout the day. They are known as the ultradian, that is 1 to 2 pulses per hour, and the amplitude is superimposed on the circadian baseline. And the clinical relevance is that sometimes you may not get, if it is in the nadir of that ultradian rhythm, a proper cortisol level. So a day curve sometimes captures, but I am not going into details of the intricacies of that. Now coming to the next agenda, that is how do we optimize the glucocorticoid therapy. So till now we have discussed where from glucocorticoid is secreted, how much it is secreted naturally, and what are the phase-wise secretion in the body. So let us go how we optimize in adrenal insufficiency. So adrenal insufficiency is a condition where it is characterized by cortisol deficiency or glucocorticoid deficiency relative to the physiological needs. So suppose there is a high physiological needs, the body cannot secrete to that extent, and that is known as adrenal insufficiency. So from in this diagram, if we go from right to left, if the adrenal is at fault, we call it as the primary adrenal insufficiency. If pituitary is at fault, we call it as the secondary adrenal insufficiency. Its prevalence is more. And if hypothalamus is at fault, then that is known as the tertiary adrenal insufficiency, and it is the most common cause, because once we give more of supraphysiological glucocorticoids, which I was discussing on my first slide, then probably we will have land up in secondary and the tertiary adrenal insufficiency. Now I will just give you an example. This gentleman has actually complained of cough for the last 1 month. It was very irritating, dry cough, and he was feeling very weak, and there was some weight loss also. The patient had consulted the pulmonologist, and consequently pulmonologist has referred to us on OPD basis because he thought that probably the pigmentation has been quite severe in this scenario. And if you can see this person, there was definite pigmentation both in the palms, in the gums, and in the mucosas. The case history is quite big, but I'm just wanted to highlight the condition that we did a serum cortisol basing on the symptoms of hyperpigmentation and the low BP, and the cortisol has come out to be 0.99 micrograms per deciliter, which was quite low. And we did a serum ACTH which was quite high, it was 648. So that shows probably the adrenal is at fault because adrenal is not secreting cortisol and the ACTH is high. So it's a primary adrenal insufficiency. We went for a CT scan. As I told, it's a very huge case, but I am just summarizing in 2 slides. So there was bilateral adrenal enlargement, you can see in this CT scan. And when CT scan was done for the chest, there was a nodule in the lungs. We went for a CT guided biopsy that showed malignant epithelial tumor, and it's a small cell lung cancer. And remember that one of the most common cause of adrenal metastasis is small cell lung cancer, and this is that case. I am not going into how we manage that case, but I am just highlighting a case which may present to you with hyperpigmentation and cough and came out to be this condition. So this is a primary adrenal insufficiency. As an endocrinologist, we must know that glucocorticoid and mineral corticoid has to be given to this person. First line of agent for glucocorticoid is hydrocortisone. It has to be given at 15 to 25 milligram per day. Cortisone acetate availability is problematic, but you can give 20 to 35 milligram per day. Always give in 2 to 3 divided doses if you are giving hydrocortisone. Alternative agent, you can give prednisolone 3 to 5 milligram per day. Agents to avoid: do not give long-acting steroids, especially dexamethasone and betamethasone. Pharmacokinetic basis, because hydrocortisone and prednisolone are active agents, they give a proper supplements. But if you give a cortisone or a prednisone, it requires a hepatic conversion to the active agent, and that may produce inter-individual variability. We have highlighted the potency of different steroid. I think this is a very important slide, because day in and day out we use different types of steroid. We must know how potent and how compared to the other steroids are. So hydrocortisone, if it is equivalent to 1, then prednisolone is 5 times more potent, methylprednisolone is 6 times more potent, and betamethasone dexamethasone is 30 times more potent. So how we can make it more simplified? So hydrocortisone, dexamethasone 0.7 milligram is equivalent to methylprednisolone of 4 milligram, is equivalent to prednisolone of 5 milligram, and is equivalent to hydrocortisone of 20 milligram. So just a easy way to remember. Principles of physiological replacement: try to mimic the normal cortisol secretion, avoid over replacement because that may lead to CVD and metabolic risk, avoid under replacement because that may lead to fatigue and crisis. Individualization is the key of therapy. Dosing regimen: cortisol secreted in a pulsatile manner, I have told, and the highest occurs at the awakening. So if you are giving hydrocortisone 3 times a day, give first dose at the time of waking up, the second you have to give 2 hours after lunch, and the third dose you have to give 4 hours before the dinner. So how we remember that? So we give around 7 to 8 am the first dose, around 2 to PM as the second dose, and the third dose is around 6 PM. Do not give it later in the day because that may interfere with the sleep and insulin sensitivity. 2 doses versus 3 doses. 2 doses is easier to give, but hydrocortisone try to give 3 doses because that gives a more physiological profile of a normal cortisol secretion. Monitoring glucocorticoid replacement, remember that it is clinical and not biochemical or hormonal. Not hormonal, biochemically also we see, so it is always clinical. So assess the body weight, postural drop of the blood pressure, how the patient is feeling, energy levels, and signs of glucocorticoid excess, like frank features of Cushing's and all, so that you have to see. Avoid routine hormonal tests. So you may not do a cortisol level or an ACTH level while you are supplementing, because if you are targeting the ACTH, then probably you will land up in, if you want to normalize, you may land up in over replacement, and that can lead to a Cushingoid feature. So these are some of the over replacement features, like hypertension, weight gain, Cushingoid habitus, versus under replacement where there would be weight loss. Arthralgia is sometimes very common, lethargy, fatigue, and low energy level, and postural dizziness. Now we must tell the patient if someone is having hydrocortisone or a glucocorticoid replacement about the sick day rules. So steroid emergency cards the patient should carry, and if there is a fever or illness requiring bed rest, you may just double the dose of steroid for that particular period of time, and then once he recovers you can reduce that. Severe illness, trauma, vomiting, fasting or surgery, you have to give IV 100 milligram IV hydrocortisone. If the person has been admitted to a hospital, followed by 200 milligram continuous IV infusion in the first 24 hours, and subsequently thereafter. I will be discussing that. Emergency kit the person should have. Patient resources should be there, leaflet instruction and clear-cut instruction what you should do and when you should increase the dose. Now come to the case 2. Now this person has come to us for uncontrolled blood glucose level. He was getting almost like 70 units of insulin but not getting a good glycemic control. When we took the history, it was known that the person has been diagnosed with bronchial asthma around 1.5 years back. Some quacks, I should say it's a quack in the health in his village, has given a 2 milligram dexamethasone. With that the symptoms has improved, and followed by the patient has been continuously taking 2 milligram of dexamethasone, that is 0.5 milligram of dexona, 4 tablets for the, and he was taking 6 hourly also for the next 1.5 years, and the patient has landed up in these features. You can see the broad violaceous stria, the Cushingoid habitus, so it is nothing but an exogenous Cushing's. So that's the secondary and tertiary adrenal insufficiency. So when you give glucocorticoid dose above the physiological level, and most of the physicians who are present here must have seen this condition day in and day out when the patient is taking steroid from outside and has got completely floridly Cushing's. And it all depends on the potency, the dose, the duration and the individual susceptibility. Mostly it is the duration which matters. All routes can produce this Cushingoid features like oral, IV, inhaled, topical and intra-articular, and it leads to a secondary and tertiary adrenal insufficiency. These are the some of the steroids that can have more potency for low risk of adrenal insufficiency versus moderate and high. So glucocorticoid potency wise, if someone is on hydrocortisone or deflazacort, the chances of adrenal insufficiency is less, whereas if someone is getting dexamethasone, betamethasone or fluticasone. Administration route also values. If someone is getting oral or IV, then definitely the chance of Cushingoid and exogenous Cushing's and adrenal insufficiency is more. Dose, if it is of high dose and of more than 3 months duration, the chance of adrenal insufficiency is more. BMI also matters, and at older age, the chances of adrenal insufficiency with glucocorticoid is more. Don't think that by giving inhaled steroid, intra-articular steroid, topical steroid and intranasal steroid, you are not hampering the HP axis. They can jolly well hamper the HP axis and produce adrenal insufficiency, and I have given the data in terms of the percentage wise. Short-term glucocorticoid, if someone is getting 3 to 4 weeks of glucocorticoid, you can taper it very fast, you can stop it abruptly also, nothing will happen. But if someone is getting more than 3 or 4 weeks of glucocorticoid therapy with a high potency glucocorticoid, and if glucocorticoid is not required for that patient, you have to taper. How you taper? The higher dose you taper it faster, but once the person is at a lower dose, at physiological dose, maybe 5 milligram of prednisolone or maybe 10 to 15 milligram of hydrocortisone, you have to go slowly. Switch long acting to the shorter acting insulin. So someone is getting dexa or betamethasone, you change over to hydrocortisone or prednisolone. At physiological dose, there are two options. Either you can taper it and see the clinical feature and stop it, or you can do a morning cortisol. So the Endocrine Society guideline is very clear in that. So suppose you want to taper it, either you taper it to you change over to the short acting glucocorticoid, taper it closely, monitor the clinical features and gradually stop. But for the next 1 year, the patient may have adrenal insufficiency with stress, so stress dose has to be explained. The other scenario is that while tapering with the short acting hydrocortisone and at the physiological dose, you can stop for 24 hours, see the cortisol level. If cortisol level is less than 5 microgram per deciliter, you continue steroid. If it is more than 10, you stop it. Between 5 to 10, you can do a 250 microgram synactin test and find out the cortisol reserve. The next is CH. This is another case scenario. It little difficult. I think the endocrinologists who are present here can easily pick it up. But this patient has presented at the age of 16 years. With chief complaint of non-palpable gonads since birth and hyperpigmentation and short stature. The patient was short stature. There was virilization, and the karyotyping was female, 46XX. And when we did the hormonal analysis, the cortisol was low and the 17 OHP was quite high, 280 nanograms per ml. So it's a case of classic simple virilizing congenital adrenal hyperplasia. Not very common, it will come to an endocrinologist at anyhow. And when you land up at congenital adrenal hyperplasia, the treatment of classic CH is hydrocortisone, and because of the short half-life and minimizes the growth suppression, avoid long-acting glucocorticoids and avoid hydrocortisone oral suspension for children. The goal is to balance the glucocorticoid and androgen control without over-treatment. So these are the guideline by the Endocrine Society, congenital adrenal hyperplasia, which steroid you have to give. So glucocorticoid, if you are giving, you can give 10 to 15 milligram per meter square of hydrocortisone. You have to give fludrocortisone and adequate sodium replacement. For adults also, hydrocortisone is preferable. You can give prednisolone around 5 to 7.5 milligram, but avoid giving dexamethasone and betamethasone. Fludrocortisone again has to be given, and the right side I have told about the suggested stress doses for them. Now the fourth case is very interesting because physicians, if you are exposed to ICU and all, you must be getting such type of patients, and what we should do is very important. This is a 75-year-old female. Unfortunately, I don't have a photograph because photograph was not required for this patient. Type 2 diabetes, CKD on hemodialysis, required several redo laparotomies. The patient had a very stormy outcome in our hospital because there was some laparotomies for bowel perforation. Again, it was repeated, and the patient was quite sick for a long period of time. Almost ICU day 30, she remained in altered sensorium. The sensorium was slowly deteriorating. By the day 30, she had altered sensorium dependent on vasopressure at a very high dose, was on mechanical ventilation and renal replacement therapy. Plasma total cortisol measured on day 30 was 8 microgram, which was low, and the treatment we started was 50 milligram hydrocortisone twice a day, and with that the vasopressures, it was swiftly tapered and stopped, and clinically the patient has improved. The hydrocortisone was not started by endocrinologist, it was started by the physician and the intensivist in the ICU. And the diagnosis was SIRSI. What is SIRSI? It is critical illness related corticosteroid insufficiency. So what happens is that when the patient is prolonged hospitalized, there occurs hypercortisolemia, the cortisol binding globulin goes down, and that finally releases more free cortisol, and that suppresses the hypothalamic pituitary adrenal axis, and the patient may have a long period of critical illness, staying for a long period of time. There will be altered mental status and requiring very high vasopressure agent. How do you treat? Come to the right side. The right side is actually SIRSI, and they tell that clinical evaluation is important, and if the patient is presenting with some subtle features of SIRSI, you can actually start with hydrocortisone, 60 milligram IV over 24 hours, and you can see the response, and then you can taper it off. No need to do for a formal cortisol assay and STA stimulation test. Coming to few slides on newer alternative, there is also continuous subcutaneous hydrocortisone infusion, a very latest development where you give hydrocortisone by infusion pump to exactly match the physiological profile, but it has got many pros. Pros is it is physiological, but cons is it is not available, very expensive and experimental. Chronocort is another molecule which has dual release oral hydrocortisone taken twice a day. It actually helps in congenital adrenal hyperplasia, in improving the 17 OHP and the virilization potential. The another thing is Plenadren, where the formulation is a central, 2 slides more. So central extended release core and the outer immediate release formulation. And the advantage over Chronocort is that it has got better afternoon and evening cortisol mimicry in the pre-awakening surge. Now they are also coming out some glucocorticoid receptor modulators. For example, glucocorticoids which will be only active for inflammation, but they don't have any metabolic disadvantages, and probably that would be a game changer in the future, because the glucocorticoid which has been used by rheumatologists, by various specialties across the medical science, probably use this molecule to avoid the metabolic problems of glucocorticoid, that is fosdagrocort. So that is a dissociated glucocorticoid receptor modulator that preserves the GR mediated transmission of inflammation. It reduces inflammation but has got lesser chances on metabolic parameters. So coming to my last slide, so glucocorticoids are essential for life and disease. Aim for physiological mimicry is important. So whenever you are supplementing, just see that how you are supplementing and what time you are giving the glucocorticoid. Individualization is very important. Newer delivery system, what I was telling, and the receptor modulators may carry a targeted and brighter future for the glucocorticoid replacement. So with that I'll end. Thank you for the patient hearing.
Thank you very much. So it was a very wonderful talk. Now the house is open for questions.
Yes. Yes, sir.
Yeah, taking from your second bulleted point in the conclusion side, that aiming for physiological mimicry is important. Now, in adult patients with primary adrenal insufficiency, where preservation of the HP axis is irrelevant, but suppressing the ACTH drive is more important, what's your take on using, say, dexamethasone at night rather than, mimicking the circadian rhythm, except for the problem of, insomnia?
Yeah. So I think that's a very good question. So first of all, for adrenal insufficiency, we can mimic the physiological thing like morning, evening, like morning, afternoon and evening. The problem arises with CH, congenital adrenal hyperplasia, where we want to
Also
suppress the,
CH, yeah.
yes, where we want to suppress the ACTH more, and there are studies which has shown to reverse the chronology of giving steroids and give the night dose at a later part at a heavy dose. But again, they have not shown much advantage in giving that regimen versus giving it the proper or the ideal regimen what we give.
Yeah, as you said, that maybe problems with the insulin resistance and the metabolic effects may
increase.
May be there. So.
Right, sir. Yes.
I think in continuation of sir's question, so the last dose should be at 4 to 6 p.m. or you want to some hour before sleep?
Yes.
Is it like this?
Yes. So that's what I have shown clearly in that thing. So if you are giving a physiological glucocorticoid replacement, the first dose should be the maximum at awakening. The second dose should be 2 hours after lunch, and the third dose is 4 hours before dinner, so that you are not interfering with the sleep and the metabolic parameters. So how we remember is that it is 8 am, 2 p.m. and 6 p.m. So beyond 6 p.m. I think going it will produce more of sleep disturbances.
So one question. So when we are to stop a patient who is already on steroids, when we have to go for the synaptin stimulation test to see whether the adrenal axis has recovered or not, many of our patients are already on prednisolone, and do we need to switch all the patients on hydrocortisone when we stop it for 24 hours and go for synaptin stimulation test? But if a patient is on prednisolone, how much time duration do you need, for how much long do you need to stop prednisolone before going for a synaptin stimulation test?
So if someone is on prednisolone, then you have to change over to the short acting steroid and then stop for 24 hours and see for the cortisol.
If I don't want to shift to hydrocortisone.
So I think there is a study which has been recently published. So on prednisolone also with a physiological dose you can check the cortisol axis.
Sir, do we need to stop it only for 24 hours, 48 hours, 72 hours? Is there a time duration?
For hydrocortisone you can stop for 24 hours, but for
72 hours.
It has to be stopped for 72 hours.
Thank you, sir.
Even sir, there is a recent paper which has shown on prednisolone you can just check it. Yes.
So if there are no more questions, let's conclude.
Thank
you
very
much.
Thank you.
I request the speaker and the chairpersons to go to the check-up point area for felicitation. Now moving on to our next session, I would like to invite the chairpersons Dr. Kumar Anuj sir, Dr. Rohit Upadhyay sir and Dr. Vijay Kumar sir to the stage.
Our next topic is adrenal incidentoloma, which is quite common and difficult to treat. So Sir Nilanjan sir, Sir Gupta sir is here to take us through it. He is a very eminent speaker, and currently he is professor and head of Department of Endocrinology, Kolkata. So over to you, sir.
Thank you. At the outset, I thank Dr. Santosh Kumar Singh and the entire organizing team of the maiden Bendocon for making me a part of this excellent scientific program. My brief is a very common but an important topic in endocrinology, that is adrenal incidentoloma. Adrenal incidentoloma is maybe looked upon as a gift of modern imaging technology, and its incidence is around 5 to 7%, and there has been a tenfold increase in the past 2 decades for obvious reasons. Now, what is an adrenal incidentoloma? By definition, it's an adrenal mass, generally more than equal to 1 centimeter in diameter, discovered serendipitously during a radiologic examination performed for indications other than an evaluation for adrenal disease. Now, this is the distribution of how adrenal, what are the adrenal lesions that present themselves as incidentalomas. Fortunately, more than half are adrenal adenomas. Then there may be the benign adrenal lesions like adrenal cysts and myelolipomas. A considerable amounts may be pheochromocytomas. Fortunately, adrenocortical carcinomas are rare. Now, when we deal with an incidentally discovered adrenal tumor, two questions come to our mind before evaluation. Is the tumor malignant? Second, is the tumor functioning? Because these two features will determine the future course of therapeutic action. So, again, fortunately for us, about half of such incidentally discovered adrenal tumors are benign and hormonally inactive. About 40 to 45% of such tumors are benign and hormonally active. Adrenocortical carcinomas are fortunately rare, and so are adrenal metastases. So this is the decision-making paradigm in adrenal incidentalomas. First, we have to find out the functionality. Is it non-functioning, hyperfunctioning, or the nodule or the tumor is associated with global adrenal hypofunction? If functioning, whether we are dealing with Cushing syndrome, pheochromocytoma, primary hyperaldosteronism, or adrenal androgen excess. In rare situations, there may be coexistence of, say, Cushing syndrome with pheochromocytoma or Cushing syndrome with Conn syndrome. Then the biologic behavior, whether it's benign or malignant. If malignant, is if it is primary, or most commonly it's secondary, and these are implications on management. So what would be the first step? To perform an enhanced CT scan for all lesions which are more than 1 centimeter. If the size is less than 1 centimeter with no signs of clinical features of hormone excess, we can leave them aside and do nothing. So we have to look at the CT attenuation value in an unenhanced scan, and that is very important. For example, if you get a fat density throughout, that may be straight away a myelolipoma. So now let's come to the imaging phenotypes of the common adrenal tumors presenting as adrenal incidentalomas, starting with benign adenomas, which are the commonest. They are round and homogeneous, have a smooth contour with sharp margins, diameter less than 4 centimeter usually. They are unilateral. They have low unenhanced CT attenuation values, less than 10 Hounsfield units, have a rapid contrast washout, and chemical shift MRI shows presence of lipids, because typically they are lipid rich, but with the caveat that some of the adrenal adenomas may be lipid poor too. What's the imaging phenotype of adrenocortical carcinomas? They are irregular in shape, inhomogeneous in density, with maybe central areas of low attenuation owing to necrosis. They may be calcified, diameter usually more than 4 centimeter. That's why this will come to this 4 centimeter value over and over again. They are unilateral. They have high unenhanced CT attenuation values, typically greater than 20 Hounsfield units. They have inhomogeneous contrast enhancement on CT, and in the adrenal protocol CT, there is delay in contrast washout. And should an FDG PET scan be needed, they have a high SUV, being metabolically active lesions. Adrenal metastases are uncommon in the endocrine practice. They are more picked up in a surgical setting. They are irregular in shape and inhomogeneous in nature. About a quarter of them may be bilateral. As Dr. Das has been pointing out, the primaries may be lung, kidney, colon, breast, esophagus, pancreas, liver, and stomach. They typically have high unenhanced CT attenuation value. They there is contrast enhancement on CT scan, and there is delay in contrast washout, and again being metabolically active, they lit up on FDG PET scan. Pheochromocytomas account for around 1% of adrenal tumors. They have an increased attenuation value more than 20 Hounsfield units, and no pheochromocytoma has yet been reported to have an attenuation value of less than 10. So any tumor with a Hounsfield unit of less than 10 virtually rules out pheochromocytoma. They are vascular tumors. There may be delay in contrast washout. Cystic and hemorrhagic areas may be present. They are variable in size and may be bilateral in up to 10% of cases. Myelolipomas are not very uncommon, account for around 3 to 6% of adrenal incidentalomas. They are typically unilateral but may be bilateral in 5% cases. The size is variable, median size being 2 to 2.5 centimeter, but they may be indeed very big, more than 15 centimeter too. They appear cloudy or smoky in CT scan. They typically have a fat density in attenuation minus 30 to minus 100 Hounsfield units, but the myeloid tissue component can enhance on contrast administration. There may be punctate calcification too. So the baseline CT attenuation value becomes very important. Is it less than 10? So homogeneous appearance and less than 10 virtually rules out malignancy, and so also pheochromocytoma. Having said that, 1/3 of benign lesions would be having an attenuation value of more than 10, and about 7% of metastases and 1% of ACC may have a Hounsfield unit of 10 to 20. So there may be certain overlap here. After the CT attenuation value, next is the tumor size, as I was pointing to. Now, adrenocortical carcinomas have a median size of 10 centimeter, and more than 90% of them have a size of more than 4 centimeter, which is why we use this 4 centimeter threshold for therapeutic decision. But having said that, one has to also appreciate that myelolipomas may be indeed quite big, and 6% of masses are with more than 4 centimeter diameter are indeed benign. Again, the size doesn't matter if the attenuation value is less than 10. So what are the points to ponder upon? What is the attenuation value? What is the look like, heterogeneous or homogeneous, and what's the size like? So if it is homogeneous and size less than 4 centimeter, attenuation value 11 to 20, probably do nothing. On the other side, homogeneous with attenuation value more than 20, size more than 4 centimeter, maybe think of surgery. Heterogeneous, attenuation value more than 10 centimeter, more than 10 and size more than 4 centimeter, again think of surgery and or additional imaging. And if it is in between, then it is up to the decision of the treating physician whether to go for surgery or additional imaging. So this area is the most gray area. So I think this slide summarizes what, it's a busy slide, but this slide summarizes what we have said. So first look at the CT attenuation value, less than 10%, chance of malignancy is very less. 10 to 20% chance of malignancy is around 2%. More than 20% chance of malignancy is 10 to 20%. Now, with a low attenuation value, now look at the size. If the size is less than 4 centimeter, the chance of it being an adenoma is maximum. If the size is more, there may be a greater chance of other lesions. Again, unilaterality or bilaterality. When it is unilateral, chance of adenoma is maximum. When it's bilateral, you may even think of adrenal hyperplasia. Similarly, with the intermediate or suspicious adrenal mass, meaning that the CT attenuation is more, and if the size is more than 4 centimeter, that will bring in a probability of ACC being more. If the size is less, the probability will be less. Similarly, if it is bilateral, chances of ACC are indeed less. But if it is bilateral, it may be adrenal metastasis. So that's how you work out, and then we have to look at the functionality. We need to do a steroid profiling for ACC. We have to look for Cushing's. We have to look for Cohn's and pheochromocytoma. So how to follow up if surgery is not performed? The standard recommendation is a 6 to 12 monthly follow-up with imaging. And if there is increase in 20% size from the previous imaging, then it's a red flag sign. And we can consider additional imaging, and what that additional imaging is, that is for all practical purposes, is an FDG PET CT scan to see the functionality of the tumor. Pheochromocytomas and malignant tumors will lit up on FDG PET. Mind it, contrast washout and chemical shift MRI, these two imaging modalities based on the principle of relative content of lipid and water in the tumor, has become less popular with the radiologists because of diagnostic overlaps. So we can also get an adrenal mass in a patient of extra-adrenal malignancy. Now, if that extra-adrenal malignancy is known and the adrenals are imaged to find out in any metastasis, that technically doesn't qualify for it being to be an adrenal incidentaloma. But sometimes in surgical practice, these bilateral adrenal masses are picked up, and even in our department, in a series of adrenal incidentalomas, about say 2 out of 20 cases, that is around how much that is, 10% may still be having adrenal metastasis, especially in an elderly individual. So we have to look for relevant hormonal excess, we have to exclude pheochromocytoma, and then of course think of further investigation. Now, what would be that further investigation be? FNA. So image guided FNA is safe in an adrenal mass, but for doing that, prior exclusion of pheochromocytoma is a must. One must appreciate that FNA cannot distinguish between adrenal adenoma and carcinoma, and these are useful mainly in granulomatous lesions and infiltrative diseases, which are not uncommon in an Indian context. Coming to adrenal biopsy, this is rarely needed or rarely done, and you should think of considering adrenal biopsy only when 3 of these criteria are fulfilled. The tumor is hormonally inactive, not conclusively benign, and third point is most important, where you feel in your clinical wisdom that histology would alter the management. In many situations with the primary known and a metastasis to the adrenals, histology is not going to grossly alter the management protocol. So how do you look at the functionality of the tumor? Of course, this is out of scope for this talk, because these are big topics. For mild autonomous cortisol secretion, you should start with an overnight dexamethasone suppression test, and then go for other definitive tests, maybe ACTH, maybe late night serum cortisol or midnight salivary cortisol, and so on. For pheochromocytoma, you should look at 24-hour urinary fractionated metanephrine and normetanephrine. For primary aldosteronism, you would start with the ARR, that is plasma aldosterone and direct renin concentration, and sex steroid profiling may be needed in ACC. So how do you repeat the hormonal workup? So generally, you follow these patients if you are not doing definitive surgery with imaging, but if there are appearance of new clinical signs of hormonal excess, we have to repeat the hormonal workup too. And you have to also appreciate that less than 1% of MACS or minimal autonomous cortisol secretion progress to overt Cushing syndrome and followed. So the surgical approach, again, this is actually a headache of the surgeons, whether you go for a minimally invasive adrenalectomy or an open adrenalectomy is best left to the surgeons. As an endocrinologist, our main duty is to decide whether the patient needs or benefits from surgery. Now, just two quick cases before I end. Now, this is a case of, you can see, adrenal myelolipoma. We tell that no matter how big they are benign and they do not disturb. But if they are very big, especially more than 6 centimeter, there may be pressure effect, compressive symptoms, and hemorrhage. And therefore, even with a myelolipoma, even with a, say, Hounsfeld unit of, say, minus 300, sometimes we may have to offer the patient surgery. Second, these are two cases. One case is that of a 33-year-old woman with an adrenal lesion, 30 Hounsfeld unit, 3.2 centimeter in size, clinically and biochemically silent. Another person at 80 years having a tumor, having 13 Hounsfeld unit, but is bigger in size, that is 4.7 centimeter, both are clinically silent. What do you do? I think in the first case, since that woman is young, since the CT attenuation value is on the higher side, even if it is clinically silent, or even if it is smaller, one may decide upon intervention, surgical intervention, rather than watchful expectancy. On the other hand, in an 80-year-old man with maybe a life expectancy of 10-15 years, we can actually jolly well wait. So this is the simplified protocol. You do nothing more if the attenuation value is less than 10 and the tumor is non-functional. If the attenuation value is less than 20 and the size less than 4 centimeter, also do nothing, and you consider intervention in the other cases. To conclude, therefore, the main purpose of endocrine evaluation of adrenal incidentalomas is to differentiate the benign and harmless lesions from the malignant or potentially troublesome ones, and act accordingly, that is, submit the patient to surgery versus watchful expectancy. One should not miss subtle hormonal excesses. And lastly, in an Indian context, adrenal masses with granulomatous or infiltrative diseases with subtle hypoadrenocorticism should not be missed. Thank you for your patience.
Thank you, Dr. Sengupta, for the nice, illustrious presentation. We too are surgeon here. The other gentleman is endocrinologist. Whenever we get a case of endocrine incidentalomas, we usually bother for two things that, as you have already explained. I just want to know whether if it's a small mass, we are not suspecting malignancy, it's homogeneous and attenuation is less, and his patient is asymptomatic. How far we should go for functional assessment? Is it must, or we can dismiss at discharge?
No, that's what I said. There are protocols, there are recommendations. You have to individualize the patient. For example, if the CT attenuation value is in the fat density, myelolipoma, and not too big at no hormonal excess, we practically do nothing. There's no point in subjecting the patient to doing an FDG PET scan. On the other hand, if the size is too small, say less than 1 centimeter, with no apparent hormonal excess, probably we do nothing. Even in MACS, the progression to Cushing's and whether treatment of MACS does translate into metabolic benefits is under doubt. So actually we do nothing. Only question is whether we are missing Cone syndrome. That is one thing. The primary aldosteronism is something which is quite commonly missed. So there now the protocol for it's being said that all patients of hypertension should undergo adrenal venous sampling. Now that's the recommendation. I won't be doing. I myself am hypertensive, won't be subjecting myself to AVS, but that's the recommendation.
But as a surgeon, we find it practically very difficult to convince the anesthetist to be ready for the surgery, because it's a nightmare for the anesthetist to give anesthesia to the patient of adrenal tumor, suspecting if it is functional.
So if it is functional pheochromocytoma, you have to prepare the patient. Yeah. If it is non-functional, I think anesthetist wouldn't.
No, sir's question was, should we routinely go for all the hormonal evaluation?
Baseline, yes. Baseline, yes. I do, yes. Yeah. I think you are audible.
Okay. See, for Conn's syndrome, you may no longer need adrenal venous sampling with the advent of the pentixafor PET-CT, which has sensitivity and specificity approaching AVS. So that's a relief now.
I think that should be the practical approach. Doing an invasive test. So I think that should be the practical approach if you need to follow that up.
Yeah, I have done it on a couple of patients and it works very well.
Yeah, absolutely.
ये काम कर रहे हैं हाँ yes.
Yes, it's available.
I think this question is there.
I have 20%
AVS,
more than 6 centimeters, again rare. It can exceed that too. But the association with CH, what's your opinion on that?
Myelolipoma may be associated with CAH, but you are initially doing a clinical and hormonal evaluation. If there is CAH or even an NCCH, you will be picking up. The problem is that when in clinical and hormonal evaluation, the patient is absolutely okay, but still you are having the tumor, there the decision comes whether the myelolipoma should be removed or not. Again, if you think that the patient may be lost to follow-up, then you can encourage. But otherwise, even with bigger, I have shown just for example, but even with bigger myelolipomas, if the patient comes to a close follow-up, I persist with the conservative approach only.
Okay, and the adrenalectomy, which is to be preferred in the children, young adolescents, and less than 40, even in indeterminate lesions. Your opinion on that?
No, again, that is dependent basically on the suspicion of malignancy and hormonal excess. But what type of adrenalectomy that will be offered is a minimal access or open adrenalectomy. That is left basically to my surgical colleague for the best decision and best judgment.
But today, I think minimal invasive is the way forward. It becomes very easy. The anatomy becomes very discernible.
If that can be technically possible.
So now I think moreover now it's laparoscopy and robotics. Open is now past.
Easier laparoscopically than open, because in open surgery, when it's a functional tumor, you can't approach the vein without handling that vein. And once you handle that, there is the hypertensive crisis and all the phenomena occur. But in laparoscopy, after mobilization, you can directly keep the vein.
That's why I get to hear from my surgical colleagues, but if there is extensive, in a malignant tumor, if there is extensive local invasion or something like that, then I think you have to open, or then also...
No, if it is extensive with lot of involvement, then you have to do open, but in those cases, generally surgery is better to be avoided. I think any question is there, or we can conclude the session. I think it is a very good talk, enlightening talk by Dr. Sengupta, sir.
Thank you.
Thank you.
I would request the speaker and the chairpersons for proceed for the facilitation. For the next session, I would request the chairpersons, Dr. L.K. Prasad sir, Dr. Ranjan Kumar sir, and Dr. Manoj Kumar Chaudhary sir to come to the stage.
Oh, good evening. Our next session is on osteoporosis, and we have got Dr. Srinath Mukhopadhyay. Please, Mukhopadhyay. So the management of osteoporosis across life stages, and I'm sure that each of us sitting over here are confronted with this subject of osteoporosis right from the age of 20 years to menopausal or andropausal age. So I think it's a very important clinical subject. I invite Dr. Srinkant to kindly deliver the lecture.
Thank you, chairpersons, for the kind words. At the outset, I'd like to thank Dr. Santosh Kumar Singh and his team for inviting me to make a presentation past 6 p.m. on a weekend, which itself is a huge challenge to engage with the audience. Jokes apart, unlike the previous talks, please, you could switch on the slide, please. This is not the one. There is a presentation. So adrenals, primary adrenal insufficiency, then incidental, all difficult endocrine talks. And this is a very simple endocrine talk which is on osteoporosis. So what is osteoporosis? You have weak bones, the minerals are gone, and so are the matrices. And so should you fall, you break your bones. If you break your hip, there is a 20% chance that you die within a year. With a massive anterior myocardial infarction, you die within a year, your risk is 20%. Same. If you look at the kind of money that goes into the management of acute myocardial infarction vis-a-vis osteoporosis, you will see that the ratio is less than 20:1. You will see billions of dollars spent on preventing atherosclerotic cardiovascular disease and its outcome, and of course acute interventions for acute myocardial infarction. I will show you data that following an acute myocardial infarction, 80% of the patients get beta blockers worldwide for secondary prevention. Following a hip fracture, only 15% of the patients get an anti-osteoporotic intervention thanks to our orthopedic colleagues. So they fix the fracture and then they forget about it. Of course, they give some teriparatide or something like that for an initial period of a week to 6 weeks, and that's the end of the story. So people are left to suffer multiple fractures and eventually succumb. A 20 crore population in India are at risk of osteoporosis. And how do you screen osteoporosis? In people who have not fractured, you do a bone densitometry. To screen 20 crore people in our country, we have only 7,000 bone densitometers. So 7,000 instruments to screen 20 crore people. And 600,000 hip fractures are happening in the country annually, which we published very recently in the Archives of Osteoporosis. So here you are looking at fractured trabecular bone in a vertebral murine model, where you can see the osteoclasts there. So you have a damaged bone. So the osteoclasts are recruited. Where do they come from? Well, you have the capillary there. You can see the RBCs. So the hematopoietic stem cells come over and they are differentiated along the osteoclastic line. So the job of the osteoclasts is to remove F-head bones. How do they do that? I'll tell you in a moment from now. Once the dead bone is taken care of, you have these teal-colored osteoblasts lined up to repair the damaged bone surface. And what are the other teal-colored cells sitting over there doing? They are the osteocytes. So they are not inert cells, they are the mechanosensors. Following a trauma, when there is a fracture, actually the osteocytes sense the fractures. They release mediators which engage the osteoclasts. Once the damaged bone is removed, they shut off osteoclast function and they stimulate the osteoblastic bone formation. Right? So that's the story in a nutshell. Keeping this in mind, Santesh has actually asked me to talk about osteoporosis across lifespan, so which is, is a big ask for a 20-minute presentation. But then just remember two things. What is bone modeling? Modeling is formation of new bone in a growing skeleton. So this happens in adolescence, right? You get new bone formation. As opposed to that, remodeling is periodic replacement of damaged, destroyed bones in adults. So you have to remember these two things in mind. So your modeling, proper modeling would lead to acquisition of an optimum peak bone mass. So you develop a bone bank in your system, and even if you lose bone at a steady rate post-menopause, your risk of having a fragility fracture is substantially reduced because you have started your life with a good peak bone mass. So that is your modeling. Remodeling issues come into the picture when you have postmenopausal bone loss, or you have other factors like autoimmune disease, rheumatoid arthritis, diabetes, glucocorticoid overuse, hypogonadism, and certain chemotherapeutic agents. So they all cause bone loss. There are some common drugs also. I will share that with you in a moment from now. That can lead to excessive remodeling problem. So here you are looking at the acquisition of peak bone mass, which actually occurs between 20 and 30. So here lies the importance of nutritional diet, high protein, high calcium and vitamin D, and physical activity. In our country, you will see computer classes having been replaced, physical education classes having been replaced with computer classes, right? So adolescents hardly have time for physical activity. The largest school in Asia, South Point School, Kolkata, doesn't have a playground of its own. And we are talking of building up peak bone mass to prevent osteoporotic fracture in the later life. So here between 20 and 30, you acquire peak bone mass, and then past the age of 30, it's all a story of relentless bone loss, right? So your age-related bone loss is around 0.5 to 1% per year, which is accelerated at menopause to 1 to 2% per year, and this accelerated bone loss continues for about 5 years post-menopause, and then you go back to your previous age-related bone loss. By the time you were 90 years of age, your bone mass is back to that of
a 10-year-old child, right? So just imagine the fracture risk in a 90-year-old, which is 80%. Okay, so your fragility fracture develops if you have a low peak bone mass or an accelerated bone loss, or worse still, a combination of the two. So this is what I was talking about. If you start with a good peak bone mass and then you lose at a rate of 0.5 to 1% per year, your risk of having a fragility fracture is much less than when you start with a low peak bone mass, even if you are losing bone at the same rate. So that's how osteoporotic fractures happen in women. The vertebral fractures are more common, while trabecular bone, where you get the vertebral fractures, vertebra consists essentially of trabecular bones, while they consist of 20% of the total bone mass, they account for 80% of bone turnover. So whenever you have a high bone turnover state, you have more vertebral fracture. Men also have higher vertebral fracture, but past the age of 70, there is a sharp increase in hip fractures as well, and hypogonadism contributes to a significant extent here. Now, if you are relatively younger, say between 60 and 70 years of age, so your protective mechanisms are still intact. When you slip on a slippery floor, you tend to fall forward and you break your wrists. So Colles fracture, relatively innocuous, not life-threatening. When you are older, you have a compromised protective mechanism, so when you fall sideways and end up breaking your hips. I will skip that. Time is running out. So death within 1 year, 20%. I told you about this. And this shows the survival plot in men and women. You can see hip fractured women and hip fractured men, they have such a high mortality. Very interestingly, if you look at the burden of heart attack, stroke and breast cancer taken together in postmenopausal women, that they add up to much less than the annual incidence of osteoporotic fracture. And again, going back to the budgetary allowances, funding to treat them, prevent them, in billions of dollars, and here it is not even billions of dollars worldwide. So lack of awareness is there everywhere. Absolute lack of awareness leading to preventable fractures not being treated. This is how on T-score you classify osteoporosis. In children, we do not use the term osteopenia. We call it a low bone mass, unless the children have long bone fractures. It's very interesting to note that the fracture rate increases as the bone BMD gets lower and lower. There is no surprises there, but the BMD, as you know, is normally distributed. If you look at fractures in women with osteopenia, you'll see this is far outnumbering fractures in women due to osteoporosis. And this is simply because of the fact that there are more women with osteopenia than with osteoporosis. Osteopenia being a much commoner disease than osteoporosis, right? So 20% have a second vertebral fracture within a year following a vertebral fracture. Fracture begets fracture. This I alluded to you before. 80% getting beta blockers as a secondary prevention strategy following acute myocardial infarction, 15% getting treatment for osteoporosis. So such a huge therapeutic gap. Vertebral fractures are missed. You do a CT scan of the chest, patient is admitted with pneumonia, and see, they have fractures. This is a retrospective study. Half of them are missed by the radiologists. Then, even if they are mentioned by the radiologist, they are not mentioned in the discharge summary. And then again, at the end, only 7% of those patients with unrecognized vertebral fracture, which is there on the chest CT scan or X-ray, they eventually get treated. So we are under-diagnosing vertebral fractures or osteoporotic fractures. So how do we improve upon this? Is there a way out? This is the recent data from University of Southampton using AI. Like our Prime Minister Narendra Modi said the other day at his opening remarks at the AI Global Consortium for Sundar Pichai was there to pitch AI. So vertebral fractures, so many cases were picked up by AI when they were given the same set of chest CT scans and X-ray. So AI is not actually antagonizing us, it's helping us. Hospital is happy, they're picking up more patients, treating them, generating income, doctors are happy, patients are also happy, so it's a win-win situation. To add AI into your diagnostic armamentarium to pick up unrecognized vertebral fractures, so you detect hypertension with your sphygmomanometer to treat and prevent stroke, detect diabetes blood glucose, treat to prevent retinopathy, and similarly, you need to do a bone densitometry to prevent fracture. Whom to treat? This is our ISBMR recommendation. Major osteoporotic fracture is more than 10.5%, hip fracture is more than 3.5% if you do a DEXA. Anybody who has suffered a fragility fracture does not need DEXA to initiate treatment. So this is our guideline. Indian patients are a little different. We developed osteoporosis a decade earlier. Our major osteoporotic fracture is more cost effective to treat. So the threshold is lowered from the Western cutoff of 20% to 10% here, whereas hip fracture is relatively expensive to treat, so the threshold is elevated from 3% to 3.5%. Okay, now going to back to treating, how to treat adolescents. So it's encouraging to see that no matter whether the adolescents are deficient in calcium at baseline or they are calcium replete, giving them calcium leads to a similar increase in BMD. What about vitamin D? What about physical exercise? Again, all forms of physical exercise, they help in acquisition of bone mineral content. What about vitamin D? Vitamin D is not here. So, but then when you go to postmenopausal women, giving them calcium alone, vitamin D alone, or a combination of calcium and vitamin D do not have any impact on preventing fragility fracture. So they work in children in building up your bone bank, not in adults. You need specific intervention to treat osteoporosis. So, but the fall prevention remains the most cost-effective strategy. If you don't fall, you don't break your bones. Simple. So these are the fall prevention strategies. Non-pharmacological interventions. Yes, get your cataracts removed. Get some strength training. Improve your balance. Keep the bathroom floors dry. Put up grab rods in the bathroom and so on. HRT actually is no longer used, although it's impressive results in terms of reducing vertebral fracture and hip fracture because of significant side effects. Calcitonin is only an analgesic used only in orthopedic practice, not in endocrine practice, because it does not have any fracture prevention data. So this summarizes the efficacy of osteoporosis treatment. You have the bisphosphonates, which are called accumulating agents because they accumulate in the bones. So once you stop them, should you think of stopping them, there is not a rebound increase in the risk of fracture, unlike denosumab, which is a non-accumulating agent, and if you stop it, there is a rebound increase in the risk of vertebral fractures. Then of course you have the anabolic agents, teriparatide, abaloparatide, and romosozumab, which are preferred to treat severe osteoporotic fractures. I don't have the time to take you through these mechanisms, how osteoblasts and osteoclasts are recruited, but bisphosphonates work here. They enter the bone and they prevent osteoclast activation. Denosumab actually is a humanized monoclonal antibody against rank ligand, prevents rank ligand binding to rank receptor on osteoclast, so preventing osteoclast activation. This is zoledronic acid data from Ian Reid from Auckland, New Zealand, showing robust efficacy in terms of prevention of fracture. Running out of time, so zoledronate stays within the system, as you can see. So comparison shows denosumab to be superior. I'll skip some of these. The side effects I don't have the time to cover. Only 4 seconds left. Okay, so let's go to the clinical pearl, the last slide. This is actually a 30-minute talk. So, yeah. So screen women in their 60s, men in their 70s, that's the Western cutoff. In India, we recommend that you screen men from 65 above because osteoporosis sets in a little earlier. Calcium should come ideally from diet, not through calcium supplementation in the form of tablets, because giving calcium from outside may unusually increase the risk of atherosclerotic cardiovascular disease. Recent BMJ paper, so should come ideally from diet. Vitamin D, inhaled and frail elderly. Potent bisphosphonates are the mainstay of treatment. After 3 to 5 years of treatment, you give them a drug holiday for 1 to 2 years, and then depending on the situation, depending on the kind of improvement, think of restarting. Bone marker, this is a bone formation marker, which is needed only with oral agents, not with the injectables. Denosumab is well tolerated, but as I said, it has a rapid offset of action. You cannot stop it. Suppose you have a patient on denosumab and the patient is not responding well and you want to shift her to another agent. There should be an overlap period of at least 2 years. Otherwise, you stop denosumab today and start romosozumab or start teriparatide, patient will have a rapid bone loss. So overlap period of 2 years, and then you take the patient off denosumab. Abaloparatide data, no time to share, so I'll go to the last slide. Yeah, every 30 seconds, someone suffers a hip fracture as a result of osteoporosis, an eminently treatable condition. So I call everyone, so for this call to action, it's never too late to diagnose osteoporosis. With this, thank you everyone for listening. Thank you.
Thank you for a nice talk on the osteoporosis. It's one of the commonest disease, more common than the MI infection and other things. More persons are involved. Problem is, it is a silent disease. Have to go for the BMD for diagnose it, unless until you are getting the fracture, and always try to find out the secondary causes. You correct them, then the treatment is prolonged. So any questions from the hall?
I had a mic down.
Short-term PTH over after the surgery, many of the orthopedics guys are giving for the 3 month or.
There is no such guideline, only stray case reports. So there is actually no recommendation that you use teriparatide short-term to enhance fracture healing. Thank you.
Short-term is no. If oral biphosphonate or IV phosphonate patient is not able to take, then they go for the teriparatide.
Yeah,
so short-term is not the thing.
No, if you initiate teriparatide, then you should continue this for at least 2 years. Now you have data for 4 to 5 years of teriparatide. See, the problem is
after 2 years, if the things are not going up, then going down, then what to do?
Then they qualify for another course of teriparatide if the osteoporosis is of a severe nature, or if the patient is not able to afford romosozumab. An year's therapy costs 3 lakhs of rupees, but it's more potent than teriparatide any day.
Denosumab, I think cost has decreased much. Oh.
Denosumab, yes. Now it is more affordable.
More affordable.
See, the problem is, in the Western world, you have a fracture liaison service. So patient gets admitted in orthopedic, the fracture is fixed. Before discharge, the patient is referred to the fracture liaison service. And they guide the patients to endocrinologists or whoever most suitable to treat osteoporosis in the long term. Fracture liaison service has been a failure in India. They tried in Mumbai, Nara Hospital, PGI Chandigarh, I tried this in Kolkata. So, but
10 years earlier in the Indian scenario.
Yeah, so
in comparison to the Western, it is 10 years earlier.
We simply don't get referrals from our orthopedic colleagues. Okay. There is a hip fracture, they will refer the patient to us for a fasting sugar of 130 or TSH of 6.5, whether the patient is fit for surgery. TSH of 4.8, they will refer. They will never ever refer for management of osteoporosis. And the patient suffers a second fracture. That's a tragic story, but that's the ground reality.
Sir, good evening, sir. Sir, my question to you is, sir, as you said that giving high doses of calcium in an individual can increase the risk of atherosclerosis. So, sir, is this only for a particular age group, or it is applicable to all age groups?
No, not in the young age group. This is all referring to postmenopausal women.
Sir, and if so, then what are the things we should look out for before supplementing calcium, and what are the precautions or additional supplements we should give along with calcium?
The first thing is, patient should be getting calcium supplements only when she is calcium deficient. To maintain bone health, to prevent osteoporosis. Calcium has no role in postmenopausal women. If you wish to increase calcium in the system, you should do it from the diet and not from tablets. That's the message.
Thank you, sir.
Yes, just right, my turn.
Yeah. Sir, in postmenopausal women, suppose you have given the anabolic for 2 years, followed by the anti-receptive for 2 to 3 years. Then what to do now? No fracture, no fragility fracture or no fracture.
The point is how the patient is responding. You don't
in terms of DEXA.
You don't expect much of improvement in hip fracture with teriparatide, given the data that we have.
Yeah.
We now have better data with abaloparatide. With the advent of 3D DEXA, it shows a much better response in hip fracture also compared to teriparatide. Point is, if the patient is not improving, then your choice is now romosozumab.
Yeah,
it's a very, very potent drug, dual action, both anti-resorptive and anabolic. And you give the patient romosozumab for a year, but don't stop denosumab if she's already on denosumab. The rapid bone loss. After a year, then you have to think of another course of an anti-resorptive agent. So now we have 15 years data from Ian Reed's group, published recently in NEJM. Okay?
Okay, sir.
In ankylosing, it is difficult to get the spine DEXA reports. Okay. So which one to rely for them? Hip or anywhere else?
Hip.
Hip only. In the ankylosing, spine will get always the...
Yeah, for elderly, spine is very, very unreliable.
In ankylosing spondylitis.
Ankylosing spondylitis, avoid the spine, go for the hip.
Yeah. Thank you very much.
Thank you. Thank you so much.
I would request the speaker and the chairpersons to proceed for felicitation. For the next session, I would request Dr. Ravi Kirti sir and Dr. Neeraj Sinha sir to chair the session.
Face the camera. Thank you. Thank you.
Good evening. So we have another topic which is of great clinical relevance to all of us. I think irrespective of whether we are endocrinologists or physicians or orthopedic surgeons, we are all dealing with patients of vitamin D deficiency and treating them every day. So it's a good idea to get ourselves updated. And so to talk on the clinical practice guidelines for vitamin D deficiency, we have Professor Jayashree Swine. Over to you, madam.
Very good evening, everybody. Thank you, Chairperson, for this nice word of introduction. Thank you, Dr. Santosh sir, Dr. Ved, Dr. Anand, for giving this opportunity. My topic, after good discussions of endocrine topic and osteoporosis, it's a nice discussions regarding the osteoporosis across this lifespan. My topic is vitamin D deficiency, clinical practice recommendation. I will try to cover within 20 minutes. So, as we know, vitamin D deficiency is highly prevalent all over the globe, so also India, despite of this tropical latitude. And approximately 40 to 50% of the populations had vitamin D deficiency, and another 25 to 30% had vitamin D insufficiency, and all total it will be 70 to 90%. So, urban indoor lifestyle significantly limit the ultraviolet B exposure. Hypovitaminosis D often remain asymptomatic initially, and skeletal till now, skeletal consequences are evidence-based indication for this correction. So, in this background, population-specific targets are necessary in this Indian setting. It is not this vitamin D deficiency is not prevalent only in the adult. There is a systemic review and meta-analysis which is published in 2020, which shows that there is high burden of hypovitaminosis D among the children and adolescents in Southeast Asia. If you look to the Indian scenario, around 64% of the Indian children and adolescents are suffering from this vitamin D deficiency. Why it is so? There is a lack of awareness, knowledge and awareness regarding this vitamin D deficiency, disease and symptom, and there is inadequate exposure to this ultraviolet light, sunlight, and there is lack of knowledge and awareness regarding the natural and dietary source of the vitamin D, and asymptomatic and subclinical nature of the vitamin D deficiency. This may be the cause where we are getting such a large numbers of vitamin D deficiency, or the prevalence of this vitamin D deficiency is very high in India. So then how we will define this deficiency? There are so many bodies, so many international societies, national societies, they are defining this vitamin D deficiency. If you look to the Indian Endocrine Society and that of institutes of the medicines and Brazilian Endocrine Society, and also the consensus group of 11 endocrine society, most of the guidelines they divide vitamin D deficiency, vitamin D deficiency, insufficiency and sufficiency into 3 categories, and they are taking 20 Ng per ml as this deficiency, 29 up to 29 is insufficiency, and more than that is sufficiency, except that is the consensus of scientific organization, 11 scientific organization. If you look to the Endocrine Society of India recent, it is only defined the adequate level of the vitamin D, that is 20 to 40 Ng per ml is adequate, and it is silent regarding this deficiency and insufficiency. Similarly, Institute of Medicines, they is also silent regarding this insufficiency, vitamin D insufficiency. Why Endocrine Society of this India is not giving their opinion regarding deficiency and insufficiency? Because these newer guidelines, they focus on the clinical contest and that of the individual risks rather than this number, particular number which is causing this insufficiency, deficiency or sufficiency. This is the beauty of these newer guidelines. They classify this vitamin D. So when something is a deficiency, then what is the effect on the gland organ? So also vitamin D, there is decrease in absorption of the calcium and lead to the decreased ionized calcium and increase in the parathyroid hormone causing secondary hyperpara. Increase parathyroid hormone leading to the activations of the osteoclast, increase this number and activations of the functionality leading to the low bone matrix and the mass and low bone then leading to the osteoporosis, what has been discussed by my previous speaker. And again there is a decrease in absorptions of the phosphate. Along with that, increase PTH is phosphoturic, so increase phosphate excretion, decrease phosphate absorption, lead to inadequate calcium phosphate hydroxyapatite and mineralization defect, and it will lead to the rickets in the children and osteomalacia in the adult. So what is when to suspect when somebody is suffering from this vitamin D deficiency? As you know, it is in children. There is delayed in this growth, walking is delayed, bowing of this leg, frontal busing, widening of this wrist and hypotonia. By that we can suspect. But in adult, there is diffuse bone pain, proximal muscle weakness, fatigue, recurrent fall, fragility fractures and delayed fractures healing are seen in the adult. We all know, still then I am repeating that. So then next point is whom to screen this vitamin D deficiency. If you look all these guidelines, routine population screening is not recommended due to biological variability, low yield and economic burden. None of these guidelines they advocate this routine screening. So you can avoid this screening in healthy adult, dark complexion, obesity and pregnancy. Then who are these persons who you are going for this screening? This is called this high risk group, and screening is very much essential in that group. Limited sun exposure, those who have the CKD, CLD, malabsorption syndrome like celiac, irritable bowel syndromes and after bariatric surgery or long term use of the glucocorticoid and other drugs like that anti-epileptic, phenytoin, carbamazepine and immunocompromised patients or low bone maintenance, those who have the osteoporosis and low bone mass and recurrent fractures. These are the suitable patients. You may go for the screening of the vitamin D. Next point is, can somebody help me? The next is what are the investigations? I think slides are not, yeah. The next what are the investigations you want to do? So along with the 25 hydroxy vitamin D, some basic investigation is required for our diagnosis, like that of the serum calcium, phosphate, alkaline phosphatase, serum albumin for corrected calcium, and in some cases bone mineral density and X-ray is required, and some other investigations like that of the RFT, LFT, and that of the malabsorption celiac tissue transglutamase is required. It is for this investigation to rule the secondary cause. I think some defect is there and it's not, the slides are not moving. So next, then what are the tests you want to do and what is the assay? The test you have to do 25 hydroxy vitamin D. Can you move the slide? The next test is this vitamin 20, you can go for the 25 hydroxy vitamin D measurement, and this process is antibody based assay. It may be this chemi or this, yeah, no, it's not moving. It may be this chemi or maybe this immunometric assay, yeah. Immunometric assay or by the LCMS, liquid chromatography tandem mass spectrometry. So LCMS may be this method is having greater accuracy and consistency, and it is preferred reference method for the estimations of this vitamin D. The result of this test must include a clear stated unit that may be, it may be the Ng per ml or the nanomole per the liters, and the assay standardization is very much essential for a reliable report. So if you are doing this with the vitamin D estimations with this immunoassay, then what are these defects? That moderate accuracy, it is cross reactivity with the other vitamin D metabolites, and it cannot reliably distinguish between vitamin D2 and the D3, and the performance varies by the manufacturer, and it may misclassify near the cutoff value. So these are these demerits with that of the other method. So LCMS is the preferred methods. So after this deficiency, after the test, then what we will do? Supplementation. It is the prevention and treatment of this vitamin D treatment in India by this expert consensus group, and Professor Jargar sir is the one of is the author here, is the corresponding author. Sanjay Karla sir, myself is there, and Dr. Sandeep is also one of the endocrinologists among this group. So what we will do? If someone is having vitamin D deficiency, after the lifestyle modification, you can go for the diet, adequate sun exposure, diet rich in the vitamin D, calcium, and that adequate exposure, you may go for the adequate calcium supplementation and start with vitamin D. At what dose? 60,000 international unit for week for the 16 weeks, and followed by that after 16 week, after 12 week, you may go for the you may locate the clinical and biochemical response. If it is satisfactory, then you go for the monthly dose. If you are not satisfied with the recovery, then you can repeat for 8 weeks, and then you reassess. If vitamin D insufficiency is there, along with the same lifestyle modifications, you can start this weekly dose up to 8 weeks. And if vitamin D sufficiency is there, you can do this lifestyle modification, and once monthly supplementation of 60,000 vitamin D is required. Along with that routine follow-up in all the group is recommended by the Indian expert consensus. So next point is that what are these different forms of this vitamin? Apart from that, we are supplementing. We are supplementing cholecalciferol, that is vitamin D3, and ergocalciferol sometimes we are giving, that is vitamin D2, when that is, it is the plant source. When that is some ethical backgrounds, in that case we are giving ergocalciferol, and calcitriols when that is the advanced kidney disease and hypoparathyroidism, we are giving calcitriols, which is the active form, and alpha calcitriol is sometimes we are giving in the kidney disease, and injectable, when malabsorption is there, we are giving the injectable one, and single injections of 3 lakhs to 6 lakhs is adequate, but the risks we should monitors, and repetition is not required at this point. So how to monitor that response of the treatments? After the reassess clinically and biochemically. If there is satisfactory response after 8 to 12 weeks of supplementation of weekly vitamin D, then you can go for the symptom improvement, or by the 25 hydroxy vitamin D. If level is more than 30, sometimes we are going for the PTH, and PTH is suppressed to the less than 65, then monthly maintenance dose of the monthly 60,000 international unit is required. If it is, you are not satisfied, unsatisfied response, symptom improvement is not there, and vitamin D level is still low and PTH is still high, then you should give the loading dose again, and check the cause, compliance of the drug, malabsorptions, and review these medications, what are these medications that is interfering with the absorption. The next point is that calcium supplementation, what has been discussed just before my presentation. When and how calcium supplementation is required in these vitamin D deficiency patients. These clinical situations like nutritional deficiency with low dietary intake, osteomalacia, osteoporosis, postmenopausal women, elderly more than 65 and hypocalcemia. The calcium supplement, adequate calcium supplementation according to the RDA is required in that groups. And if somebody is taking adequate dietary intake, these patients may not require additional supplementations. So this is the most important information still now from this guideline. So next point is extraskeletal manifestations. So as you know, this skeletal manifestation is we are discussing so many times regarding the rickets, osteomalacia, osteoporosis, and so many other things, fracture. But extraskeletal manifestations of the vitamin D deficiency is very much important, and nowadays it is coming to these fields. It may be connected with the autoimmune diseases like cardiovascular, respiratory diseases like heart failure, pneumonia, hypertension, and impaired muscles, sarcopenia, muscle weakness, and obesity, diabetes, cancer incidents, and mortality. In all cases, if there is vitamin D deficiency is there, quality of life is decreased and this mortality is increased. Then what is the recommendations regarding extraskeletal manifestations and supplementations? So from all these guidelines, whatever is available till now, there is proven benefit for the skeletal health, but extracellular benefit remain uncertain. So again, another important thing is that vitamin D supplementations may delay the progressions of the pre-diabetes in deficiency patients, but it does not consistently prevent the type 2 diabetes. So no clear reduction in the major cardiovascular event in the large trial. In short-term trial, we have noticed that there is beneficial effect, but in large scales, there is no extra benefits. And again, it may reduce the acute respiratory infection, especially in the patients, those who have the deficiency. Another important thing is that there is observational link with the autoimmune disease, neurocognitive disorders, but the therapeutic role is unproven till now. And if you look to the D-Health trial, the overall rate of this major cardiovascular event, particularly myocardial infarction and coronary revascularization, was lower in the interventional group when compared with that of placebo. But the absolute risk difference between the two was very small. So, to conclude these extraskeletal recommendations from all these guidelines, vitamin D should not be prescribed solely to this extracellular indication without any deficiency. The next point is how much vitamin D to be replaced. If it is infant, the target levels in almost all these guidelines are more than 30. In Indian consensus, it is 40 to 60. The physiological levels they have given 40 to 60 Ng per ml. So in infant, if it is sufficient, 400 IU daily. If it is deficient, 2000 IU, and the maintenance dose is 400 IU. And in children 1 to 10 years, 1 to 3 years, if it is sufficient, it's 600, 600 to 1000 in 4 to 10 years. If it is deficiency, it is 2000 as before, or at this point you can start 60,000 international unit weekly for 6 weeks. In other case, you can give 8 week or 12 week, but in children you can it is up to 6 weeks, and maintenance dose is 600 to 1000 unit. And in adolescent 11 to 18 years, if sufficient, the dose is 600 to 100 units. If deficiency, it is just like of the adult, 6 to 8 weeks, and maintenance dose is 1000 unit for day. And in adult, it is equals, if somebody is sufficient, 800 to 2000 unit per day. In deficiency, it is 8 weeks, severe deficiency, it is 12 weeks, and the maintenance dose is 1000 to 200 international unit, or otherwise you can give 60,000 unit monthly. This is the recommendations, and it is little, just 1 or 2 slides. So it is just, if you look to the pregnant woman, that is more or less it is equal to that of the adult, but it is deficiency, you can prescribe up to 12 weeks. Pregnant women and elderly more than 65 are equal supplementation is required. So what are the high risk group where this more amount of this vitamin D supplementation is required? This is the conditions like this CKD, CLD, malabsorption syndromes, those who have the cerebral palsy, neuromuscular disorder, chronic use of the glucocorticoid, epileptic drugs, or this disease with extensive cutaneous involvement. And in obesity patients, they may require 2 to 3 times of the higher dose from that of the adult. And in chronic kidney disease, calcitriol is required, and glucocorticoid therapy, the maintenance dose level should be more than 30. So, if you look to this IOM recommendation and in Endocrine Society recommendations, IOM recommendations varies from 400 to 800 and starting from infant to that of the elderly. Elderly, you can more than 70, you can prescribe 800. If you look to the Indian Endocrine Society, the daily requirement varies from 400 to that of the 2000 international unit. So, empirical recommendations of this vitamin D, they have new recommendations what I have found in these guidelines. So, you can prescribe children and adolescents, adult more than 75 years, pregnant individual, high risk pre-diabetes. In this group, you can give this empirical vitamin D. And in all adult less than 75 years, and if it is healthy, no recommendations, no empirical treatment is required. In all groups, no test is required, just last take home message. So, if after my discussions regarding all these guidelines, so my take home message or clinical poll from all these guidelines, vitamin D deficiency is highly prevalent all over the world and clinically significant. Serum 25 hydroxy vitamin D is the diagnostic marker. Sufficiency in practice is defined as more than 30 nanogram per ml. Nutritional deficiency treated with cholecalciferol. Standard adult replacement dose is 60,000 international unit weekly for 8 to 12 weeks. Maintenance is 60,000 unit monthly. Calcitriol is only reserved for advanced chronic kidney disease and hypoparathyroidism patient. Severe deficiency when it is less than 10 require closer monitoring. Children require universal prophylaxis with 400 to 600 international unit daily. Postmenopausal and elderly individuals require fracture focus supplementations. Routine population screening is not recommended by any guideline till now. Thank you for your patience here.
Thank you, ma'am, for such a deliberate enlightenment on this topic of vitamin D. Now, this house is open for any questions. Yes, please.
Ma'am, patient asks what should be the exposure timing, and what should be the area that should be exposed for gaining vitamin D in our part of world.
It's the time between according to the Indian consensus, the time between 10 a.m. to that of the 3 p.m. 15 to 30 minutes exposure of the arm, leg, face and back is sufficient, and it will produce 1000 to 3000 international unit of this vitamin D.
Is that you supplement 60K every weekly for 8 weeks, then the patient becomes sufficient, then you go for once in a month. So for how long?
I have searched for these literatures. There is no in recommendations. I think there is no such 1 year, 2 year, 3 year. I have not found. Sir, Jargar sir will answer. Satinath sir will answer that things. Yeah. That is, sorry.
Fundamentally, you know, many times whenever we say diagnose authentically a vitamin D deficiency, we never try to find out the cause of it. either nutritional or total indoor life. And we never concentrate on that. As Satyanath was telling about even osteoporosis, treat the fracture and forget about the quality of the bone that you're underlying. If you correct vitamin D deficiency, you also need to correct the lifestyle which was responsible for it.
Cause of
if you are not able to correct it, then continue cyanide eye. If you are able to correct it, then stop it. Measure it and stop it.
Thank you, sir. Thank you. We can conclude the session.
I would request the speaker and the chairpersons to proceed for felicitation. For the next session, I would like to invite Dr. H.K. Singh sir, Dr. B.K. Singh sir and Dr. Ejaz Alam to chair the session.
Good evening to all. Dr. Abdul Hamid Zarga sir is widely regarded as father of modern endocrinology in Kashmir. Sir is leading expert in pituitary and metabolic syndrome. And in Bihar, we know here postpartum hemorrhage remains prevalent. So revisiting Sheehan syndrome is important both clinically and academically. With these notes, we welcome sir for sharing his insights on Sheehan syndrome. Thank you, sir.
Professor Jagar is more known to me since I think more than 30 years.
Absolutely, sir.
He needs no introduction. He is my good friend, young friend. Sheehan syndrome to the Jagar.
A very good evening to a very fatigued audience. Fatigued with time and fatigued with some intense knowledge about endocrinology. And in the next 20 minutes, we'll be talking about how our own concepts in one of the commonest pituitary disease in developing parts of the world developed Sheehan syndrome. One day, when I was doing my DM, on Tuesdays we used to run a medical OPD. And all those people who were the direct recruits of PGI, we had to give an emergency night once in fortnight. And one day this fortnight fell on a Tuesday. And there was a guy, a junior resident in emergency, a Kashmiri young doctor. He said, Dr. Zargar, why do you want to see this patient? This lady every day comes from Saharanpur. In the last 3 months of my posting, she got admitted thrice for recurrent diarrheas. Why did we admit him under endocrinology? Because on Tuesdays we used to admit all cases and then shift him to her to gastroenterology. I said, I need to see her. I need to have a justification to admit her because endocrinology at PJ did not have huge beds. So after I got cooled down from the emergency round, I went there, examined this patient, and I found she had frank hypothyroidism and she had hypertension. And I just had one question. She's a youngish lady, 38. Menses hota nahi, 10-12 साल से नहीं होता है. मैंने कहा, this is not a gastroenterology case, this is our own case, the Shyam syndrome. It's the first case I saw as a diagnosis in an emergency on my own. Now, you know, many of us know that you need to destroy a substantial amount of an endocrine organ to cause hypofunction. You see, like you remove 3 parathyroids, you will not have a hypoparathyroid state. You remove an adrenal gland, you will be eucortisol. You remove half the beta cells, if you ensure other half beta cells are going to be there, you will not develop diabetes. You develop one gonad, you remove one gonad, you will not have an endocrine dysfunction. So you need a major insult to pituitary, and on an average it was believed you need to destroy more than 75% of the pituitary gland to cause a either complete or partial pan-hypopit state. And there are many predisposing factors for that, because during pregnancy the pituitary increase in size, particularly lectotrophs, not corticotrophs, lectotrophs predominantly, and gonadotrophs, and the size is huge. And the portal circulation that supplies it is a very low pressure. It's not our arterial circulation, it goes under pressure of 140, 120, it's a low pressure. Anytime there is a fall in the blood pressure, the amount of blood needed for maintaining this double or triple size of this pituitary is lost. So there is a necrosis. Like, you know, when you deprive a vascular supply to heart, you get a myocardial infarction. You deprive this pituitary, enlarged pituitary, of its supply, it gets infarcted. This is the only epidemiological study done on Shyam syndrome, because it's not possible to do an epidemiology of Shyam syndrome, which we published about 2 decades back, which told us that the load of postpartum, we now don't call it Shyam, postpartum pituitary dysfunction is huge. A lot of critique, a lot of discussion over decades in endocrine circles, and this can tell you that lactotroph function, gonadotroph function, corticotroph function can be quite variable. At any given time, you see the patient, you can have one hormone deficiency through a couple of hormone deficiencies, and you don't have a tumor there, and you have a history of a bad obstruction. And even if you do not have a history of a bad obstruction, chances of a postpartum pituitary dysfunction. And this was one of the first papers that, when first time we published the data, that I still remember that one of my colleagues, who later became a professor of endocrinology, I asked him, are we truly making these diagnoses rightly? And then we revisited all these 86 cases and their investigations. Many cases, you know, where we had doubts, we did not publish them. We did not. Now, in this process, you know, where we're looking at, one of the first things that happens with Shyam syndrome is if you have a pituitary dysfunction. Shyam is like a stroke. So basically the maximum should occur initially. It's a vascular stroke. So one of the first things that people notice is a lack of lactation. One fine day in my home in Baramulla, my hometown, one young lady came that she had second child, she had not lactated. And I said there's some unusual form of Shyam syndrome, and we admitted her and evaluated her. We used to do a multiple stimulation tests, insulin tolerance test, chlorpromazine test, metchlorpromide test, at the cost of national exchequer. So we could become good academicians at the cost of the national exchequer. And then she went home, because it used to take 2-3 weeks for the test to come. One day I was sitting in the library, and I picked up an issue of fertility sterility. And there was a paper, there was an editorial on what is the biology of prolactin. And said that is extremely difficult to know, because isolated prolactin deficiency is a rarity. And every time you give a drug to induce hypoprolactin state, whatever you study could be the drug impact or the impact on other hormones in the body. I came down, I got her all records and went to my home, which was across the road. You know, I was living in all along, from my residency to my senior citizenship age, I was living within the campus. I told them I'm taking off, I get all the records. And I went home along with my wife and called this patient again, and called her mother also. Mother said, I have given birth to 6 children and I have never lactated. So she was very hesitant to get admitted, but we had to coax her to get investigated, and we documented that she also has all the hormones normal. The mother had a postmenopausal state, LHFSH was high. First time documented a genetic transmission of isolated prolactin deficiency. And I still remember there was one Professor Dandy who had reviewed it, and he wrote a note to me that it is not a case report, it is a study on what is the role of prolactin in the body. So a lot of things happen there. And this is quoted in de Groot, this particular genetic transmission of prolactin deficiency. Then, in the same process, we're looking at patients with alactogenesis. Prolactin terribly high, all others. This is the first report of prolactin resistance in mankind. We reported in the same. But what amazed me was that longer the duration from the last pregnancy, more the dysfunction, more hormones were involved and severer was the dysfunction. So like normally we believe if you have a stroke-like sickness, either you recover or you die. But this, in all those people who would survive, people who would have a terrible postpartum hemorrhage, they would succumb to hemorrhage. Some people will get a renal failure, some people will get a hypovolemic shock and would not make it. But it was that group of patients who would make it. But why this hormone deficiency was slow? And there came some study, Goswami did this study, that is there a possibility of an autoimmunity in this situation? Then what we believed was, when there is an insult to pituitary cells, with that insult, all cells do not get destroyed. Let us say 10% of the thyrotropes get destroyed, but the patient is euthyroid. But in the process of destruction of these corticotropes, thyrotropes, gonadotropes, the untrapped antigens within this are released into the circulation, which normally are not exposed to the immune system. So we postulated that probably they are giving a progressive autoimmune dysfunction. And depending on the severity of that autoimmune stimulation would be a progressive damage if the patient managed to survive. In a similar, we documented pregnancy in Shyam syndrome. One day, I was sitting in the OPD and one of my residents who recently retired as a dean and professor from SKIMS, yes sir, Shyam patient hai, iska abdominal swelling. And in the 300 patients, I put my hand there, I said, look, it's a huge abdominal cyst. अब वो श्यान वाले को बताना है कि अब घर जाके दोबारा, मैंने कहा यार एडमिट करा लो, we'll get it operated. Next day I went to the ward and I still remember, it was in my ward and bed 23. The same guy said, मैंने कहा what did it turn out to be? He said, no, we will not tell you, you need to examine her. मैंने कहा क्या हद होगी यार? कि नहीं सर आप examine, so full-fledged pregnancy. मैंने कहा oh my God, why are we wrong all along? And I stopped. I said, who made a diagnosis of Shyam syndrome? They said, you. So who made it? I said, you. You can see your own handwriting even on the OPD card. I asked one of my consultants. I said, you get her card, get her all, and go to the lab. She had been admitted to SKIMS twice with Addisonian crisis because she had stopped the medication. And we had already twice confirmed her pan-hypopit state. We twice confirmed. So there was so I said, there's some revival there, somewhere, which is occurring. And then, because now our eye was on it, we kept on seeing this variability. It's another case that we saw. Now, initially, apart from whatever hormonal aberrations we had described, anemia used to be very common in them. And every time they would say, the way we, Swan just now said, we give vitamin D. iron, folic acid, B12 दे दो, which we otherwise also from our younger days, because it was a huge problem right from when we did our medical studies. So hardly ever a hemoglobin A1C of 9, 10 would ever be there. They pulled on. One day, you know, one of our residents who had left endocrinology referred case from hematology. And the referral was for, is a myelodysplastic syndrome, biopsy proved myelodysplastic syndrome. He said, iska Shyam syndrome bhi hai. So, as passionate as I had been with my own staff, admit kar lo yaar, dekh lenge hai. We diagnosed her as Shyam syndrome and treated her. Then we asked them, all the female patients that you have on your follow-up, myelodysplastic, biopsy proved, not this, ask their obstetric history, 6 cases. We investigated them, confirmed Shyam syndrome, treated them. Everybody is myelodysplastic, so-called quote-unquote myelodysplastic syndrome reversed. This is when we published in Annals of Hematology. This fellow, Shahnaz, Bashir Ahmad Lawe retired as the dean of that institution. Javed retired as the chief of hematology. Shahnawaz was this middle young man's teacher in Srinagar. And a couple of them retired as professors of internal medicine. And then you know what we did? We said, now we get patients who have Shyam syndrome. We randomize them. One we treat, one we treat. मैंने कहा यार अब ये इथिकल मामला इतना खतरनाक नहीं था जितना आजकल है. या जहाँ से 5 साल से ट्रीटमेंट नहीं हुआ 3 महीने से क्या फर्क पड़ेगा? So we evaluated them doing the bone marrow also. One group we gave steroids and thyroxine, other group we did not give. And then looked at their bone marrow, beginning at the end. Then came in the journal Pituitary. All those people who got diagnosed and treated, their bone marrow anomaly corrected. Now normally, you know, this is the sequence that was supposed to be followed by Shyam syndrome. You know, when you look at pituitary dysfunction. And diabetes insipidus was supposed to be extremely rare. Because it was fundamentally, most of the damage would occur in the anterior pituitary, because it was anterior pituitary which was undergoing hypertrophy during the pregnancy, not the posterior. And this is a case where we, you know, documented that not only was the anterior pituitary destroyed, the posterior pituitary was also destroyed. And this particular figure you can see in textbooks William also, because no one else will take the, neither will see the cases, nor will take the pains to do all those things there. Then we saw many things, you know, Shyam syndrome happening. And I was one day wondering, you know, I was reading a paper in Acta Endocrinologica. It's a paper from Western world. They said, first time they read our paper, they studied many of the women of the Indian subcontinent. They had reported 3 cases of Shyam syndrome in them, who had been visiting for a chronic ill health to their Western hospitals. Growth hormone is not all that redundant as we get adult. And there was an attempt many times that if people who survive, if they get growth hormone, it will improve the quality of life and improve their metabolic health and improve their cardiovascular health. I still remember the first time the growth hormone came to this country, Genotropin from a company known as Kabi Vetri. They wanted to do a growth hormone trial on Shyam. They said, we will give them a growth hormone for 1 year. Then for 3 years, they had to take on their own money. मैंने कहा यार जिन पेशेंट्स का Shyam syndrome हुआ होगा वो हस्पताल था कि वो growth hormone क्या देंगे हमें? I'm like, you know, it's a non-starter. But some of our boys did look at it and found out, yes, cholesterol is on the higher side, LDL is on the higher side, triglycerides are on the higher side, and even blood sugars are on the higher side. When you compare patients with Shyam syndrome with comparable age group, non-Shyams. This paper we published recently, again in the pituitary, where we showed that prevalence of calcium deposits in Shyam syndrome in the coronaries, again telling us that they have a predilection for cornea. Now people live longer because now they are under scanner, at least those who visit our institution. In most of the patients who came to us were referred by the students who did their MD with us. So, literally 100%. You see, like this hematologist was in endocrinology posting, and some people, a smarter kid in the hematology posting, making that decision that do they have a Shyam syndrome. And this again, you know, this medical college, one of our students who is now a senior consultant, who has taught my chairperson also recently, in the last few years, and he did and continues to follow it, and again, talking about the coronary artery disease in them. Huge amount of data available on inflammatory markers. Highly sensitive C-reactive protein, and so it doesn't seem to be as simple as Shyam thought. And there seems to be more to it. Many times I thought, is there a possibility that this is autoimmune hypophysitis? But the numbers go against it. We are not the only people who get pregnant. It happens globally. Maybe we get a little bit more, but so autoimmune hypophysitis epidemiologically would be lesser. But there is something more to it, and I believe it's a secondary. Huge amount of data, again, coronary artery disease in them, and credible data shown that many people admitted in the psychiatric hospitals, depression, psychosis. The same residents diagnosed Shyam syndrome, referred to us, we made a diagnosis, treated them, 80% were off their drugs. Again, many papers have come. And this, you know, Satynath, this is a national paper that was published a couple of months back, looking at BMD, the multi-center study, data from SCIMS also, looking at bone mineral density again in people who have Shyam syndrome. But I don't think it's a huge brain starter. Someone, getting a Shyam syndrome or pituitary function knocked out, whether you call it today Shyam syndrome or not is doubtful in view of the data that it was a secondary autoimmune dysfunction of the pituitary. So somebody, getting a menopause at 55 and somebody getting generally a premature dysfunction of the hypothalamo-pituitary ovarian axis at the age of 25. Bone mineral density is bound to be on the lower side because these are the guys who come from relatively low socioeconomic, where the facility for a good delivery is not available. So nutritional status also otherwise happens to be low. And if we document significant, you can see it, lumbar and hip osteoporosis in comparison to them. Pretty huge. So all those people who manage to survive will live with the periods of hypercortisol state and hypocortisol state as you keep on tuning it, will keep on living with a hyperthyroid state and hypothyroid state because most of the clinicians will still be looking at TSH. And TSH would be no guide to tell us how hypothyroid is doing. You need to look at free T4 and keep it in midline. There will be situations where we have seen people in an acute stage coming with a pituitary expansion and a pituitary apoplexy, but more often than not, we have picked up people with a secondary hypothyroidism, bizarre clinical presentation, secondary amenorrheas, postpartum dysfunction, vague history of lactational failure, behavioral disturbances. Many people who were, in the recent times even picked up with osteoporosis, severe osteoporosis at the age of 40, 38, 36. Then you realize that we have seen the youngest Shyam syndrome at the age of 18 published. So, if you look at this whole picture today, clinical presentation of so-called Shyam syndrome can be very bizarre, and we need to have a very high index of suspicion to diagnose it. This disorder is not rare in the Indian subcontinent. Whatever progress we might think we have made, this is not the state in Kashmir alone. I'm saying there is no reason to believe why it shouldn't be equally good or bad in Bihar, Haryana, Madhya Pradesh, UP. Probably, might be better in the southern states a bit. Even if today it might be better, but many of those people who have been living with it for the last decades when situation wasn't better. So we need to be very focused on making a diagnosis and making a timely diagnosis. Last month one lady came, 52 years, and she had a son along with her, 35 years. मैंने कहा बेटा कहाँ से? मैंने कहा आपने अपनी माँ को मारा ही था, हा? अगर हम न होते, डायग्नोज किए होते तो आपकी माँ भी न होती. So you know, making these diagnoses can be quite gratifying, and I still believe there has to be a huge cohort of these patients somewhere down the line in South Asia in general and in our country as well. Thank you so much. I don't see obstetric care becoming so dramatically good. I see so many. I was telling somebody, you know, outside those Jombadis in All Institute of Medical Sciences in New Delhi, you know, I was a member of the governing body for a decade. How many of them who are living outside will have an access for delivery within the All Institute of Medical Sciences? None. None. Just few feet away. So that situation will continue to be there, and we need to give a benefit of doubt to as many people as possible. Thank you so much.
Excellent presentation, as usual, Dr. Nargar. Now the house is open for any query or question or comment.
Zargar Saab.
Absolutely. Massive bleeding. Yes, sir.
So you have been following these cases since the 1990s. So,
it is.
Yeah, so prevalence I understand, but is the incidence going down? Notwithstanding the difficult terrain of the valley, I think obstetric care must have improved significantly over the years.
I'll tell you, Asha scheme in this country came in after my persuasion with this data to the health ministry. And we were one of the first beneficiaries of that scheme in J&K, because I kept on talking about in every forum. Every time, you know, people would ask me to talk about anything. I said, I'll talk about women's health. And so I did. I personally believe, at least in Jammu and Kashmir, obstetric health has remarkably improved. Remarkably improved. One reason for that, not that government did some wonders, which government did, you know, cannot be said, Sasha. But we never stopped training people in our own institution, in spite of whatever happened. And those people became physicians, surgeons, super specialists throughout state first. And they became aware of what are the issues, because we had made them aware of these issues. So they kept on locally preaching those issues. As I was telling you, even today, most of the cases that even I see go for a second consultation to Dr. Zargar, one of our own students. So many of them are now good enough now to make a proper diagnosis on their own. Jammu and Kashmir is a very high dense physician and endocrinology area. Huh? See, I think in Srinagar for 8 lakh people we have 20 endocrinologists. I don't think even New York can boast of that. I personally believe, yes, cases are going down. And at least in Kashmir, because I cannot wish safe elsewhere. But episodic case is always there. I still keep on seeing them. But I can tell you, Satyanath, I become so delighted when I see someone whom I made a diagnosis 3-4 decades back, and the son or daughter is around who is already married. I tell to myself, life has been worth living, old man. Probably if she had conked down, this kid would have been a motherless one. So life would have been different.
Thank you, sir. Thank you very much.
Thank
now
you.
Close
Pleasure.
the session.
Pleasure.
I would request the speaker and the chairpersons to proceed for the felicitation. Now coming on to the next session, the chairpersons for this session are Dr. Ajay Kumar, Dr. Saibal Guha sir, and Dr. Shyam Kishore sir. I would request them to come to the stage.
A very good evening, ladies and gentlemen. It's our privilege to have Dr. Kalyan from Kolkata here. Kalyan is a leading endocrinologist and a very incisive mind in analyzing data pertaining to all in the entire field of endocrinology, particularly diabetes. We have heard him, we have read his articles, and he is here to tell us a lot about diabesity, how to approach diabesity. And we all know that we have now blockbuster drugs to address this problem beyond the lifestyle modifications. But without wasting any time, let me request Dr. Kalyan Gangopadhyay to start his deliberations. Thank you.
Thank you, Ajay Kumar ji. So good evening, everybody. So if I put the first slide. So this is a Novo-sponsored symposium on semaglutide. बोल बोल के थक गया, आप लोग सुन सुन के भी थक गए होंगे. So I thought, कुछ नया तो देना है. So some of the important clinical decisions which we have to make in day-to-day practice, some of the myths, and I will put you some new data which has come up with semaglutide. So कुछ ना कुछ तो नया होना चाहिए इसमें. So I have learned a bit after reading through it. So Novo का 2 ही slide है, पहला वाला, उसके बाद बाकी मेरा है. So anything you want to contradict, please feel free to do it. So I'm not going to talk just about what is semaglutide and all that CBOT, जैसे बताया था, बोल बोल के थक गए हैं. Now when the first the GLP-1 receptor agonist came in, our tendency is patient overweight है क्या, obese है क्या, तो देंगे. We forget the point that it is primarily an anti-hyperglycemic drug. So if I give you an example, this is a patient, I'm just giving you a hypothetical case. My patient was similar to this. I don't remember the exact numbers, but BMI was around 26. Didn't look overweight or obese at first glance. HbA1c 9 on multiple OHA. तो ये सवाल है, तो ओवरवेट नहीं है, मल्टीपल ड्रग्स में है, कंट्रोल नहीं है. हम लोग का नेक्स्ट है कि इसमें तो GLP-1 नहीं चलेगा बिकॉज द पर्सन इज नॉट ओवरवेट. इसमें इंसुलिन ही देना है. ऑफ कोर्स if the patient is in a catabolic state, losing weight rapidly, that means he is insulin deficient, insulin ही देना है. But short of that, if that is not the case, then the guidelines clearly state now GLP-1 should be ahead, before giving insulin. So अब, when I gave it to such patients, so I noticed कि HbA1c drop was good, very good, marked HbA1c drop. Glycemic control बहुत अच्छा control हो गया, इतना कि मुझे सल्फोनीरिया डोज को हाफ करके 1/3 डोज में लाना पड़ा, ग्लिमेपिराइड 1 मिलीग्राम में लाना पड़ा. So I wanted to see, is there any data for such patients? So अगर इसका BMI 35 से ज़्यादा रहता, तो वही उतना ही HbA1c ड्रॉप करता जितना 25 BMI में है. So is there data? So now this is all the pioneer studies with the oral semaglutide. This is change in baseline, change in HbA1c based on baseline HbA1c. तो ये देखिए यहाँ पर है less than 8, ये 8 to 9, और ये more than 9. So all throughout it is the dark ones are semaglutide. So you can see here clearly HbA1c ज़्यादा है तो A1c drop ज़्यादा रहेगा. That is almost consistent across the trials. So that is there. But my question was not that. My question was that कि BMI ज़्यादा है नहीं है तो क्या काम करेगा HbA1c drop करने में? So this is the data. Now if you see the BMI less than 25, 25 to 30, 30 to 35, more than 35, all over here. You can see here, उसमें कोई फर्क नहीं है. In fact, in those patients who were just on diet and exercise, not on anything, there the HbA1c drop was the most in those group of patients where the HbA1c, where the BMI was less than 25. So we should not forget that these agents are very effective and efficacious HbA1c lowering agents, regardless of their BMI, and that should be given ahead of insulin unless there is a catabolic state. The body weight drop again, Higher the body weight, there will be more weight loss. Higher the HbA1c, more HbA1c drop, but weight doesn't matter. Less than 25 will be as efficacious as it is more than 25 HbA1c drop wise. So if you look at these, combination of Sustain 6 and Pioneer 6, the CVOT, again, less than 25, 25 to 30, more than 30. The CVOT data, this MACE, all-cause, everything, it is not significant. So again, weight does not matter when you're giving this for HbA1c control, for CVOT reduction. This is the SOUL trial. Again, if you look at the BMI, less than 30 is here, more than 30 is here, almost mirroring each other. So that is an important issue because these patients tend to be missed out. We do not consider the GLP-1 receptor agonist just because they are not overweight or high risk है उनको CV होने का, CVOT, cardiovascular disease होने का. Now, the other case, suppose this patient is not diabetic, so has got a stent, BMI only 27.5, और दूसरा मैं थोड़ा सा और देता हूँ कि semaglutide शुरू तो किया, लेकिन weight loss नहीं हुआ. There are a group of patients who don't lose weight with semaglutide, albeit the number is low, but it is there. So weight loss, एक तो BMI ज़्यादा नहीं है, और एक दूसरा patient का weight loss हुआ नहीं. Will these two patients benefit from semaglutide? Patients non-diabetic with ischemic heart disease. So this is data from the SELECT trial, and if you look at the analysis of the 3-point MACE, again, less than 30 BMI, 30 to 35, 35 to 40, more than 40. Again, p-value for interaction is 0.45. It doesn't matter. So we should not be denying these patients the power of the GLP-1 receptor agonists. And the second question was, weight loss nahi hua, to fir fayda hoga? So this here, you can see here, more than 5% weight loss, no weight loss, to less than 5%, and weight gain. And if you see the incidence rate, it is same if the weight loss is more than 5% or there is no weight loss. If there is weight gain, then it goes up. But if there is no weight loss, then also they will benefit from the CV outcome. So that's what they said is the cardioprotective effects were independent of baseline adiposity and weight loss. Had a small association with waist circumference, but not with weight loss. Weight loss nahi bhi hua, to bhi benefit hoga. How about the liver? From the ESSENCE trial, this is the data. So patients losing less than 5% of body weight, there also the steatohepatitis will be resolved as compared to placebo. Improvement in liver fibrosis, more important I feel. Again, if there is less than 5% weight loss, again there is more than placebo. So some speculate that it is the loss of weight that leads to improvement. However, potential effect of the agent itself, not driven slowly by weight reduction, improves the features of MSLD. Now, this I came across because some of the patients, I tend to ask, आपको लेने के बाद कुछ फायदा हुआ तो किसमें हुआ? Variety of responses. It will take a whole day for me to go through it. So some patients told me, खाने के बाद बहुत नींद आता है. हाँ तो मुझे भी आता है. बोले नहीं, I feel very sleepy and tired. सोना ही पड़ेगा 1 घंटा. Some patients, and particularly I noticed that elderly patients after food feel very drowsy, very sleepy, very tired. और आपका ये ड्रग से एक फायदा मुझे हुआ है, वजन भले ही 2 किलो ही कम हुआ है, लेकिन मेरे को वो नहीं हो रहा है. खाने के बाद मुझे टायर्डनेस नहीं लग रहा है. So one thing is they might be having obstructive sleep apnea, that might improve, but there is another thing. Now this I came across while trying to look through literature. One of the reasons is the postprandial drop in blood pressure. So when we eat, circulation पेट में आ गया, so your blood pressure drops, body fights it, and it keeps the blood pressure up. So for a healthy, normal, healthy person, your blood pressure will stay up, even after food. Although there is a tendency for it to come down. But as you age, particularly in diabetic patients, this compensatory mechanism might be affected, and they can drop their blood pressure, postprandial drop. That can be one of the reasons for the tiredness you feel after having food. अच्छा, तो फिर GLP-1 का कुछ data है to counteract that? So what is the prevalence? So this is a systematic review. This is a relatively new thing. Systematic review and meta-analysis, you can see the prevalence varies from 9% to 60% in particularly in elderly patients. And so much so that there was a meta-analysis of CV outcomes, although the number of studies were not great, and it showed that if you have a postprandial drop of blood pressure, you have got more all-cause mortality and CV events. Because your blood is, your heart is not getting the blood, it's being stolen away from the heart. So this is the data with an intravenous GLP-1 receptor agonist. Now you can see here, these two are healthy people and these two are patients with diabetes. This is systolic blood pressure, diastolic blood pressure. After a 75 grams glucose drink, the systolic blood pressure drops, the IV GLP-1 doesn't make an impact. But for diastolic blood pressure, it does make an impact. For diabetic patients, however, see the drop is here. It drop in systolic and diastolic, both are here. But if you take the GLP-1 receptor agonist, there is no drop now of the blood pressure, both the systolic and the diastolic. There was a study with subcut lixisenatide, again, which suggested that this is the dark one is lixisenatide. There is no drop of blood pressure. So here, with the placebo, there is a drop. Placebo, there is a drop, both in normal people as well as patients with diabetes. So maybe, I'm just hypothesizing here, maybe this is one of the effects why some of my patients, when they said, I don't feel tired and sleepy anymore after having food. Now, the other thing is, this patient, आपने तो 26 BMI में दे दिया, उसका बेचारे का मसल नहीं है और आपने तो मसल भी खा लिया, तो फिर, so thus will semaglutide lead to loss of muscle mass and muscle function. And let me be clear, any weight loss strategy will also lead to muscle loss. Don't be fooled by any company person telling you, नहीं साहब, हमारा GLP-1 में या GLP-1 GIP में muscle loss नहीं होता. गलत बात है, muscle loss होगा ही weight loss हुआ तो. But the important thing is my muscle function affected? So I will tell you in a little bit. My interest in muscle has been aroused by Professor Sotinadda. So he first showed us the intramuscular fat and its problems, and I will just highlight that. Muscles are very important. Why? Not just for activity. They handle about 50% of the oral glucose intake. And after your food, about 70 to 80% of the glucose disposal is done by muscles. So if you lose muscle, your glucose level will also go up because there is no muscle to handle it. It's important to remember. It works both ways. And it is not only the glucose handling. With loss of muscle, you can frailty, falls, lots of things occur. Now, there is something called intermuscular adipose tissue. ये बहुत important हो रहा है अभी. So if you see here, this is a younger person with BMI in normal range. उसका muscle का subsection किया है, and this is an older person with obesity. Now you can see here the fat in between the muscle. The muscle size एक ही है, लेकिन इसका fat अंदर बहुत ज़्यादा है. And is this important? The intermuscular adipose tissue, is this important? I'll tell you why it is important. See, muscle groups के अंदर जो fat है, they are very dangerous. Why? If there is lot of fat, that will cause inflammation. This inflammation will eat away the muscles. And you will never come to know of it because all these chemicals which are eating it away, they will not come into the blood for you to measure it. It will stay there itself. And so there is no way of knowing it. So the increase in fat will eat away your muscles. That is obesity, sarcopenic obesity. So if you look at, this is the subcutaneous adipose tissue, visceral adipose tissue, intermuscular adipose tissue. So if you look at all the bad things, that is all these inflammatory cytokines, chemokines, many of them are actually more in the intramuscular adipose tissue than even the visceral adipose tissue. and the volume of intramuscular adipose tissue is perhaps same or not, if not more than the visceral adipose tissue. तो उसका वॉल्यूम एक है और वो शायद ज़्यादा डेंजरस है than the visceral adipose tissue. So there is data with the GLP-1 receptor agonists which take out this intramuscular fat. So suppose the person has got fat, and after giving GLP-1, the muscle mass seems to be less. But hang on, if I take out the fat inside, it will look as if muscle छोटा हो गया, लेकिन actually fat ही निकल गया है, पूरा muscle नहीं गया है. So that is important thing to remember. So this is a data with semaglutide in rat muscle, in rat. So here, normal control, high fat diet mice, and this is high fat diet mice with semaglutide, okay, 3 arm. Now if you look at the muscles, normal control has got very little fat in the muscle, high fat diet has got a lot of fat in the muscle, but when you give semaglutide, look, the fat is much less than here. So if you feed this person, it will appear to be shrunken, but actually it is the fat which has gone up. So वो सब बोल के फायदा नहीं है, आप बोलिए muscle function ठीक कम हो रहा है कि नहीं. There is actually 1 or 2 studies which I had seen with semaglutide which also suggested there was a bit of reduction in muscle function as well. Those were retrospective observational data. Now this is the most recent, published this year, 2026, you can see the semaglutide study with 115 patients where they gave semaglutide 2.4 milligram and they checked the muscle function at 0 month, 7 months and 12 months. Muscle function is very easy to check. You give a hand dynamometer and there is something called get up and go test. चेयर में बैठने खड़े होने में कितना टाइम लगता है, 6 सेकंड चलने में कितना दूर आप चल सकते हैं, वगैरह वगैरह. There are a lot of tests, but they are very simple to do. Now if you see the fat mass in this study, it is reduced. There is reduction of fat mass at 12 months. Fat mass change is reduced, maximum at 7 months, but it continues to go down. Now if you look at the lean mass, that goes down. The lean mass also goes down. At 7 months, then it stops here, and it is same. This is the lean mass percentage, which the companies might come and tell you, देखिए हम लोग का muscle mass बढ़ रहा है. जी नहीं, lean mass percentage है. बाकी कम हो गया, इसलिए आपका percentage ज़्यादा दिख रहा है. So the percentage is increased doesn't mean your muscle mass has increased. The lean mass percentage has increased. Now the important thing is this, hand grip strength. In this study, I was very pleasantly happy, surprised and happy that the hand grip strength actually increased from 0 to here to here. So muscle mass कम होने के बावजूद the hand grip strength increase. So that gives me a lot of reassurance that I am not making the muscle people sarcopenic, because by sarcopenia by definition you need to have loss of your muscle function as well. Now this I think Sutinatha and I was discussing. मुझे बहुत दिन से इच्छा थी कि मैं जो मर्जी खाना खा लूं, लेकिन उसको अगर मैं बर्न कर दिया तो कैसा मजा आएगा. तो कुछ एक्सरसाइज करने की जरूरत नहीं. Whatever I eat, I will burn. This is the residual energy, resting energy expenditure. Unfortunately, with semaglutide, in fact, that did go down and it came up. So the residual resting energy expenditure बढ़ता नहीं है. Till now, only glucagon increases your fat burning ability. So I'm waiting for retatrutide to come. वो लूँगा और खाना भी खाऊँगा. Now, so it is very important that any weight loss therapy that you give to the patients, always teach them simple isometric exercises. किसी को जिम जाने की ज़रूरत नहीं है. Just taking extra protein, vitamin supplements, extra nutrients will not cause any increase in your muscle unless and until you do isometric exercise. And the simple isometric exercise, I will tell you, I think all of us in this room should do. I also do it. So I tell my patients, देखिए आपका 2 ग्रुप है, lower limbs, upper limbs. दोनों का isometric exercise करना है. कैसे? बोला आप बैठे हैं, खड़े होइए. Invariably the patient will stand like this. आप यहाँ पर भी देख लीजिए, जब उठेंगे चलो अब खाने का टाइम हो गया, तो चेयर के ऊपर, हैंडल के ऊपर हाथ दे के हम लोग खड़े हो जाते हैं। सो ऐसे विवेकानंद को देखें, बोले हाँ कैसे खड़े होते थे, तो वैसे कर लीजिए। और बैठे हैं तो जब भी बैठे खड़े होंगे, ऑलवेज रिमेंबर विवेकानंद एंड स्टैंड। सो सिटिंग अप like this. So I did it for a month and now I've got used to it. So I don't use the handle now. I stand up without touching anything. I keep that. So that gives you big muscle groups का isometric exercise हो गया. दूसरा, whenever you are standing in a lift anywhere, you just tiptoe. That will give you isometric exercise of your calf muscles. हो गया आपका lower limb का काम हो गया. In a day, you might be sitting up and getting up at least 25-30 times. हो गया आपका isometric exercise. Without touching anything, you will stand up and do this. For your upper limbs, take a 2-liter water bottle in your clinic in between patients. Bend and then slowly let it go down. Don't let it go down quickly. Slowly bend, down, up, down. That's it. Upper limb, lower limb का हो गया isometric exercise. So I'm running out of time. So Chairperson sir, you can stop me anytime. Just a few more slides about the renal bit, the new data which has come up. I don't think it is published yet. I don't know if you have seen the slides. I had not seen it. This is just presented in Texas nephrology conference. The one thing मुझे हमेशा से ये ताज्जुब हुआ कि GLP-1 receptor agonist, how can it improve renal function? कोई mechanism नहीं दिख रहा है. SGLT2 inhibitors का mechanism है, इसका mechanism कुछ साफ दिख नहीं रहा है. What might be the mechanisms? So multiple theories, hypotheses. Multiple hypotheses मतलब पता नहीं हमको. So this is the data. Again, this is pretty recent, 3 or 4 years ago, particularly in Asian patients, where it suggested that high BMI was not significantly associated with CKD, but it was associated with CKD only if there is increase in perinephric fat. So this is, again, oh, sorry, it has not come out. This was just a few months ago. So this was data of more than 2,500 patients, a meta-analysis. What it showed is very interesting. Patients with type 2 diabetes, with heart failure, only CKD, and overall. So you can see here, those patients who had type 2 diabetes and CKD or heart failure and CKD, everywhere the perinephric fat was more. So it seems not just the obesity, but if your perinephric fat is higher, that will give you a higher chance of developing CKD. It makes sense because the perinephric fat matlab fat hai, inflammation ho raha hai, inflammation will eat away. It is closely applied to the kidneys, inflammation is eating away the kidneys. So I wanted to see whether there is any data to reduce the perinephric fat. There is data with SGLT2 inhibitors in reducing perinephric fat, mind you. So this is the FLOW trial, which you are all aware, so I'm not going to bore you with showing it again. But this is the remodel trial, which is not yet published. It has just been presented in Texas American Nephrology Association. So you may not have seen the slides. I got it just today, few hours ago, so I could not get time to read through it. So this is a remodel trial, HbA1c of less than 9%, eGFR 30 to less than 75, and urine ACR 20 to less than 500. So albuminuria के रेंज में नहीं है, उनको भी इंक्लूड किए हैं इस ट्रायल में. Here they gave semaglutide 1 milligram and the duration of trial was 1 year. Now this is a big trial because they not only looked at functional MRI, they looked at kidney biopsies, they did multiple blood and urine analysis. I think there are about 50 papers will come out of this trial. You just mark my words, in the next 1 or 2 years. So this is the FLOW trial, which includes patients here, and the remodel trial, patients up to here. So it also includes less sick patients. And this is the comparison, oh, I'm sorry, it is not coming up nicely, comparison between FLOW and remodel. I'll just tell you, because I can see from here, the SGLT2 proportion of patients on SGLT2 inhibitors here in the FLOW trial was only 15%. Here it was 38% because this had come up after FLOW trial. Rest of all, they were similar, but the EGFR was higher in the remodel because I showed you that there were less sick patients also included. And if you look at the urine ACR reduction was almost similar. The EGFR, holding on to the EGFR, not letting the EGFR go down, was also similar. But I'm not looking at that. So this is another data which supports the flow trial. But I'm looking at the perinephric fat. So this is change in urine ACR, change in EGFR with the semaglutide. The EGFR seems to hold there. You see, hold across, this is the 0. So there was no change. With the placebo arm, there is definite decrease in the EGFR. Now, this is so they divided into two. One is the perinephric fat and the renal sinus fat. And both, there was 25% reduction in the perirenal fat and about 13% reduction in the sinus fat. So this could be one of the mechanisms by which the GLP, one of the many mechanisms by which they could work. And they looked at fibrosis markers also, and there was absolutely no change at 1 year, whereas the placebo arm, the fibrosis markers had increased. And this is data for 1 year only. So if you had gone further, maybe it would have been more. So I'm sorry I've exceeded the time. So Novo ka 2 slide to rakhna hi padega. Isliye I have kept the first and the last slide for you. So with that I end, but this we can discuss in the question answer session. Thank you very much.
Hello. So you have heard Dr. Kalyan at his bilingual best, and thanks for such an elaborate talk, and hats off to you for the novel aspect of viewing this molecule and reading between the lines, which many of us overlooked in the past, in our experiences. The topic is open to the House for any queries or comments. Sadhinath sir, yes.
In the flow trial, there was cardio-renal benefit with injectable semaglutide. In the SOUL trial,
no benefit.
No renal benefit. So assuming your hypothesis to be true, is there any data on reduction of peripelvic fat with the SOUL cohort?
Okay. So I did ask this question to I think McGuire. It's the same, exactly the same question. Why was there no benefit in the SOUL trial, but there was benefit in the flow trial? So one answer to your question, I'm not aware of any perinephric fat data from the SOUL trial. Second, in the SOUL trial, the EGFR was 74 and in the flow it was 47. So what they are saying is, probably in the SOUL trial, the patients were not sick as far as kidneys were concerned. So inflammation has not set in. In the flow trial, there were kidney sick patients, so inflammation has set in. So it seems that the GLP-1 will work when the inflammation has already set in, as opposed to when the inflammation has not set in. This SGLT2 wins over GLP-1 because SGLT2 will work even when the inflammation has not set in, because all the CVOTs, their EGFR was more than 70, the EMPA-REG, Declare-TIMI, and the CANA trials as well. But there, they did show that there was, they held on to the EGFR.
Sir, my question is, on many occasions, if we are treating obesity, GLP-1 receptor agonist has to be given for lifelong. Your first case scenario where the BMI was 26, metformin, sulfonyl urea, DPP-4 inhibitor, the choice was between insulin and a GLP-1 receptor agonist. You had a good point to favor the GLP-1 receptor agonist. On many occasions, we used to reduce the medication in our diabetic patients if he or she is having a good glycemic control. Do you consider that apart from obesity, whatever the other indications you have shown, we can give for a shorter duration of GLP-1 receptor agonist for 6 months, 1 year, for glycemic control, for tiredness, sleepiness, OSA, and if you can consider the osteoarthritis, may not be right to mention because it's mostly due to weight. So do you consider the shorter span of GLP-1 receptor agonist can be used in these patients?
Okay, I'll come to the arthritis bit later. First point is, so The data we have is for those patients who continue taking it. So I cannot tell you whether there is any data that if you stop it, what will happen after 2 years. I don't think anybody can tell you what will happen. It is likely that they might gain their weight back, they may gain all of those back. But one thing which I can tell my patients, because some patients tell me, बहुत खर्चा हो रहा है, 1 साल बाद तो बंद करना ही पड़ेगा, तो कुछ तो बोलिए. And I can only say that it might prolong your life by 1 year at least, because that duration of your body inflammation is reduced, that might have some sort of a legacy effect. But this is all hypothesis generating questions. The answer is, I do not know. As far as arthritis is concerned, I initially thought that the improvement in arthritis is only due to the weight loss, but that is not the case, because there are GLP-1 receptor agonist receptors in the knee joint, in the synovium. So it acts by not only causing weight loss, but also in reducing the inflammation in the synovium. So that is one of the mechanisms also by which it reduces the knee pain, knee joint pain. So you will get the pain benefit even before you lose a significant amount of weight.
Any other question from the audience? Yeah, please. Dr. S.K. Singh.
Thank you. Dr. Kalyan, excellent presentation. So 2 concerns. One is that weight loss is always accompanied by sarcopenia that you have said, because there is a reduced intake of protein, and also when you have too much of weight, you do more effort to lift your body, and that also contributes to good muscle mass. So in absence of these 2, that is, you're losing weight and also taking less of protein, because many of these patients will have loss of appetite. So protein loss and these 2 will always be accompanied by sarcopenia. And most of the studies have already proved that sarcopenia will be there. And to overcome, you have to increase the protein intake, you have to do more isometric exercise, as you said. That will perhaps take care of, but no data is there to support that it will be regained. That's number 1. Second concern, that you said that adipose tissue will have more cytokines, inflammatory substances released, and will be eating up the muscle. Why they don't eat the adipose tissue itself from where they are being produced? So if that conjecture is holding true, I think that is not very easy to understand.
Okay, so if the snake has got venom, why doesn't it die? Snake has got venom, why doesn't it die?
Very right, so, very simplified.
So,
but that doesn't happen.
Inside the fat, inside the adipocytes, the fat is unlikely to cause the damage, because they are accustomed to high levels of fatty acids. Outside the fat cells, they are not accustomed to the fatty acids, to the chemokines, cytokines. That is why they will kill others but not kill. So the snake will kill you but will not die. As far as your question about protein is concerned, it is, I'll repeat again, the isometric exercise is much more important than the protein intake. Just protein intake will not increase your muscle mass unless and until you do the isometric exercise. Third point, that with the incretin-based therapies, there is reduction in mainly of fatty food and more of carbohydrate-based food, rather than just an aversion towards protein. So I would not say that they are protein deficient mainly because of this. It is mainly because of weight loss. So bariatric surgery patients, they also have got sarcopenia. Any weight loss drug will cause some degree of sarcopenia. And you have said that when you are overweight, you take more effort in getting up. But the first place, you are overweight because you are not exercising also. So when you lose weight, it is likely that you will do more exercise. That the knee joint pain will go, you will likely that you will be walking more. So you will be doing more exercise. So I will turn it around and say the other way around. But so I will not say that you increase your protein intake, whatever you are eating, but must do isometric simple exercises day in, day out. Otherwise, if you tell the person to go to the gym, 2 महीना जाएगा, उसके बाद नहीं जाएगा.
So, what is your advice to young individuals of my age group who are thinking of taking semaglutide and have no other comorbidities like any other like diabetes or hypertension except family history of hypertension or diabetes. So what is your advice to them? Should they take this medication or should they stick to regular dietary lifestyle modification?
Sure. So first thing to realize that lifestyle change is the basic thing. So diet, exercise, healthy lifestyle, that is a platform. That's the basic thing. Whatever we are doing is on top of that. Second, for you, whether you should be on semaglutide, be guided by the indication. If your BMI is less than 27, you are not diabetic, then there is no indication to have it. If you are overweight.
Regarding weight loss, sir? Central obesity and weight loss.
Okay, so there is no approved indication as yet that if you have got a BMI of less than 27, but you have got central obesity, therefore that is an indication. That is not there. It should be, I feel, but that is not there. So we are guided by BMI only. So if your BMI is less than 27, you should not be taking it if you don't have diabetes.
Thank you, sir.
Thank you, ladies and gentlemen. This was an absolutely fascinating talk and discussion. We must thank Dr. Kalyan Gangopadhyay for his excellent presentation and the audience for the wonderful interaction. Thank you very much.
I would request the speaker and the chairpersons to proceed towards the felicitation area. By this we come to end of this evening. Tomorrow we will be starting the session at 10 a.m. and I kindly request everyone to be on time. Thank you and good night.
I think it was a great academic day for all of us. It was so mesmerizing, and after this day, cultural program will follow soon for refreshing our mind. I think in 10 minutes. Please have your snacks by that time, and we will join the cultural program in 10 to 15 minutes. Thank you.